Everyone kindly settle down. We'll start now. तिलावत है? Bismillahirrahmanirrahim. Distinguished guests, respected seniors, esteemed colleagues, and dear delegates, Assalamu alaikum and a very good morning. We'll start the program with a recitation of Holy Quran.
Bismillahirrahmanirrahim. Qul huwa Allahu ahad, Allahus samad. لم يلد ولم يولد ولم يكن له كفوا أحد.
It is an honor to welcome you to Day 3 of PSN 2026 for what promises to be a day of thoughtful academic exchange, critical reflection, and future-oriented nephrology. My name is Dr. Talia Tahir, and I will be serving as the Master of Ceremony today. Scientific progress is built on curiosity, questioning, and original inquiry. Free paper sessions represent the academic pulse of a conference where emerging data meets critical appraisal. Research is not complete until it is shared, questioned, and refined. This session will be chaired by Professor Tofal Mohammed, and co-chaired responsibilities are shared by Professor Sultan Zafar, Professor Saeed Ahmed, Professor Muhammad Abid, Professor Salman Tahir Shafi, and Professor Kiran Nasser. I wish all the presenters the very best of luck. I'll request the chairs and co-chairs to kindly grace the stage. We now proceed with the free paper presentation. May I now invite our first paper presenter, Dr. Babar Rafiq from Pakistan Emirates Military Hospital, who will present on the topic, Genetic and Clinical Analysis of Chronic Kidney Disease in Pakistani Population.
नहीं बस मैं आप अपने यहाँ से चलाना
यकूब मगदी साहब अब आवाज़ आ रही है मेरी अल्लाह करे इन्होंने जो कोशिश की है रात कि हमारे ज़मीर वाकई जाग जाएं मैं उर्दू इसलिए इस्तेमाल कर रहा हूँ कि यहाँ कोई फॉर्मर नहीं है मुश्किल नहीं हाँ तो आइडियल सलूशन तो मुझे पता है कि कभी भी नहीं मिलता लेकिन अगर सोच समझ कर कोशिश की जाए तो अल्लाह ताला के और सिंसेरिटी भी हो कमिटमेंट हो तो ये क्रिएटर का वादा है कि वो हमारी कोशिश को ज़ाया नहीं करेंगे इसके बारे में ज़रूर सोचें और दूसरा ये अभी मैं बिस्मिल्लाहिर्रहमानिर्रहीम का तर्जमा वो किया है आपसे भी रिक्वेस्ट है मेरी ये सारी दुनिया में यही तर्जमा हो रहा है लेकिन बेटा ये तर्जमा सही नहीं है आप कहेंगे कि इसके क्या रेलेवेंस है लेकिन नहीं इसकी है हमें पता होना चाहिए इट्स नॉट इन द नेम ऑफ अल्लाह इट इज़ विद द नेम ऑफ अल्लाह इनका तर्जमा फ़ी होता है अरबी में हम अल्लाह के नाम से शुरू करते उर्दू में यही तर्जमा होता है ना वी स्टार्ट विद द नेम ऑफ अल्लाह जब तर्जमा करते तो हम इन आ जाता है इसके सोचें इसको करेक्ट करने की कोशिश करें लो बेटे बिस्मिल्लाह
सर मैं आई स्टार्ट Bismillahirrahmanirrahim. I am Dr. Babar Rafiq. I'll be presenting on behalf of my research team led by Dr. Suhail, who's my mentor and supervisor. The research work on the topic of my presentation is the genetic and clinical analysis of chronic kidney disease in Pakistani population. Research work on the topic of genetic and clinical characteristics of CKD has highly prevalent in and under-recognized in Pakistani population. This study focuses on importance of genetic testing in improving diagnosis and patient management. The sequence of my presentation is as flashed. Chronic kidney disease is a major global burden disproportionately affecting low and middle income countries. Inherited kidney disorders along with high consanguinity and metabolic risk factors drive early onset CKD, highlighting the need for early genetic diagnosis enabled by next generation sequencing in Pakistan. Chronic kidney disease has heterogeneous etiological spectrum. This Venn diagram highlights the underlying factors including diabetes, hypertension, obesity, and age. Genetic risk involves genes like MYH9, APOL1, while individual choices such as diet, exercise, smoking, and substance use also contribute. Their interplay determines the development and progression of kidney disease from early CKD to end-stage renal disease. The objective of our study were to clinically characterize families with CKD, identify pathogenic variants, explore genotype-phenotype correlation, and provide genetic counseling to predisposed families. 20 families were enrolled from various regions of Pakistan, including both syndromic and non-syndromic CKD cases. Each participant underwent detailed evaluation and to document the disease spectrum, followed by whole exome sequencing. Identified variants were further evaluated through filtering, segregation analysis, SLECO pathogenicity prediction to pinpoint likely disease outcome and mutations. Now coming over to the results. This pedigree shows a 35-year-old proband, which is known as, we've named them as a nephro family 1. He was a soldier by profession, presented with end-stage renal disease due to nephrolithiasis and bilateral nephrocalcinosis on CT-KUB. 3 of 4 brothers were affected while sisters were spared, suggesting an autosomal recessive renal tuburopathy consistent with Claudin-16 related disease. This slide compares 2 affected members of nephro family 1, both with nephrocalcinosis, hypomagnesemia. One had the end-stage renal disease while the other had impaired renal function. This was consistent with familial hypomagnesemic hypercalciuric nephrocalcinosis. Claudin-16 disrupts paracellular magnesium and calcium handling, leading to hypomagnesemia, hypercalciuria, and nephrocalcinosis, which lead to progressive CKD. This genome browser snapshot confirms pathogenic missense variant in Claudin-16 gene on chromosome 3. The highlighted cytosine represents the wild-type nucleotide, and variant involves guanine to cytosine single nucleotide substitution. The second case was, we named him the family as Nephro 3. This involves 48 years of age male proband presented with nephrotic range proteinuria along with grade 2 renal parenchymal disease. He had no dysuria or hematuria and had a negative autoimmune profile. Kidney biopsy was consistent with end-stage glomerular pathology. Family history showed that 3 out of 5 siblings were affected with either CKD or microscopic hematuria. Genetic analysis identified dual homozygous variant in MYO1E and FAM133A, supporting a hereditary glomerular disorder underlying family's CKD. A novel MYO1E variant was identified, which plays a critical role in podocyte cytoskeletal integrity and glomerular filtration. These are the lab parameters of nephro family 3. 2 of them had nephrotic range proteinuria with normal serum creatinine, while third member had impaired serum creatinine with advanced nephrocalcinosis on CT-KUB. MYO1E and FAM133A were suspected pathogenic variants. MYO1E dysfunction correlates with proteinuria and glomerulosclerosis, while FAM133A is suspected to have impairment with the intracellular trafficking, which further drives the podocyte injury and renal impairment. This slide shows missense variant identified in the Mayo gene using Vertex software. The variant is located on chromosome 15 and results in lysine replacing glutamic acid, confirming its non-conservative substitution. This slide shows the annotation and genomic localization on X chromosome, where adenine is replaced by guanine. Our next family we named the family as Nephro4. The proband case was 18 years of age, female, eldest among 6 siblings, presented with reduced visual acuity at 11 years of age, along with anterior lenticonus on ophthalmologic examination, and she had subnephrotic range proteinuria. That was suggestive of collagen A4 mutation leading to Alport syndrome. This slide shows visualization of pathogenic collagen A4 variant identified on chromosome 2. The variant causes frame shift mutation, which leads to loss of function in alpha 4 chain of type 4 collagen. This slide shows another pathogenic variant in the same pedigree, in which missense variant resulting in glycine replacing valine was found in the patient. This slide represents the key genetic finding of our study, identifying 4 novel biallelic pathogenic variant in genes essential for renal structure and function, each associated with distinct hereditary nephropathy, including tubular, glomerular, and Alport spectrum disorders. The take-home message is that whole exome sequencing is a powerful tool for diagnosing hereditary CKD. Early genetic diagnosis enables precision management, and genomic medicine should be integrated into routine nephrology practice in Pakistan. I thank you all for your patient listening.
होता है कि जी सारे प्रेजेंटेशन हो जाए तो सबसे आखिर में सवाल पूछें, मेरे ख्याल में साथ साथ ही ना, जस्ट टू क्रिएट इंटरेस्ट। जी तो मगदी साहब।
Hello, hello, hello.
जी आप बेहतर।
Can you hear me now?
जी जी।
Yeah. Thank you. Today I feel I've come to a 21st century country. It's a first step in the right direction.
Thank you, sir.
Congratulations to Zahid Beg. Where is Zahid? Congratulations. So I think it is, just want to make a point that when you said whole genome sequencing, I think you can get it less expensive, as was the thing, by targeted, because remember there are so many genes which have been now identified in different areas. If you've got a person with tubular disorder, we in UK order a tubulopathy genome. So they'll just go and get 99% of the pathogenic sequences which have been identified. As in UK, most of the people who have these disorders also come from Pakistan. So some of the cases which you mentioned, I have got those patients in my clinical practice because they come from consanguinity, usually from either Bangladesh or Pakistan. And in order to save cost and available for the rest of the country, there are now targeted gene chips available. So you don't have to go through the whole malarkey of next sequencing genomics.
Sir.
You can have a targeted glomerular, you can have targeted nephrotic syndrome. So like in nephrotic syndrome, with podocytopathy, they have already got 26 genes which will capture 99% of the pathology. If that doesn't show, then you go to the next genome sequence. And I'm guaranteeing in a country with such a big consanguinity, you'll be able to get all your patients in a fraction of the cost. So that is my request, that yes, you've taken a very good step, but now we want to make this available for the rest of the country. And also by doing this work, you can then your next mission should be to go out in the country and try to avoid consanguinity. People say in Islam it is okay. If you were to look at Islam, it's the last resort. It's not the first protocol which is happening in this country. If there is no person available, and then you should not have a generational consanguinity, which is where the problem lies. That you just have... So please, by doing this, you are starting a very big mission. And you can have this as a slogan for the country and wake the country up and change this so-called cultural practice which has been hidden behind Islam. So disentangle that and just do something useful. And I'm so grateful that you presented, even though 4 cases is the first step in the right direction.
Sir, thank you.
Assalamu alaikum. So, Saeed Ahmed, UK. So, in the UK, we have the Rare Disease Registry. Prof. Magdi just mentioned it. We have 35,000 patients on that registry across 109 sites. So, you're starting the right steps. Create a registry. As you are collecting this data, gene sequencing is, for us, is quite cheap. So going forward, it will become cheaper. So even at a small level, start a registry as you collect the data as you go around the country. That's what I suggest.
Sabir Sahab.
Sir, honestly, that's the mission we are actually taking. And this is the first step, rightly said by Dr. Magdi Yaqub. This was in collaboration with our Shaheed Zulfikar Ali Bhutto University Molecular Biology Department. And this is the first actually step. The end result where we are aiming is to develop genetic counseling lab, which we don't have in Pakistan. We don't have this, we don't have this exome sequencing, free genome sequencing in Pakistan. We had to resort to a collaboration of that university with the Macrogen Korea, and we had to send it there and develop it. There are many organizations here, government organizations who are doing these in their own setups, but it's very expensive. So this is a project which we have taken our Park Military Hospital along with the Shaheed Zulfikar Ali Bhutto University to link all these genetic labs and try to create this registry. And first thing is to provide it freely to everyone. The other thing which we had seen in our setups is a taboo as well, which we have to overcome. We had 20 families, and many of the families which we actually shortlisted, they were not ready to come in. And they did not want their genetics to be tested because they thought that it could be a taboo in their family if it's announced or if it's labeled. Instead of what we thought was that we could give them this counseling. So we had to do a lot of counseling. And in fact, the other thing which is important, which we feel that if we have to go through this project till the end, that is the awareness, which is still lacking, that we have no awareness of genetic testing, the importance. In this closed hall, of course, there are so many people who understand and know it, but what about the general population? So it has to be, this project has to be linked with the governmental system, where we could really create first this awareness side by side in providing them the free genetic testing. That's just my comment on it.
Find a single case of APOL1 in Pakistan. So it will be a waste of money. APOL1 is only found in West Africa. And the African ancestry people who came to Indian subcontinent came from East Africa. And up till now, with my collaboration, we have not found a single case of APOL1 in East Africans. So I would just advise you to focus on the low-hanging fruit. And that what I'm trying to, that it will be easy. There are 2 chips available, which is glomerular as well as tubular. And the third thing, which we have not just touched, that the commonest kidney problem in Pakistan is kidney stone disease. We don't even mention, it's not just one talk for the commonest kidney problem in Pakistan. And that also we begged the program, one of my colleagues is going to present. This is where you will find rare genetic disorders. So I would just say that focus on this and go on simple, cheap chips available, and you'll soon have a registry. Then the whole world will flock to you. They will come. If you have a registry, they will come digging for the cases, because every drug company wants to develop an expensive drug. You will become a center for that. So I would just say that forget about APOL1, you will find nothing.
Yes.
Sir, at the end, please. Thank you for your comments. May I now invite our second free paper presenter, Dr. Umair Ijaz Malik from PEMH, to present on the topic Effect of Mesenchymal Stem Cell Infusion in Stage 2 to Stage 4 Diabetic Nephropathy. Sir.
Bismillah ar-Rahman ar-Rahim. I am Dr. Umair Ijaz, and I will be presenting on behalf of my team, which was led by our supervisor, General Sohail Saab. So my topic will be the stem cell therapy and its role in chronic kidney disease caused by diabetes mellitus. So first of all, a little bit about diabetes in Pakistan. So it is overall prevalence is found to be about 21.2% as of 2022. And it is the highest in Southeast Asia amongst our neighbors. And it is highest prevalence was found in patient group which was over 50 years of age, and lowest was among patients in less than 30 years of age. There was a male predominance of about 62%, and the main causes attributed were lack of awareness, dietary and lifestyle habits, screening protocols, and access to treatment which was lacking in most of our setups. So this is a very complex slide showing the pathogenesis of diabetes mellitus. However, it is pertinent to focus here on basically this point here, which shows that ultimately there is a production of free radical injury. There are basically two pathways, the metabolic pathway and the hemodynamic pathway. And the metabolic pathway, ultimately it trickles down to the fact that there are free radical injury and oxidative products which form and which lead to inflammation and ultimately damage to the glomeruli. And again, the hemodynamic, as we know, cause also attribute or aggravate that. So the proposed mechanism of the stem cells is, stem cells are basically precursor cells which are non-differentiated, and they act by two methods. The main method is that they are anti-inflammatory, and they release certain cytokines, inhibit the release of certain cytokines that prevent the inflammatory reaction and fibrosis. And furthermore, they also are undifferentiated cells themselves, which can lead to further healing process. So these were the proposed mechanisms of stem cell repair in patients of diabetic kidney disease. These are theoretical, and they were done mainly in animal models. So it is anti-inflammatory and immunomodulatory. There is preventive, there is prevention of oxidative injury and apoptosis. It is anti-fibrotic, and there are studies that say that it can also cause paracrine cell repair. So what are the challenges in our stem cell? First of all, the sources. As you know, this has to be harvested from human source. Either it is the umbilical cord blood or the bone marrow. In Pakistan, we are not allowed umbilical cord blood as present, so we are doing it with the bone marrow. The optimal dosing, since it is a novel therapy, it is unclear as yet. There is no long-term efficacy studies which tell us as to how long the dose is effective. And there are regulatory and ethical issues as understandable. And finally, there is also the cost of treatment, which again also limits the use of this therapy. So the aim of our presentation was to compare the effect of mesenchymal stem cells versus the placebo in patients of stage 2 to stage 4 CKD. So this was the methodology. It was an interventional, prospective, randomized, and double-blind. It was conducted in PEMH Rawalpindi for almost 3.5 years. There were 78 participants. It was both male and female. The age we limited to from 18 to 75 years. And the patients who were pregnant, type 1 diabetics were excluded. And if there was any other concomitant renal disease other than hypertension, then we also ruled them out. So our primary goal was to assess the improvement in GFR, which was done by a technetium-labeled DTPA scan. And the safety of MSCs was also evaluated as to the proof of concept. And we also looked at effects of confounders like the glycemic control, ACE inhibitors, ARBs, SGLT2 inhibitors, and baseline renal function and proteinuria. Our planned intervention was 30 million units as a single infusion over 30 minutes in normal saline, and we compared it with a normal saline placebo, which was in covered bottle to ensure that it was blinding was done. And the follow-up was done monthly for 6 months with routine labs, and a DTPA scan and HbA1c were repeated at 6 months and compared with the baseline. So 91 individuals were initially registered, out of which 41 were placed in the treatment group and 50 were placed in the placebo group according to the randomization and allocation concealment. 6 participants died during the course of the study, and once it was unblinded, we found out that 2 of them were in the treatment group and 4 of them were in the placebo group. And the 7 participants were lost to follow-up due to various reasons. The intention to treat analysis was done for all 91 participants. Here we took the lowest available GFR of the cohort as those who had either died or lost to follow-up. And the pre-protocol analysis was done for the 78 participants who had completed the study and were available for screening at 6 months. So this was our data for intention of treat analysis. First of all, we checked for other parameters such as age, gender, the mean duration of diabetes at the time of study, the serum creatinine at baseline, the spot urine ACR at baseline, and the stage of CKD. And as you can see from the p-values, that none of them, as you can see from the p-value, that none of them is significant. Moving on to our main objective, which was to assess the DTPA improvement in GFR as assessed by the DTPA scan. And here you can see in intention to treat analysis as well, the DTPA scan, which showed a significant, borderline significant, but significant change in improvement of GFR, which was not shown in the placebo group. And now for the per protocol analysis for those patients who had actually completed the therapy and were available for observation at 6 months, again it shows that none of those parameters, as I mentioned earlier, were in the significant group. And here, when we compare the DTPA scans in patients with after 6 months of completion and having ruled out those patients who died or who had lost to follow-up, we see that there is a clinically there is a statistically significant improvement in DTPA in patients who were given MSC as compared to those who were given placebo group. So we also compared it with the anti-proteinuric medication, which was supposed to stop the prevention, which was supposed to prevent the progression of CKD. And again, as you can see, it was not clinically significant whether the treatment was given in either placebo or MSC group. So assessment of drug safety was also done. There was a separate independent patient safety board assessed in the same hospital, which did not compose of the primary research team. The 6 deaths that occurred, 4 in the placebo group, 3 were due to cardiac events, while 1 was due to sepsis, whereas in the 2 MSC group, 1 was due to cardiac event and the other one was due to a road traffic accident, which was not related to the study. And no deaths occurred within 1 month of the MSC or placebo infusion. Patients were also monitored 72 hours inpatient so that we could see if there was any acute adverse reactions or cytokine release syndrome.
So 1 minute remaining.
So now the result summary, there is statistically significant improvement in technetium-labeled DTPA GFR in the intervention group as compared to the placebo group. And there was statistical reduction in HbA1c in the intervention group. However, there was no statistically significant improvement with respect to age, gender, duration of diabetes, or stage of CKD at the time of study. There was no significant GFR improvement with respect to the baseline GFR or urine ACR, and there was no significant improvement with respect to the use of medications such as ACE inhibitors, ARBs, SGLT2s. So now a brief literature review. There are 2 trials. The NEPHSTORM trial done in Ireland from 2018 to 2020. There were 48 patients who were given MSC at doses of 80, 120, and 160 million units, and they were primarily assessed for drug safety. there were 2 mortalities which were not directly related to the MSc infusion, and 6 and 18-month profile was favorable in the lowest drug group. Secondary outcome was improvement in GFR, which showed similar results to our study. Serum creatinine level and NGAL were used for estimation as compared to...
30 seconds, please.
Sorry?
We are already running short of time.
So finally, the conclusion. So MSc is a potential treatment option for diabetic nephropathy. It can, both our primary and secondary objectives are achieved. However, due to a relatively small sample size and duration, less duration, this cannot be generalized. So larger multi-center trials are required, larger cohort and longer duration of patient follow-up is needed for elaboration of the role of MSc in DKD management. Thank you very much.
जी, any questions or comments? Any reservation? जी, Yaqub sir.
Thank you again. I think it's a very brave study to be done in a country like Pakistan.
Zara thoda sa please move it closer to you.
It's a very brave country, a brave study
Sir.
in a country like Pakistan. So on that, I would say you're congratulated.
Thank you very much, sir.
I'm very nervous.
Sir.
We did a study in Alport's animals
Sir.
and gave mesenchymal stem cells from the bone marrow. And most of the mesenchymal cells either converted into fibroblast
Sir.
or even dermoid cysts.
Sir.
But they are very, very powerful cells.
Sir.
So then we did the same study, having done a radiotherapy to the kidneys.
Sir.
And we got mesenchymal still in surviving when we gave after radiotherapy of the kidneys.
Sir.
And guess what? The radiotherapy to the control group
Sir.
also improved the parameters.
Sir.
So was it mesenchymal stem cells or the radiotherapy which was causing the benefit?
Sir.
You have not tagged these mesenchymal stem cells. You have no idea what those mesenchymal stem cells are doing in a pro-fibrotic environment.
Sir.
And there is quite possible that you might make the matters worse in long term.
Sir.
Rather than, and with so many effective therapies coming,
Sir.
is there a place for such an invasive therapy in diabetic kidney disease?
Sir.
So I will just say that the focus should be on getting all your diabetic kidney disease patients on guideline-directed therapies,
Sir.
rather than inventing mesenchymal stem cells.
Sir.
And it got to be for a very selected group of patients.
Sir.
And even the 2 commercial partners which you couldn't complete because you are running late,
Sir.
they are thinking of abandoning the whole idea. So this is the inside information,
Sir.
that the phase 2 trials did not go the way they were, so they are thinking of abandoning the whole project.
Sir.
They are the commercial partners.
Sir.
So you are not even a commercial, you are just
Sir.
a research. So I would just say that move to something else.
Sir.
Any other question?
Thank you for the presentation.
Thank you.
I have one more question or comment. The HbA1c,
Sir.
was that averaged over that time period or just taken at one point?
Sir, it was taken, sir, at the time of the enrollment of patients, sir, at the baseline, and then at 6 months, sir.
Right, so you haven't got one over time?
No,
It's
sir,
just
because of
2
the 3
months.
months period.
Yeah. And the other fact is lead time bias. The patients with diabetes, do they all have similar amount of end organ damage?
Sir. Sir, end organ damage, sir, other end organ damage, we assessed for it, but however, we did not correlate with the diabetic kidney disease, sir. We just look at diabetic kidney disease, sir, and then we proceeded forward, sir.
Okay, thank you.
So thank you so much, sir.
But I have a comment, just brief one. I don't know what my colleagues and youngsters will feel in this hall, but determination of GFR by DTPA,
Sir.
I have serious reservations. And I have tried to raise this issue with the people who run the department of nuclear. And I don't think even literature recommends that if you really want to do it, so go by DTPA. I have find faults in quite a few patients that the results did not tally with the other methods of finding GFR, different equations. Any comment on this point?
I think very good point you have made. So DTPA was meant to shorten the duration of measurement of GFR, which is basically the decay of nuclear dye.
Technetium levels.
And it is usually done for 4 hours. So the patient goes, you give an injection, and then you take the measurement at that half hour, 1 hour, 2 hours, and 4 hours. That is the current trend. That can be, slight variation in that timing can give you quite screwed up results. At the moment, you know the gold standard is inulin clearance, which nobody does. But now, iohexol is the one which is now being promoted by our all the international and national societies. It's very easy. You inject a certain amount, and then the patient doesn't have to even come back. Give an injection in front of you, and give him a blotting paper and a self-addressed envelope, and tell him to just pinprick it, give that blot of paper, and post it to you. And you will get the result, which is more accurate than all the other timely measurement which we are doing. But I can understand, it's very expensive, first of all. Iohexol is 1/10 of the price. It's very cheap, and it's more reliable, but your patient got to be reliable to give you at that particular time the blood test, and it's just a blotting paper. It's so easy. So just taking your point, that will be the future when you want to do a major GFR. DTPA and all the other shortened version have got some problem because of the timing of the sampling which happens.
But moreover, it's expensive. I know in Faisalabad, it costs about 9,000 rupees in this day. 9,000 rupees, 9,000. Yes. Professor Azman.
Thank you. I think I tend to agree with you, Professor Saab, because we did a study in comparative study in Sheikh Zayed Hospital, looking at 24 hours creatinine clearance and the Cockcroft and the CKD-EPI and the DTPA. And we found that DTPA was not all that reliable.
Yes.
And depends on how well hydrated the patient is and what has he taken in the morning, and these factors, they do contribute. So we generally don't rely on the DTPA. Sometimes it only helps in, seeing that whether the right kidney is working better or the left is working better. That's where, Thank you very much.
I remember I know we are running short. I remember a 17-year-old boy from Jhang just a year ago, on the basis of DTPA, they said kidney is non-functioning, please try to remove it. Luckily, I thought of some things about his age. I conducted IVP, absolutely normal. Then I took those studies to another people who do it, DTPA. They were embarrassed on me. So keep that in mind, please.
I'll now invite our third free paper presenter, Dr. Fariha from Dow Hospital, to present on the topic post-renal transplant cardiovascular remodeling.
Assalamu alaikum. I'm Dr. Fariha from Dow Hospital. I'm a postgraduate trainee there. So starting from the introduction, cardiovascular comorbidities secondarily to end-stage renal disease is one of the major determinants of early morbidity and mortality. The stressors in ESRD leads to an enlargement of heart muscles, decreased blood vessel supply within the heart, and the formation of non-blood vessel-related fibrous tissue, as well as hardening of arteries and reduced flexibility in the heart. It diminishes the cardiac efficiency in pumping blood and escalates the energy and oxygen required by the heart. The main study endpoints were to assess the cardiovascular function capacity in individuals with ESRD, both pre and post-renal transplant via transthoracic echocardiography, and to examine any functional and structural changes in their cardiovascular system during this process. This was a quasi-experimental, non-randomized study. The study was conducted at Dow University Hospital in collaboration with Department of Cardiology. 65 patients were included in this study. The pre-transplant cardiac evaluation were performed 1 month prior to the surgery, and follow-up assessments were conducted at 12 months post-transplant. Cardiac structure and function were assessed using echocardiography. How echo helped us? We assessed the left ventricular remodeling by using left ventricular mass index and left ventricular dimensions and left ventricular ejection fraction. Vascular stiffness was assessed by using pulse wave velocity with higher values indicating greater arterial stiffness. Chamber dimensions were also assessed by using interventricular septum, and posterior wall thickness were assessed in diastolic to identify remodeling. We included the patients which were at the age 18 to 65 years and were being transplanted during this study period. We excluded the patients having pre-existing cardiac disease unrelated to ESRD, patients with severe systemic infections, and patients unable to provide informed consents were also excluded. We classified these patients into high-risk and low-risk groups. The high-risk patients were the patients with significant cardiovascular comorbidities, like having reduced ejection fraction, left ventricular hypertrophy, or pre-existing hypertension. Low-risk cardiovascular groups were the patients having without significant comorbidities. The mean age at the participants was 44 years, and 58.5% were male. Almost 89.2% patients were on dialysis for 28 months. And of the total sample, 72.3% had pre-existing hypertension, and 40% had diabetes as a contributing cause of ESRD. On the results, we got that kidney transplantation was associated with marked improvement in blood pressure control. At 12 months, 68% of patients achieved optimal blood pressure control, and compared to 21% pre-transplant. Pre-transplant hyperkalemia was noted in 38% of patients, which declined to 11% by 12 months. Calcium phosphate balance was also normalized in 62% of patients during the same study period. But the primary endpoint was the effect on the left ventricular mass index, which was significantly improved from 141 gram per meter square to 116.5 gram per meter square post-transplant after the 12 months of the period. And the ejection fraction was also improved significantly in the majority of the patient, from EF increased from 37.4 to 44.8% at 12 months post-transplant. So concluding this, the kidney transplantation led to significant improvement in cardiac structure and function in patients with ESRD, reflected by a reduction in left ventricular mass index, better blood pressure control, and improved systolic performance as measured by ejection fraction. 2/3 of the cohort demonstrated clinically meaningful ejection fraction improvement at 12 months. Both high and low-risk cardiovascular subgroups benefited well, although the degree of recovery was more pronounced in high-risk patients with pre-existing structural cardiac changes. Thank you. I would like to thank my team from Dow University Hospital who helped me in this presentation and in this research. Thank you.
Now I'll invite our fourth paper presenter, Dr. Bilal Mosa.
We have to ask her, give her time also, because we have given time to other presenters.
Sir.
So for questions, at least for 2 questions.
Okay,
because we have given it to the other participants.
Right.
Please.
Okay, the thing is, it's a good paper. I have a question for you. Have you guys done coronary angiography before proceeding to transplant? Because
yes.
have you, like my question is, have you ruled out in ischemic heart disease before proceeding to transplant?
We ruled out ischemic heart disease.
In every patient?
Hold, yeah.
We just ruled out the ischemic heart disease by doing the echocardiography, and we just get the fitnesses of those patients, and they all were given the fitness. They were not having any.
I think I am asking whether the ischemic heart disease was excluded by doing a thallium scan or coronary angiography in every patient or not?
Yes, every patient was excluded. These MPI scan was done, and each of them was MI was excluded.
Where you mentioned about coronary angiography, it's not a non-invasive procedure.
Yeah.
And unless you have some specific reasons, I think it's not recommended that everybody should go through it.
The paper is about improvement in echocardiographic findings. So I was just trying to ask whether the patient has underlying ischemic heart disease or not, because many patients, they are asymptomatic pre-transplant.
Yes,
yeah, please.
Yes.
Is like we always take the patients in two groups, like those who have diabetes and plus 40. We always go for MPI scan regardless of the cardiologist suggesting, and after doing that we get the cardiac fitness. So if the cardiologist think that the patient still needs angiography, then they always proceed for angiography. So it is not mandatory, it is never recommended that every patient should be going for angiography before proceeding for the transplant. The point of doing this study was, previously in Pakistan, these all patients were left behind who have ejection fraction of less than 30. Those patients were never been selected for a transplant in any center in Pakistan. So we have started including all those patients, and we have done it very successfully. And the results show that majority of the patients have improved their ejection fraction post-transplant.
Very good.
Sir, we are running short of time. Can you please have the other two presentations, and then we can have...
Excuse me, we are running short of time, sir. Sir, we cannot take any further comments. Sorry for that.
I'll invite Dr. Bilal Mohsen from King Faisal Hospital, Saudi Arabia, who will present on the topic, Are Expanded Criteria Donors a Viable Alternative?
Thank you so much for giving me this opportunity to share a futuristically very relevant topic to the nephrology segment in Pakistan. And I believe that this is a core issue that we deal when we are dealing with patients who are on the waiting list of kidney transplant. The topic of my research is that are expanded criteria donors a viable alternative? Comparative outcomes of kidney transplant from expanded and standard donor criteria, and we have a 10 years experience from our center. So this is the background. We are aware of this thing that there is a global shortage of not even living related donors, living unrelated donors, but even deceased kidney donors are not very easy to find. And this is the reason that most of the transplant programs have been compelled to expand donor eligibility. And that includes extended donor criteria. And in contrast to standard donor criteria, often these kidneys originate from deceased donors who are on the higher end of their age spectrum or have their comorbidities. This helps the transplant centers by alleviating the waiting list burden, but it raises concerns about long-term graft durability, and together with that also patient-related outcomes. And that is what basically was the driving force for us in our center, that let's find out that we are doing extended donor criteria transplant, we are doing standard donor, is there any comparative difference between the two? And this is our methodology. We enrolled continuous serial enrollment of all the patients who underwent, it's a retrospective cohort study, but we enrolled patients who underwent transplant from January 2015 till December 2023. And we followed them up till December 2025. So this is the recent data that we are sharing with our colleagues. Minimum follow-up duration of 24 months with a maximum duration of plus 10 years. Primary endpoints that we considered for our patients were graft survival and patient survival at year 1, year 5, and year 10. And secondary outcomes included the serum creatinine, rejection episodes, and BK virus nephropathy. And we use multivariate Cox regression and logistic models for other core confounding variables, including donor age, the creatinine at the time of kidney duration, cold ischemia time, and recipient comorbidities to find the impact of the factor that we are studying.
And this is how we define standard donor criteria. Young donor, basically simply stating young donor with no comorbidities with a donor creatinine less than 1.5. Expanded donor criteria, donor age 60 or above or less than 60 years with a history of hypertension, death by stroke, or terminal creatinine of more than 1.5 milligrams. A standardized induction regime was used for all these patients, including methylprednisolone pulses. Thymo was the standardized induction, 1.5 milligram day 0 and 1 milligram from day 1 onwards, depending upon the CBC differential count, absolute lymphocyte count, and together with the cellular response of the patient. And maintenance immunosuppression was also standardized with Prograf, prednisolone, and Celcept. Standardized prophylaxis, our center regimes include Velgan, Cyclovir, Bactrim, Omeprazole, and Heparin. And these are our results that I would like to share with our kind audience. 143 deceased kidney transplants were done, out of which standard donor criteria were 85 and extended donor criteria were 58. That is a significant number. Mean recipient age of the patients who are receiving kidneys from the extended donor criteria was 61 years and standard donor criteria was 48 years. No statistically difficult gender difference between the two groups. Recipient demographics, when we saw the recipients who received these kidneys, we saw
1 minute
that...
remaining. 1 minute remaining, sir.
Okay. We saw that the patients were diabetic and cardiovascular disease were more in the extended donor criteria. As far as the results, donor-related AKI was present in 29.3% of the extended donor criteria and 11.8% in STC, and it was the independent factor of worse graft function and graft survival at 5 years. Graft rejection in both the groups was slightly different, with more patients rejecting in EDC. BK virus was comparative. We noted lower 5 years graft survival in EDC, but the patient survival at 10 years was comparable. Donor age, donor AKI, cold ischemia time, and recipient diabetes were independent confounding variables. This is how we see our key proportion of donor types with acute rejection and BK virus nephropathy at comparable between the two groups. And this is the patient survival showing very encouraging results at 10 years between both the groups with standard donor criteria and extended donor criteria. And this is the graft survival summary and the patient survival summary. 5-year graft survival is comparable, but of course better in STC, but of course in 10 years, the patient survival is comparative. And limitations of retrospective study were there. Clinical information might be missed due to lack of charting. Significant clinical events outside our hospital could not be recorded. But this is how I would like to conclude, and I would take 30 seconds on this slide, please, if I am allowed, that extended donor kidney transplant remains a viable strategy, especially for patients who are old age recipients, multi-access failure patients. This can be the lifeline for a couple of years for them. Patients with high PRA with positive cross-match on several runs on the deceased kidney transplant, and the patients who have been on waiting list for a couple of years. We need further data. We are welcome to a mutual collaboration, to a multi-center studies. We need to expand our data because I believe that this is, inshallah, the future that we will be practicing nephrology in Pakistan. Thank you so much, and questions are more than welcome.
Two quick questions. Only one? All right, wait. Ji.
Thank you, sir. Right, sir. Right, sir.
Right. So, and with no waiting list in, as I know, in Pakistan,
yes, sir.
There is no disease donor program. So what you said is slightly irrelevant. My comments are that the donors, whether the extended criteria or whatever,
little bit loud, please.
Were they local, or were they expats
who
have fallen from a wall and then be used as a... So that's one thing which is slightly in the news, that quite a few deceased donor in Middle East, they come from poor expats who are working there. And the comorbidity of the people who are the locals, who benefit from them, because they are the one who are on the waiting list, they cannot be considered as donors. So I just want to ask that in your extended criteria donors, as well as in your standard criteria donors, what proportion of patients were local, which is I'm talking of a Saudi versus how many were expats?
Sir, in the last decade, there has been a rising trend of kidney donation in local Saudi population, but till date, sir, I totally agree with you. 78% of kidney donations are coming from the expatriates due to accidental deaths, traumatic injuries, and they are usually involved in the labor work, so they are more prone to these injuries, and they are taken as STC and sometimes EDC also. But in 2025, sir, we had 55% of the donors at local Saudi population.
So that is an improvement.
Yes, sir.
But you know what I'm trying to. How many expats who are there working are on the Saudi waiting list for kidney transplant?
So we have a local population donor list that has been updated, but recently in the last 2 years, the expatriates have been also encouraged to enroll in that list.
My question was not be diplomatic. I ask a simple question. What proportion of expats who get a disease with end-stage renal disease are put on the plane, visa cancelled, and sent back to the country of their origin?
Sir,
I just want to know what is happening, because you are working. I get this news from my colleagues. Is this a common practice, that if you are unwell, you get a chronic illness, you are just sent back? Is this the current trend in the Middle East? And this got to be highlighted. This is unethical.
Sir, unfortunately, I would like to second you on that this is what is happening, that if somebody gets into a life-threatening illness, we are honest with them that their insurance is not covering their expenditures, they travel back to their home countries. Thank you, sir. Thank you.
We will now move to our fifth and last presentation. I'll invite Dr. Warda Riaz from Bahrain International Hospital, Lahore, to present on the topic, Outcomes of Renal Transplant Utilizing Low-Dose ATG Titrated via Absolute Lymphocyte Count.
Assalamu alaikum. I'm Dr. Warda Riaz, working as a team member of Dr. Muhammad Ahad Qayyum in Bahrain International Hospital, Lahore. So we have done the study, Outcome of Renal Transplantation Utilizing Low-Dose ATG Titrated via Absolute Lymphocyte Count with our team members. And we all know that ATG is the standard of care for induction therapy in renal transplantation. Optimizing anti-thymocyte globulin dosage is difficult in resource-limited countries like ours. Routine CD3 T-cell monitoring is inaccessible and it is cost prohibitive. We all know this facility is not available in Punjab at least. Sorry. So, purpose of this study is to determine if absolute lymphocyte count can serve as a surrogate biomarker for ATG dose titration. So we took a cohort of 14 living-related renal transplants, and they were stratified into tolerant and non-tolerant groups. Tolerant group consisted of patients who were able to complete the ATG dose as initially prescribed according to their immunological risk. However, non-tolerant group were those who could not complete the prescribed dose, and we have to stop the ATG prematurely due to any of the following reasons. Either their absolute lymphocyte count become less than 0.2, platelet count become less than 75 to 50, or occurrence of severe allergic reactions. So the patients were monitored for up to 180 days post-transplantation, and our primary evaluation goal was rate of acute rejection, graft loss, and incidence of infection in both the groups. So these are our results. In the tolerant group, at this charge, the mean creatinine was around 0.87. However, in the non-tolerant group, it was around 1.05. Acute lymphocyte count was achieved in both tolerant and non-tolerant group, that is less than 0.5. After 6 months, the mean creatinine in tolerant group was 2, and however, in non-tolerant group, it was 1.03. No dialysis was done after the renal transplantation in both tolerant and non-tolerant group, and surprisingly, we didn't get any rejection. Biopsy was done in one patient in tolerant group and in one patient in non-tolerant group. Both came out to be acute tubular necrosis. We have lost one graft in the tolerant group due to mucormycosis. However, no graft was lost in the non-tolerant group. So we saw 37.5% infections in the tolerant group. Like 3 of the patients out of 8 had infections. 1 of them had LRTI, 1 of them had infective diarrhea, and 1 was mucormycosis. And interestingly, no infection was found in the non-tolerant group. So patients who achieved desired lymphocyte depletion despite premature cessation of ATG showed no increased risk of rejection, and on the other hand, it has also demonstrated decreased risk of infection as compared to the tolerant group. So this was our study. Thank you so much.
Yes. Don't tell me there are no questions. No. Is Azma, you want to about the last one? Professor Akhtar, Professor Halim.
Thank you, all presenters. And now I will invite the General Sohail Saber to present the shield to our chair and co-chair.
किनको invite करना है? शील्ड किसने देनी है?
I'll invite Professor Tufail. I'll call them. वो आ रही है सर.
टीम इसलिए जरूरी है मेरे साथ खड़ी होनी कि दूसरा एक तो सारे presenters ages were young but internally they were all heavy weighted. और जैसे रात बात हो रही थी नाम तो नहीं लिया गया लेकिन we all know कि what Professor Magdi Yaqub was referring to last night in terms of ethics and the attitude of the government. और उनके रिप्रेजेंटेटिव अगर रिटायर हो चुके हैं लेकिन मेरे राइट साइड पे खड़े हैं प्रोफेसर साबिर साहब जी माशाल्लाह बहुत अच्छी स्टडी थी एक्सीलेंट पहले कहा गया ये पिक्चर प्रॉपर ही लेना याद रखना
सर आप ले आए the next shield goes to Professor Saeed Ahmed. Now to the Professor Muhammad Abid. Sir, de den.
I'm sorry जब मैं वहाँ था तो पता नहीं मेरा माइक कहाँ पे जमा था मेरा क्या था ना हमने शीट एज ऑफ इनको प्रेजेंटर्स को देनी है भाई हमने तो खामोशी से बैठ के सुना ही आप और तो हमारी कंट्री कोई नहीं है तो शीट तो ये लोग डिजर्व करते हैं इतना अच्छा काम किया.
Now the last shield goes to Dr. Kiran. Sir. Scientific collaboration between clinicians and industry plays a vital role in translating innovation into patient benefit. We now move to an industry symposium sponsored by Nabi Qasim Pharma. I invite Dr. Raja Asif Masood to speak on anemia management in chronic kidney disease, a paradigm shift.
Excuse me. I just want to make one comment. May I request PSN to move into the 21st century by abandoning this useless shield awarding ceremony. Please second it who wants. It's more expensive, wasted time, which we would have given more feedback to your speakers today who have come all the way. They what needed us to give them the feedback. What are you going to with this shield? Please, in future, just send us by email a certificate of attendance. This is what I need. I don't need your certificate. I don't have the space in my luggage to take all this rubbish. Please save the money and bring 2 more attendees rather than wasting time and effort. Move into the 21st century.
So thank you for your
Please, PS, and listen to me.
इन्होंने लफ्ज़ ज़रा थोड़ा सा ना ज़्यादा इस्तेमाल कर दिया रबिश चल नहीं ये यूज़लेस एफर्ट है बेटे आई ज़रा थोड़ा सा और मैंने ये इशू बहुत दफ़ा जिक्र किया है मतलब फैसलाबाद में भी और बेटे जितनी मैंने वो आदत है ना कि नहीं जी जो है अपने जिन्होंने ऑर्गेनाइज़ किया है बहुत मेहनत इन्वॉल्व हुई है इसमें कोई शक की बात नहीं मेहनत इन्वॉल्व होती है मतलब लेकिन बेटे इट्स एन ऑनर अगर आप इफ़ यू कैन क्रिएट समथिंग आउट द हार्ड वर्क इट्स मच मोर इम्पॉर्टेंट दैन द शील्ड तो इन्होंने बहुत अच्छा पॉइंट रेज किया मैं भी करता हूं लेकिन चूंकि इनकी पोजीशन ज़्यादा बड़ी है आई होप इसका इम्पैक्ट होगा
I'd like to invite the panelists, Dr. Azaz Mand Ahmed, Dr. Akhtar Ali, and Dr. Professor Umair Ahmed Siddiqui.
All right, good morning, everybody. I've been told I have only 5 minutes now left to complete this quick talk. This is about something we deal every single day in our clinics and in the hospital, management of anemia and CKD. And we're going to talk about quickly about the role of hypoxia-inducible factor, prolyl hydroxylase inhibitors. This is something new drugs emerging in our field. So it's pretty common anemia in all over the world, and especially in Pakistan. You can see up till 60% patients have anemia, those who have CKD. And if you look at the dialysis patient, this prevalence goes up to almost 90%. So it's very important to discuss about it. Multifactorial, the etiology of anemia in CKD, especially most important one is erythropoietin deficiency. And erythropoietin is produced by peritubular cells in the kidneys. As the kidney disease progresses, that production declines, leading to anemia, along with some iron deficiency, which is also important. A couple of reasons for iron deficiency, including poor oral iron intake, blood loss, especially in dialysis patients, and inflammation as well, causing decreased oral iron absorption in the gut. And then you have inflammation that increases hepcidin levels, and that also plays a part in iron homeostasis, leading to inhibition of iron absorption from the intestine. And some other factors you can see that develop in the development of anemia and kidney disease. So what are the standard therapies we've been using right now to manage this anemia? These include erythropoiesis-stimulating agents, along with iron supplementation, depending on your ferritin and transferrin saturation. And if when needed, B12 and folic acid is replaced as well. So let's talk quickly about hypoxia-inducible factor prolyl hydroxylase inhibitors. These are the new emerging drugs which are being used now in different parts of the world, including Pakistan. So how do they work? I'll just go quickly on this slide. It's a HIF pathway which activates production of erythropoietin. So under normal circumstances, when we have enough oxygen, this HIF alpha is degraded by these prolyl hydroxylase enzymes, leading to decreased transcription of erythropoietin gene and as well as decreased iron absorption, and this way shutting off the erythropoietin production. What these HIF inhibitors do, they prevent that degradation, leading to availability of HIF alpha, which dimerizes with HIF beta and ultimately cause increased transcription of erythropoietin gene and cause production of erythropoietin. Also, it decreases hepcidin, which also improves the iron absorption from the gut. Now, there are different drugs which are actually available and approved for treatment of anemia, including roxadustat, vadadustat, and daprodustat, but we're going to talk about daprodustat, which is FDA approved, especially in dialysis patients, not in CKD patients, but in rest of the world, including Asia, Japan. It's improved in CKD patients, including dialysis. So this is a series of trials actually which were done on daprodustat, and it's called ASCEND trial. So ASCEND-D trial was done on patients who were on dialysis, and they compared daprodustat with erythropoietin and in patients who were undergoing dialysis. So they found out that, the target hemoglobin levels were almost same in patients who were on daprodustat versus HIF inhibitor versus erythropoietin. And you can see they also looked at the cardiovascular adverse effects, which were also almost the same. So they found out that daprodustat was non-inferior to erythropoietin stimulating agents in both hemoglobin level as well as kidney as well as cardiovascular effects were concerned. Then there was a ASCEND-ND trial. This was on patients who were not on dialysis, and daprodustat was compared with darbepoetin alpha. And they found out again among patients with CKD anemia, they were not on dialysis, and they found out that daprodustat was non-inferior to darbepoetin alpha with respect to change in hemoglobin as well as with respect to cardiovascular effects. And this was a trial also done to look at the quality of life. And in this trial, they randomized patients on daprodustat versus placebo. And they looked at the hemoglobin levels, which were much better in daprodustat group. And also they looked at the quality of life, including, by using a survey which included their questionnaires such as their physical activity, fatigue, and they found out that the quality of life was much better in the patients who were on daprodustat versus placebo. So daprodustat is a new emerging drug which is being used in different parts of the world, including Pakistan. It's approved by FDA on dialysis patients, and in Japan, and also in Asia and other Middle East, it's approved in CKD patients also. It's usually a once-a-day dosing, and depending on the hemoglobin level, you can start that at 1, 2, or 4 milligram. Also, if you have to switch it from erythropoietin, then you have to follow this table. If your requirement is less than 2,000 per week, then you can start with 4 milligram of daprodustat once a day. It's contraindicated in patients who are using cytochrome P2C8 inhibitors such as gemfibrozil, and other contraindications are same like erythropoietin, uncontrolled hypertension, cardiovascular acute thrombosis, or acute stroke. Also, you have to be careful when we use in pregnancy and lactation. In hepatic impairment, if you have class C, it's contraindicated, but in mild hepatic impairment, you can use this drug. Thank you.
Professor Tufail wants to say something.
I know we're running short of time, but without questions, no interest. But according to priority,
yes,
the factors responsible for anemia, you put erythrocytes destruction as number 5, and other 3 is followed. But I think if you carefully look, and I in fact conducted the study myself, went through it, RBC destruction is a factor, but it's the last one. Its contribution is only minimal. I don't know feeling of the rest of my colleagues. It should be mentioned, but it's not major.
Okay. Thank you for the comment.
Hello. Thank you. As it is an industry-sponsored symposium, and I assume that your background is from the drug which you were mentioning, my question is very simple, that you said that it is now licensed to be used in Pakistan.
Yes.
Can you please tell us from the company point of view how you get license in Pakistan for a drug? Simple, because I will just say from the British point of view that we have got NICE, National Institute of Clinical Excellence, which does cost-effective analysis of every drug approved by FDA, EMA, whatever. That process determines whether that drug will be available in the United Kingdom or not, purely based on cost-effective analysis. In a country like Pakistan, does that process exist that a poor Pakistani would be able to afford the drug and how much benefit he will get? So cost benefit, how many collie years a drug would be giving you to get a license?
I understood your question. Actually, that was one of the reasons I wanted to talk about this drug. And in a country like Pakistan, basically where cost is a big problem and people are not able to afford erythropoietin, the good quality erythropoietin, I would say. So for them, I think this drug is getting more famous in our country because it's less cost, it's not injectable, it's not sub-Q, they can take it orally, that improves their compliance, as well as the cost is better. So I also wanted to know with my other colleagues in Pakistan whether, because I'm having a difficult time, being more comfortable starting using it because still it's in question in FDA, especially in CKD patients. So I don't know what's happening in UK, what they're doing, but in US where, I did my fellowship, it's not being used, the way it's used in other countries. And one of the reasons, as you mentioned, is the cost issue too. So it's not approved by the insurance over there. So it's important to know by myself whether it's being used in other parts of the world or not, especially in UK. I mean, you can tell us if you're using there or not.
Yes, yeah. Please.
How much it cost Mustafa to, in a year time, you have got a patient who is on hemodialysis. I can tell you for my country, okay? You guys are working in Pakistan. You have patients on hemodialysis. They are on EPO, I assume, as part of the hemodialysis regime. What is the cost of EPO per year to keep a patient on hemodialysis? That's a simple question.
12 to 15,000.
Sorry?
12 to 15,000.
Rupees per month or per year? Per year. 12,000 rupees, so it's 1,000 rupees a month.
The institutional costs are different and the retail store costs are different. So people in Pakistan are getting free hemodialysis. I don't know if you know that, through the Sehat card. Majority of the population of Pakistan has been insured for 1 million rupees every year to get hemodialysis. That may differ from province to province. The Sindh province may not be in that loop, but the rest of the country is getting that. And the EPO is provided free of cost to all those patients who are getting dialyzed through the Sehat card program.
It's not free. The taxpayer is paying for it. But it is not free. It's free for the patient.
So that's why
I paying the tax.
I know. So that's why I said the institutional prices are different. The cost of EPO for the government is probably 300 to 400 rupees per 4,000 unit injection. But at the retail store, it may cost around 2,000 to 3,000 rupees.
Normally the EPO, it is it's 10,000 units cost about 1,500 to 4,000. It's different companies, different market. So it's around approximately if we take 10,000 units for 2,000 rupees, which means the patient is getting dialysis for 3 times in a week. And if he is getting 10,000 units per week, then you can sum up how much it's very costly. It's going to cost, and also the injection, depending on the number of injections he's getting. So definitely the tablet form is easier to take and lesser expensive.
Thank you, Raja, for doing this presentation. I just have one question, or if you can clarify for me. Seems like KDIGO anemia guidelines talk about the major adverse cardiovascular events with the PIF inhibitors. And these were non-inferiority studies, which we all know are subject to biocreep and other forms. This is how these medications come into the market. So the recommendation, it appears, is that only in those who are EPO resistant, one may go to these category of drugs, regardless of the cost. So if with the major adverse cardiovascular events, how can you justify indiscriminate use of this drug in the entire population of Pakistan just because of ease? I'm just trying to understand that. Thank you so much.
See, this is the very important question, and that's why we have to, whenever we are about to prescribe this drug, we have to make sure that about the cardiovascular safety. And in US, that it's not approved by FDA in CKD patients, only in dialysis patients, and mostly on those dialysis patients who are already resistant to erythropoietin. I agree with that. But even in those patients, they have concerns started using it. Because I was there recently, and my colleagues have not started using it. So that's why one of the things I wanted to bring this up, that in a country like Pakistan, we started using it, okay? And we are doing, we ourselves in our institution doing a study on this and see what are the effects we're going to get. But again, the other things which make us use this drug is the cost issue, compliance issue, especially a country like Pakistan. And I have personally not started using in CKD patients because I'm not comfortable with that. I'm using it only in dialysis patients, actually. And I'm going to do, we are doing a study, and we're going to see in next couple of months how these drugs behave. That's why, this topic, when, it came up, I wanted to discuss about it. I wanted to know, like the sir said, in UK, in other parts, like in Saudi Arabia, we have colleagues, are you guys using it, not using it, in dialysis, non-dialysis, how is it working? I just wanted to know. But I agree with your points. We have to be very careful when we use these drugs. Especially in patients who have risk factor for cardiovascular disease. We have to be careful.
One comment from me to the speaker and the colleagues. There is a lot of incentive to use the either EPO or hypoxia-induced factor medications. A while ago, when Stanley Sheldon came from UK, and he showed the data that adequate dialyzed patients do not need EPO. And he showed it is data and literature, and my senior colleagues who know Stanley Sheldon from UK, he demonstrated adequacy of dialysis, and if you properly dialyze these patients, you do not need EPO, only you need iron supplements. But there is a tendency in our population in general, and my colleagues who are practicing nephrology and hemodialysis know it very well, that patient is not dialyzed well and given EPO and other agents. If you dialyze this patient well, majority of them will be maintained to maintain HB of 10 and 11, providing other factors are being corrected. So why there is a rush to use an ESA or a medicine like that, unless you have adequately dialyzed these patients? And in government sector hospital, and there is a paper coming up by a younger colleague, patients are dialyzed twice a week, even a 3-hour session. And there is a rush and push and rush and push. Yes, rush and push. So the 10 are being dialyzed, and I worked in government sector hospital for 32 years and ran the nephrology services for ages and decades. So we have got 20 patients on and 20 are waiting. So adequacy of dialysis is a very important factor, which I would say we must emphasize here before we proceed to those supplemental agents which have its good and bad points. They are useful agents in a selected population. What are your comments on it?
No, I don't agree with what you're saying, because we have to be realistic and practical. If you practice in Pakistan, you know how these people are being dialyzed in our country. Recommendations are 4 or 5 times a week of being dialyzed, and we dialyze twice weekly, sometimes once weekly. Sometimes they don't get dialyzed. When they present to you, they are so anemic. So we're talking about those patients who are already anemic, and we have to use these erythropoiesis stimulating agents, and they cannot bear the cost of these drugs. So what are we going to do with these patients?
Can you get the HB up with the patient who's azotemic? You have got so many inhibitor of erythropoiesis, you can never get the HB up in patient giving either EPO or duprostatat. unless
true.
you dialyze them. So what is the wastage of money and time and energy and giving a false hope to the patient, giving an EPO or Deprostat or other agents when he is not dialyzed at all?
But that would be an ideal situation which is not happening in our country. We all know that.
Thank you, Dr. Raja. It was a very nice and illuminating talk. Thank you.
Thank you, Dr. Raja, and the panelists for their opinion. Thank you, Nabi Qasim Pharma, for supporting continuous medical education. Ladies and gentlemen, we now move to a significant milestone. The Pakistan Society of Nephrology is signing a memorandum of understanding with Nabi Qasim Industries Private Limited. The purpose of this memorandum of understanding is to establish a collaborative framework between the Pakistan Society of Nephrology and Nabi Qasim Industries for the planning, organization, and execution of a joint academic initiative titled Nephro Grant. This initiative aims to promote academic excellence, enhance clinical knowledge, and support the professional development of FCPS Part 2 nephrology trainees across Pakistan. May I invite the dignitaries to please come forward for this ceremony. Mr. Tariq Majid and Mr. Abdul Munim from Nabi Qasim platform, and Dr. Zahid Nabi from PSN. Thank you all involved in making this collaboration meaningful and impactful. We now move to the prize distribution of paper presenters recognizing excellence in research and scientific communication. May I invite Professor Zahid Nabi to kindly present the prizes to our paper presenters. I'll invite all prize winners to kindly come forward as their names are announced. The first three prizes are sponsored by Nabi Qasim, and the other two prizes are sponsored by PSN. I'll invite Dr. Babar Rafiq to kindly receive the prize. The first prize is of 1 lakh rupees, 25,000. The second prize winner is Dr. Umair Ijaz Malik, and the prize is for 1 lakh rupees. The third prize goes to Dr. Fariha, 75,000. The fourth prize goes to Dr. Bilal Mohsin, rupees 50,000 and sponsored by PSN. And now comes the last awardee, Dr. Warda Riaz. Sir, lucky draw. Lucky draw के लिए आप लोग इधर we will now proceed with the lucky draw, which will be conducted based on registered attendance. I'll invite Dr. Zahid Nabi, Dr. Adil Manzoor to come and conduct the lucky draw. Take the chair. Sir?
करेंगे वो वॉच है।
अच्छा थर्ड प्राइज
दूसरे साथ कौन है आधे में दूसरा
बस the draw is for the smartwatch.
He's our own trainee.
स्लिप भी दिखा दो सर स्लिप
Thank you, sir.
The next draw is for the tablet.
आयशा मुगल आयशा मुगल सर आप नाम पूछिए मुझे आयशा मुगल
Dr. Aisha Mughal, address is not written.
So this cancels the draw. You can go for the other one.
Dr. Sajid Abbasi, PIMS Hospital. नहीं what is alive and kicking.
Please sir.
Thank you.
The first prize, the first draw is for the laptop now.
Laptop.
Laptop. Yes. तारिक अजीज शिफा
Dr. Tariq Aziz Shifa Hospital, nephrology resident. ये सबसे
लैपटॉप
looks to me the best one.
सर ये चिट भी ले जाइए
ये चिट भी ले जाइए
थैंक यू सर थैंक यू
सर थैंक यू
We now enter the plenary session, the intellectual highlight of this morning. May I invite our esteemed chairpersons to the stage. Chair, Dr. Fazil Akhtar, and co-chair, Dr. Azaz Mand, Professor Khaja Mushtaba Qadri, and Professor M.H. Usmani, Professor Suhail Saber, for the co-chair. Health that empowers patients is healthcare that endures. This session highlights sustainability, patient autonomy, and system-level transformation in renal replacement therapy. It is a pleasure to invite our distinguished speaker, Professor Edwina Brown. Professor Edwina Brown is a president of ISPD and global leader in peritoneal dialysis.
Well, thank you very much for the kind introduction, and thank you very much to the PSN for asking me for a third time running to come to this meeting. I always enjoy coming to Pakistan. The welcome is very friendly. I've got to know a lot of people here and have garnered some understanding of the challenges that you all face in delivering kidney care here in Pakistan. So what I'm going to talk about today is the role of the International Home Dialysis Consortium in promoting the opportunities for people requiring dialysis to have this at home. So what I'm going to talk about are some of the challenges for dialysis here in Pakistan, why PD is going to be of benefit. I'll talk something about the International Home Dialysis Consortium, and then finish off with how this could be an opportunity for Pakistan. So while preparing this lecture, I did what everybody does these days, and I went onto Google and put in dialysis in Pakistan, and this is what it came up with in its AI section that now sort of comes up before you have to stretch your brain to click onto any individual websites. So this may or may not be accurate. I take no claims for the level of accuracy, but the key thing that it said was that only a small minority of people who with advanced kidney disease who would benefit from renal replacement therapy actually get it. That there is some free care for dialysis, but it's mostly dependent on charity rather than government funding. That hemodialysis is the most commonly available dialysis, but PD is encouraged as a cost-effective home-based option. And it then went into the challenges that we'll discuss during my talk. What this didn't say is that PD numbers in this country are currently limited to 300, because that is the limit set by Fresenius Medical Care, because they are making a loss on all the fluids that they sell to this country, because that is all that people can afford to pay. So in my background reading, and I think I quoted, because I lifted this slide off my talk that I gave last time, is that there has been a qualitative study looking at people's experience of hemodialysis in Pakistan. And that was published a few years, not that long ago. And they interviewed 20 hemodialysis patients in 2 units in Pakistan. And the general themes that came out of this was not people who really enjoyed the treatment or felt they benefited from it. There were numerous challenges for the people on hemodialysis. And I suspect that a lot of this was because of the out-of-pocket expenses that people had to come up with for hemodialysis, and the stresses that this put onto their families, and therefore their ability to work. But this is not unique to Pakistan. This is common in people who are living in low or middle income countries. And for people who are interested in the challenges of delivering dialysis or kidney replacement therapy in low and low middle incomes, I can thoroughly recommend the 2 papers that have just been published in Nature Medicine, which focus on the debacle that happened in Thailand when the PD first policy was reversed. And then there's really excellent editorial from Munira in Indonesia, who wrote this editorial on challenges of kidney replacement therapy under universal health coverage for low middle income countries. And what is talked about is, again, that it's the same dilemma, that there's a challenge to sustain public access to kidney replacement therapy without overwhelming the health system priorities. And that is because it's not a one-off cost for dialysis. It's not like paying for a surgery or for a drug that is a quick fix. People on dialysis accumulate. So you start 100 one year, 80 may survive, and the next year you're starting another 100 and the number's gone up to 180. So it's ever increasing costs for maintaining people on dialysis. And this is going to be a real challenge in aging societies and with increasing prevalence of diabetes. This commentary also went over the advantages of both hemo and PD, saying that there were advantages and disadvantages for patients, and that transplantation remains the best long-term solution for many patients. But the difficulty lies in how to finance these, procure systems, and then have the clinical capacity for delivering them. So why PD? Or any type of home dialysis. So PD avoids travel to a distant hemodialysis unit or having to relocate with or without your family. Hemodialysis, I think we all need to recognize, is often of variable quality and frequency and is often only once or twice a week, which results in poor patient well-being and a high risk of blood-borne virus transmission that can occur. That PD would enable people to remain economically active and involved in family activities, and it can be of benefit during short-term environmental upheavals, which are certainly more common in this part of the world than, say, in the UK. So with flooding or hurricanes or typhoons, then people are in their homes with their supplies and can continue their dialysis and don't need to worry about how they're going to get to the dialysis unit, say in a major blizzard or snowstorm. What about the advantage of PD to the healthcare system? Well, it lowers the use of complex transport systems to and from dialysis centres. Certainly where I live, we spend a lot of time organising transport of older, frail people who require ambulances, etc., to be able to get to dialysis. And in this part of the world, where people can live mostly in the rural communities, they don't have to think about how they're going to get to a dialysis centre in their nearest town. There's lower investment in building and equipping new dialysis centres. You need fewer nurses and other healthcare professionals, and there's much lower hospitalisation rates for bloodborne or airborne infections, and that was really important during the time of COVID. So the next thing that we need to think about is the comparison of costs. It's often said PD is too expensive. And yes, the cost of consumables for PD is inevitably going to be higher than the cost of consumables for hemodialysis. PD is almost entirely consumables, whereas hemodialysis, you require machines, you require buildings, you need water purification, you need a lot of staff, you need vascular access pathways, you need electricity, you need to air condition your buildings or heat your buildings, you need to transport the equipment, and the patients, the people on hemodialysis need to pay for their transport, or you need to pay for their transport, and they're not working, so not contributing to the wider system. Whereas on PD, yes, you need to pay for fluids, and you need to pay for the fluid transport to your country. If you're using APD machines, these need to be paid for, but there's much less staff, etc., and you need fewer units or clinic buildings. But there are many things that determine dialysis modality distribution over and above the actual costs. So a lot of it is the philosophy and the culture that is existing both by the individual person requiring dialysis, but also in the wider healthcare system and in the country. And we'll go into some of these interactions as we talk. So what is the IHDC? So the International Home Dialysis Consortium is a project that is a joint venture of the ISN and the ISPD. It's co-chaired by Vivek Yar for the ISN and by myself for ISPD. Its aim is to bring regional and stakeholder forces together to drive home dialysis uptake globally, not just in low-income countries, but in high-income countries as well, where PD is often underutilized. And the mission of the IHDC is to promote equity and increase access to home dialysis globally to both high and lower-income countries. So we all know that there's huge variation of the availability of chronic PD globally. And even in Asia, Pakistan stands out as this yellow country just above India. It's got even fewer people on PD than in India, which is already a fairly low use of PD. So as I've said, the IHDC is a joint project, and its membership is represents representatives from the major key regional societies, including the APSN, the Asian Pacific Society of Nephrology, and unusually, instead of just looking to industry for funding, we have used industry as partners, because industry can't expand access to home dialysis without us, and we can't expand access to home dialysis without the support of industry. So there are many challenges to home dialysis growth. And I'm not going to go through all of these because they're all well recognized. But I think we do need to recognize that there are biases amongst the nephrology workforce, because if you don't see a treatment, you're not going to recommend it. So there's lack of familiarity and training. There's a shortage of, therefore, of personnel who can organize and run home dialysis. The reimbursement schemes are often totally against home dialysis, with nephrologist incomes being dependent on people going to hemodialysis and being paid each time they see somebody on hemodialysis, which is, if 2 or 3 times a week, is considerably more frequent than people coming to peritoneal dialysis clinics, where it'd only be once every month or 2. I only see my maintenance patients every 2 months, but I'm on a salary, so it makes no difference to me whether my patients are on PD or on hemo. So we had our first meeting at the WCN in Argentina, and at that point we created 4 work streams that we saw as being the major planks for expanding access to peritoneal dialysis. And those work streams are empowering people needing dialysis, in other words, the patients, thinking about nephrology workforce education, developing workforce and resources, and then the politics of integrating care and payment policies. So what were the outcomes from this launch? Well, we created a manifesto which we then sent out to individual nephrology societies globally to get them to sign up to it, with the aim that they would then provide support for home dialysis, both in terms of education and also in terms of political advocacy within their countries. And we published this in Kidney International Reports last year. So what is this manifesto? It's available on the ISN website. And what it's asking people to sign up to is that in terms of empowering people needing dialysis, that it will provide, that the society will provide education of people for kidney failure, raise awareness of the benefits of home dialysis, that it will empower nephrology workforce education, educating and training not just the healthcare workers, but also the healthcare providers. That it will support the developing the required workforce and the resources needed to deliver home dialysis. So catheter insertion pathways, training, making sure that there are links with microbiology, etc. And really important, enabling advanced kidney care clinics and support for people so that patients get education about dialysis options before they actually need to start dialysis. And then the politics of integrating care and payment policies. And I think the absolute key to this is what I've put in bold at the bottom, is ensuring provision of fair and equitable reimbursement for home dialysis, removing the financial disincentives, in other words, nephrologist reimbursement, and actively promoting optimal patient choice of dialysis modality and location. So what has happened since then? So we've had 53, I looked at the website when preparing this talk last week. There are now 53 societies that have signed up, and I've listed those from the Asian Pacific region, and unfortunately, Pakistan Society of Nephrology is missing from this list of signatories. So I very much hope that, having heard me talk about the IHDC, that you will now sign up to this and give support for the concept of growth of home dialysis and how you can support it in this country. So what have we done since then? I want to give you some of the updates of how the IHDC has actually impacted in really a very short time period, the growth of home dialysis in different countries. So our meetings are usually linked with the WCN and or the ISPD. So our last meeting was at the WCN meeting in Delhi, when we had people from India, delegates from India, incorporated in the groups. So we had the outcomes from each group. So the barriers that were identified to patient empowerment, and this is really thinking about South Asia and India, were listed into the institution, healthcare providers, patients. And some of the things that was lack of a standardized policy, shortage of nephrologists, lack of empowerment of healthcare providers, low levels of health literacy. And then the possible strategies that were identified to improve patient empowerment were earlier CKD detection, and therefore opportunities to provide education to patients about the implications of their disease, which would have the advantages of being able to slow down the progression of kidney disease and therefore kidney failure, but also being able time to plan dialysis starts on the modality that suits the patient. Empowering healthcare providers, especially PD nurses and coordinators, making inclusion of PD in nephrology training mandatory, and then having PD patient champions who can really be very powerful advocates with policies regarding dialysis. You need multidisciplinary teams, and we also talked about technology and partnerships with industry. In terms of nephrology workforce education, that group had focused on the concept of a hub and spoke model. In other words, and we discussed this yesterday at the PD workshop, having a reference center or a center of excellence which then supports peripheral units or smaller units that are starting to develop PD. So the center of excellence can do the catheter insertions, they may even do the patient training, they can certainly lead on education, and they can lead on regular meetings of the whole network where you discuss difficult clinical cases, discuss the politics, provider issues, etc. The key challenges to this, certainly in India with the two systems of healthcare, public and private, the unplanned starts, and that in the public sector, PD is provided free in only some but not all districts. And of course, it's not really provided free anywhere in Pakistan unless you're able to access charitable funding. Developing workforce and resources was regarded as important, developing online resources which could be helpful for education. I'll skip over that complex diagram in interests of time. But in terms of the politics, the key things that were identified were the challenges, impact of reimbursement models, which we've discussed, the big block, not just here, but in many parts of the world, including many countries in Europe, is the fact that nephrologist incomes are dependent or linked to people being on hemodialysis and frequent visits.
Ma'am, 5 minutes remaining.
Okay. You need to think about reimbursement challenges and comparing dialysis costs. So what's happened since then? Well, certainly in India, we've had personal communications that the federal government is actually looking much more positively at PD and increasing funding for PD, but that needs to be now devolved down to state level. In Germany, which is hardly a low-income country, but only has 5% of their patients on PD, the German Society of Nephrology has actually quoted in a press release the importance of the IHDC in terms of highlighting the issues required for expanding home dialysis, and they see this as essential because of a shortage of nurses and also hemodialysis centres in a country with very low transplant rates. In Malaysia, both Raj Malhotra representing ISPD and myself representing IHDC were invited to a meeting with the Ministry of Health just before the Asian Pacific PD meetings in September. And interestingly, at that meeting, we had a patient come who, when asked by the minister why she liked PD, she says because it enabled her to lead a normal life and get on with what she wanted to do. And he repeated that statement several times during the meeting. So it really shows how important patients are in terms of impressing people like ministers of health, because only 2 weeks ago he announced in Parliament an increase of funding for PD in Malaysia from 40 million up to 100 million. I'm afraid I don't know their currency. So a huge increase in support for PD in the government sector. So what about for Pakistan? So the IHDC is having its next meeting at Yokohama at the WCN, and will be focusing on high-income countries, Taiwan, Korea, and Japan. And Ahad Qayyum from here is going to be at the meeting, and so we'll come back with ideas about, how people are addressing the politics and the advocacy needed for expanding PD. So the key, the principles identified by the IHDC are really relevant to Pakistan in terms of patient empowerment, education, etc. We need to get the manifesto signed by many more places, including by Pakistan, because by having support of the PSN, that really gives an important message to the politicians that PD is really an essential component of delivering dialysis to the many people in this country who can't access dialysis. And of course, you're already doing some of this. So this photo was from the PD workshop 2 years ago, where I was really impressed by the rapid expansion of PD knowledge and know-how that has occurred in this country. And of course, we had the workshops yesterday, which were really buzzing with many more people than had been anticipated who came to that. And the last time I was here, we did have a meeting with the providers, the industry, really trying to focus on how you're going to develop PD here in Pakistan. And as I've said, the challenge to the global suppliers is that the amount that they are getting paid per bag of fluid represents a loss for them. You do now have a local company, an IV fluid company, who is about to launch homegrown PD fluid at exactly the same cost, not very different to the cost that what is being paid for Fresenius. So it's not a cost-saving exercise, but it does mean that you will be able to, it won't limit the amount of fluid that's being delivered, because the Fresenius cap it at 300. The company concerned told me yesterday that they're expanding up to 1,000. And if that actually happens, by just the sheer quantity of making the fluid, they should be able to bring down the costs. However, you're always going to need 2 suppliers in case something happens, and I'll be addressing this concept of homegrown or local fluid production in my talk tomorrow. So how are we going to measure the outcomes from the IHDC? There are various stages for this. We're sort of midway really at the moment. We've got the manifesto, which is at the bottom, and there is an increased focus on home therapies in many meetings. We do have some global and regional collaborations, and it'd be really excellent to see one here in Pakistan. And then we will need to see an increase of number of centers and patients on home dialysis. And the eventual tip of the pyramid is an increased access to dialysis overall, not just home dialysis, but by increasing access to PD in many parts of the world will actually increase access to dialysis for everybody with reduced costs of care and improved patient outcomes. And this is my last slide. I saw this sculpture at the Royal Academy 2-3 years ago at an exhibition of art from the southern states of the US. And it immediately grabbed me as really the challenges for growing home dialysis. We've got all these different wheels or things that are stopping us. It's only by getting everything into line that that bicycle is going to go ahead and actually achieve our aims of increasing access to dialysis for all. Thank you. Okay.
Thank you for presenting a roadmap that aligns innovation with accessibility. Good science asks good questions. Great science changes practice. This is a rare opportunity to learn about scholarship, editorial rigor, and the evaluation of nephrology literature. Professor Rajneesh Mehrotra is invited to speak on reflections after a decade of editorship at JASN and CJASN. He serves as editor-in-chief of Clinical Journal of American Society of Nephrology.
I want to thank again the Pakistan Society of Nephrology for inviting me. It's a pleasure. Even though I've been an editor for 10 years, this is beautiful Seattle, where I come from. I invite you all to visit. But this is the first time I'm actually speaking publicly about my experience in 10 years, so I'm grateful for the opportunity allowed me to reflect on what I've been doing. So the guiding experience for perspective is that for 7 years, I was the editor-in-chief for CJASN, and I have now the privilege of being the editor for JASN and also lead the portfolio, which is 3 journals from the American Society of Nephrology. So where I want to begin is that journal publishing is even more crowded. If you look in 2025, Clarivate, which is the clearinghouse for all journals, reported that reports the journal impact factor for 55 nephrology journals. That is a lot of journals. And if you look at what the impact is of these, about 8 journals have had an impact factor of more than 5. That means the work they published relative to how many, the number of citations to the work they published relative to what they published is 5 times the number of citations as the papers they published. But there are 10 journals that have an impact factor of less than 1, where they published the work, but it is not cited by the same volume. So the traditional model for journal publishing is subscription journals, and it is we as individuals subscribe to the professional society. So if you're a member of the American Society of Nephrology, you have access to the American Society of Nephrology journals, or the publisher. And usually the publisher, it is an institutional subscription to the journal, but increasingly it is that libraries are subscribing to portfolio of journals that are published by an individual publisher. And then there are some paid charges that everybody has to pay, and that's been the traditional model of journal publishing. These are some of the big names in journal publishing. Just for disclosure, Walters Kluwer publishes the ASN journals. So Jason, C. Jason, Kidney 360 are published by Walters Kluwer. I'm the president of ISPD. In that regard, Sage Publishing publishes our journal, which is the Peritoneal Dialysis International. So just kind of putting it out there. But if you look at it, there has been a pushback around the scientific world around this model. And it largely is that this journal publishing is run by large corporate publishing houses, which in 2024 had an estimated annual revenue of $28 billion. And the profit that they have is between 28 to 39 cents. Let's say 40% of 28 billion is their profit. So it is a very large money-making enterprise for the professional journals. And so this has led to is moving away from subscription journals to open access journals. And the open access journals is that the expectation is that research will be publicly available, that it'll not be behind a firewall. I don't have to be a member of ASN to access articles that are published in ASN. And that's the way it is. Nevertheless, there is an expense that is related to publishing. Instead of the readers paying the charges, now the authors are paying a large number of charges. And this is the growth in open access journals. This is up through 2021, and this is across all specialties. As you can see, there has been a substantial growth in new journals. New subscription journals is in blue, and in this orange is this open access journals, and those are the type of journals that are increasing most rapidly. This is just an illustration of how much it costs for an original research article to be published in any of the nephrology open access journals. KI Reports, Kidney 360, as you can see, it's between $1,800 to about $3,800 is per article that is paid for by the authors. As a part of this movement towards open access, and because there are delays in peer review, what has also grown is the culture of preprint servers. Preprint server is a service that is provided where I have finished my research, I've written up a paper, and I go and submit it even before it is peer reviewed. That does not preclude its publication in another journal later on, but at least I can tell the world I've finished this research and it is now publicly available for you to judge. Preprint servers really boomed at the time of the COVID pandemic, where there was delay in journal publishing and people wanted to get their work out quickly in terms of their experience that they were having. And there are these two preprint servers, the BioRxiv and the MetRxiv. These are the preprint servers that at least the science we receive in nephrology journals is often posted by the authors before peer review. A strong word of caution, this work has not been peer reviewed. And so one has to exercise great caution in assuming the validity of the work that is published there. It is eventually, hopefully, going to show up in peer-reviewed journals, and you have to be mindful of the risk you take when you focus your work that is coming from these preprint servers. And then finally, all of this open access movement has led to what is called predatory journals. And predatory journals essentially have little to no peer review. Papers are accepted without regard to quality. Authors are informed of pay charges after acceptance. There's aggressive solicitation of authors and for editorial board membership. Fake academics are posted on editorial boards. They mimic the name of journal or website of journals that you know about, and they cite fake or non-existing impact factor, and they boast about being indexed. And that has also, it is estimated that in 2025, there are 18,000 such predatory journals. And many of us get solicitations 3 to 5 a day to submit the work to predatory journals. And so it's again a word of caution in being careful in where you choose to publish your work. in what that means to the scientific publishing world. But I think aligned with all of this, and because there's this push for rapid introduction of science into the world, but then also particularly with the COVID-19 pandemic, there has been a rapid decline in public trust in science. And this is in the United States. This is, I don't know if you can see this blue line up top is the hospitals and doctors, how the trust in them has plummeted. This green line is scientists and researchers. The red line is CDC, which is the Center for Disease Control, and the yellow line is for pharmaceutical companies. There has been a rapid erosion in trust, and this, for us, those are journal editors, and for those of us that are researchers, have to acknowledge this decline in trust and make sure that the work we do builds that trust, that we have to maintain the integrity of the work we do. In the end, what we cannot influence is the politics in the communities we live in and the vested interests that are driving that mistrust. We cannot influence that. But what we want to make sure is that we have policies and approaches that allow us to stand by the work we publish with integrity. And that is what needs to guide the work we do as journal editors. So considerations for editorial work then is that we compete for and publish the most impactful science in the world, while also ensuring editorial approach and policies that engender trust of the medical community at large. So selecting the best science, so I'm just going to show some, a lot of the perspective that I'm going to provide is from the ASN journals. Our approach has been to make sure that we have a low burden of submission of articles to the journal on the authors. We provide high quality peer review. Between the 3 journals, in the last 2 years, we had over 3,600 people that stepped forward to review articles for the ASN journals. We want to make sure that our decision-making is consistent across manuscripts, and we provide editorial guidance for consistent reporting, and then we have a multimodal approach for dissemination, and I'm just going to skip that in the interest of time. While maintaining high rigor, we want to be welcoming of the best science, but we don't want to be, but we have standards that we want to maintain. In 2025, this year that just ended, we had over 2,700 papers, research papers, that were received by the ASN journals. So Jason and Kidney 360, these are over 2,700 unique submissions. And as you can see, this is how selective we are. In this year, 80% of all the work that was submitted was either triaged, that means it did not go out for external review, or it was rejected after external review. 18% of the work was published, 2% of the work we still is in process, and we don't have a decision for that. So our hope is that we maintain an author-friendly culture because it's competitive, yet we want to make sure that we are consistent in our decision-making and maintain high rigor. One of the things I just wanted to acknowledge, and this is part of the conversation that I had the other day with some people, is that we have had a substantial rise of submissions to JASN and across the ASN journal portfolio from Asia, particularly from China. And that is particularly true for basic science. In fact, most of the basic science submissions, as you can see, there are twice as many submissions that JASN receives from China than from the United States, and it has been rapidly increasing. And this is a phenomenon that is not limited to nephrology. This is from the New York Times. There is this report that came in that Chinese universities surge in global rankings as US schools slip. And this is Leiden, University of Leiden is in the Netherlands, and University of Leiden publishes the results of the impact of science based upon the universities. What is evident is that of these top 15, as you can see, there are only 2 of them that are outside China. 13 of them, the 13 universities with the most impactful scientific research that is coming out from China. The only 2 institutions that are there are from North America. One is the Harvard Medical School, and second is the University of Toronto. If you go down further down the list, the next US university after number 15 is number 20, that's the University of Michigan. The first university in Europe that shows up is Oxford, which is number 29. The University of Washington, where I am, is number 39. And this has been a dramatic change in the last 20 years. There is a huge and so we ignore science coming out of China at our own peril. There's a lot of funding in research that is going there, and we need to be mindful of the work that is coming out of there, and it is not simply in nephrology, but also across biomedical science. So what papers meet the threshold? I had asked me, like, initially when he proposed the topic to me is, why do papers on Pakistan not get published? And I don't want to answer that question because I don't know. But which papers meet the threshold? It is, we start off by posing the question, is the research question significant? And of course, because we're an international journal, it has to have relevance around the world. Is the research question relevant? Is significant? That is the triage decision. Are the research methods valid? And that is very important because there is concerns about reproducibility of research. I do some research, I publish the work, somebody else does the research, they don't get the same findings. And so we have to be very careful in that regard to make sure that the research methods are valid. And the next thing is inherently subjective. Are the results a meaningful advance in the field? And what is it? That's in the beauty lies in the eyes of the beholder. Is this meaningful or not? Depends upon who's looking at it, and that is important decision making. Nevertheless, what we want to do is to solicit the best science. You know, even though we consider ourselves as a highly selective journal, yet we are competing with other highly selective journals for the best science. And so we routinely, high-impact journals, starting from the New England Journal of Medicine, routinely reach out to leading investigators around the world for high-impact work to be published in their journal. And there's been a big transition also in the nature of science that we publish, for example, in basic science. It's moved to like multi-omics, spatial transcriptomics, single-cell transcriptomics, and imaging. And there has been a rapid increase in clinical trials in nephrology as new therapeutics have come through in nephrology. So for example, in diabetic kidney disease, for the longest time in my professional career, all we had was ACE-ARBs. And now we have SGLT2 inhibitors, we have GLP-1 receptor agonists, we have mineralocorticoid receptor antagonists. And then greatest advance recently has been in IgA nephropathy. Like, if you just look in the last 6 years, it was in 2022 that budesonide was approved, then sparsentan, and the endothelial receptor antagonist, iptacopan, a complement inhibitor, was approved. This is all in the United States. Atrasentan was approved. And then we have, I cannot even pronounce this now, sibeprenlimab, whatever it is. And there are other drugs like atacicept, which is an APRIL-BAMF inhibitor that is in progress. So there is a rapid increase in the number of clinical trials, and the commitment that we have as biomedical research journals is to, may I just go back, this is a paper that is published in CJSON, which in my assessment is the reason why we have had such rapid approval. Before work like this was published, it was necessary for manufacturers to demonstrate that the treatment slowed the decline of GFR. Now that is a long-term outcome which is very expensive for pharma to fund. Research that was done that said, if we look at drugs that lower proteinuria, that is a good surrogate. And so then the FDA agreed to change the surrogate. The FDA said, we don't require you to show that there is a improvement in decline in GFR. If you show it is reduction in proteinuria, we'll approve the drugs. And so their foundational work such as that has been important in leading to the changes that we are seeing in IgA nephropathy, particularly in therapeutics. But nevertheless, as a journal, we feel it is our responsibility to rapidly publish clinical trials as they are presented at meetings. And this has been one of the key initiatives that I've led in the last 3 years. And we've been focusing initially, for example, we published this paper that was presented simultaneously with the ERA. In 2024 with Kidney Week, we published 4 clinical trials that were published simultaneously with their presentation. And then with the hypertension meeting, and then 2 of these with Kidney Week in 2025, and look out for more simultaneous publications in JSON from the World Congress of Nephrology and the ERA meetings. We are reviewing several submissions that will be presented at late-breaking clinical trials. If they meet the bar, they will be published simultaneously in JASN. All right, moving on to the second part of my talk in terms of what I said is because trust in science has declined to its lowest levels since it's been measured, it is a responsibility to build and maintain trust. And I've just highlighted 4 things there: disclosures of conflict of interest, prospective registration of clinical trials, data sharing, and what about artificial intelligence? So disclosures of conflict of interest, this is a paper, this is an article that was published in 2018 and CJASN was the leading story on the front page of the New York Times in ways I did not want CJASN to be. And it was that one of the papers we published, one of the co-authors was the dean of Yale Medical University, and he was a consultant with the company, and he was receiving hundreds of millions of dollars in consultative fees from the company, which he did not disclose as a conflict when this paper was published. That was the last straw that broke the camel's back. The editor, the dean at Yale was forced to resign directly as a result of failure to disclose conflicts of interest for a paper published in CJASN that I had overseen. So this is something that I take very seriously because I don't want it to happen again. I'm not going to go through the details of this audit that we did, that made me raise the question, like, how good are we in collecting data for commercial conflicts of interest for the authors of the papers we publish? And the most important thing there was that, as you can see, if you can see, no concerns, 228 out of 237 authors. So there was like over 90% of authors, there is no problem. Most people are honest and in sharing their conflicts of interest. However, in my assessment, there is no room for error for even one person not reporting their conflicts of interest. And so this is my thoughts and disclosures of conflicts of interest. First thing, we always talk about financial conflicts of interest, but there are also intellectual conflicts of interest. The disclosure system has to remain an honor system. We have no way to police researchers around the world in where they're receiving their money from, right? We have no way to know that. It is an honor system, but what we have done is that if we find there is a violation of that honor system, we will have strict sanctions on that author. They will not be allowed to publish, will publicly reveal that they have failed to their conflicts of interest, and things such as that. And I also want to say that perception of conflict of interest is actually as bad as an actual conflict of interest, even though, and so as a result of that, the ASN journals, we require the authors to disclose all financial relationships. We don't want the authors to judge whether the relationship is relevant or not. We want you to tell all the relationships you have, and we want the readers to judge. Let the readers decide whether they feel that your opinion in that work or the way you present the data has been influenced by the conflicts you may have. The next thing is registration of clinical trials. Clinical trials, I'm not going to go through all of these, but just the first bullet there, the definition of a clinical trial is actually very expensive. Clinical trial is you're assigning people to an intervention, and you don't have to have a concurrent control. And you're studying the relationship of an intervention with an outcome. And so, you can read or whatever is available, but for example, we have this paper that is in press about a very, and I'm not going to divulge the details, they had 6 patients with a certain condition with AL amyloidosis actually, where they gave an experimental treatment. And it needs to be registered ahead of time for it to be considered in any high-impact journal. So the ICMJE is International Council of Medical Journal Editors, is that all trials should be registered prospectively in a public clinical trials registry before the participant is enrolled. If a clinical trial we receive has not been registered prospectively, it will not be considered in an ASN journal. It will not be. And there are 18 such registries that I looked at in 2024 that are available around the world where people could register. The next thing is that data sharing is now expected. So if just because if you collect data and you publish it in a journal, it is your responsibility to make the data available to other researchers that are working in the field, whether it is for meta-analysis, whether it is to do additional analysis. It is an expectation if you publish it in an ASN journal. It started in 2007 with genomic data, and there's this website that the NIH operates that's dbGaP, and all genetic data is publicly deposited in dbGaP. Then it started in clinical trials with the ICMJE requiring data sharing for clinical trials. Now we require at least a data sharing statement. The only exception we make is if the innovation is proprietary. For example, it's not in the public domain yet, and people want to maintain that. In the absence of that, if you have data on 2 mice, you have to share it. If you have data on 2 people, you have to share it. You have to be open to sharing it with other researchers. Just trying to advance this. Can you advance it for me? It's stuck. I'm towards the end of my talk. Right, what about AI and journal publishing? You know, there's, can you keep on advancing it for me? Just a little. It's just agla. So you know, just go back. I think this may have, the battery may have died. This is not working. So what about AI and journal publishing? There is a lot of interest in AI, and people can use AI to write a research paper. People can use AI for peer review. And then there is all of this conversation how AI is going to replace physicians, and all the work in diagnosing and treating will be done by AI. I'm not going to address the second. Can you just go on? Next. Next. Just populate the slide. There's one more. Just one more. I think there may be one more. Yes, that's it. Yep. And as you can see, this is generally what is widely accepted around research. First is that even if you use AI, they cannot be co-authors on that work. If you use AI to create content or assist with writing or editing of manuscripts, you have to disclose that use. There are people, particularly in basic science, that use AI to generate images, and they have to report that. More importantly, if I'm an editor or a reviewer, I cannot upload that into an AI like ChatGPT to get input on its review. And the reason is ChatGPT is a public domain, and the manuscript that we are evaluating is confidential. It is not in the public domain. So putting it into ChatGPT or any of these tools is putting it out in the public domain before peer review has been completed, and that is completely not allowed. Next. All right, I think I have 2 slides, and then I'll be done. What has also happened in terms of the movement in editors for journals across biomedical disciplines, including in nephrology, is to our commitment to train future editors. And so for the first time now, we have a harmonized program across the 3 ASN journals. And as you can see, we have, 14 people from around the world that are in editorial training at one of the ASN journals. I don't have a picture, but Candile, who's listed to be in the USA, she's actually from Karachi. So she and I talked briefly before I was coming here. She's from Dow Medical, is where she did her MBBS. Now she's at New York University. But as you can see, there are people from around the world that are junior associate editors. Go on, next. Just skip the slide, just go on to the last slide. This is just showing that this is a very highly regarded program. Let's go on. All right, this is my summary. Just populate this and I'll just read it out. So what I've tried to say in the last 20, 30 minutes is that authors have more and more choice of journals to submit their work. beware of predatory journals. Journals have to be solicitous of authors on one hand, while developing consistent standards for rigorous peer review. Journals have a responsibility to increase transparency to our readers, to build and maintain public trust. I can see how that is sometimes annoying and aggravating for authors, whether it is about data sharing, whether it is about disclosures, or things such as that. And we also have a responsibility to better train the future generations of editors in ways that none of us were trained previously. If you just go on to the next slide, it's just my solicitation to invite you all to come to Cape Town for the next meeting of ISPD, which is going to be held in the end of September. Thank you for your attention.
Thank you, Professor Malhotra. I just have one quick question for you, please. Thank you so much. So, with what you have presented, it seems that there is an inherent element of publication bias based on where one comes from and the ability to pay for a peer-reviewed paper which has been recommended for publication, but somebody cannot pay for it. So, should there be some way of addressing high-quality papers and having some kind of a shared sponsorship by ASN journals or others? In your view, isn't that something that would increase the integrity of science and our belief that it's all an equal world and there is some kind of an equity out there?
Yeah. Well, I mean, there are many ways to answer this question. The first thing I would say is that if you are focusing on publication charges, let's say as being a barrier, for ASN journals and for biomedical journals generally, at least for low-income countries, I don't know about low-middle-income countries, those charges are waived. So it is, the challenge, of course, in low-income countries particularly is on a day-to-day basis, they're dealing with so much else that focus on what meets the threshold for high-quality science, there is no room and space for that. You use the phrase publication bias, and there's no question that there is a bias towards publishing positive results rather than negative findings. And we have to guard against that. And are we perfect in doing that? No. But a well-done study that is negative is equally important as a study that shows benefit of a treatment. Nevertheless, there is real publication bias that exists in this regard. And the final thing is, in terms of the one thing that comes to mind, both in my role as the president of ISPD as well as the editor of the journal, so we have created a room and a place for global experiences in Kidney 360. And so we have global health perspectives where short articles describing kidney disease care in different parts of the world, there is an article on any one of them every issue. And so there is that experience to be shared that is more like a public policy rather than a clinical research experience. So for example, the conversations that we had about peritoneal dialysis in Pakistan, that could be framed as a very nice global perspective, and Kidney 360 will be very receptive to that. So your point is well taken. There are some ways forward there, and that's not perfect, but I appreciate your comments.
Thank you, Professor Malhotra, for your candid and inspiring reflections. The greatest threat to global health is not disease alone, but delayed action. The upcoming talk addresses the global CKD burden through the lens of health system, prevention, strategies, and equity. It is an honor to invite Professor Mahdi Yaqub to share his insights with us today on epidemic of chronic non-communicable diseases and CKD in developing countries, lessons from the Western world.
This is forward. Right, thank you. Thank you very much. Thank you again for organizing committee to invite me. I have got no conflict of interest, by the way. To learn something today, one thing I've always said, that I won't do anything where I'll have to make a slide to say I've got conflict of interest. And I have remained clean up till now. I don't know what will happen in future. So I will just start with the very sobering statistics. And particularly it is meant for the trainees, because we have created the mess, and you will have to be looking after this. So we are in the epidemic of chronic non-communicable diseases. When I was growing up, very country where I am standing, communicable diseases were the commonest cause of death in this country. That landscape has changed. Based on this, we are talking of global figures here, okay? So this is how we defined. Chronic diseases are those who have stayed with you for 3 months, and they cannot be prevented by vaccines, so there are no vaccines for these conditions, and cannot be cured by any medications. You have to live with them. That is the simple definition of chronic non-communicable disease. In 2015, according to this Lancet, very high impact factor journal, globally, remember this is pre-COVID, 57 million people, 57 million total deaths in the whole of the world. 63% of those were because of non-chronic NCD, which is non-communicable disease. 63%. 10 years later, I would have expected it to either stay the same or reduce, isn't it? We are doing something. The whole world is woken up that this is a problem. Let's move 10 years later, 2025. Instead of 57, we now have 64 million deaths. And of those, almost 75% now. So from 63%, almost 75% of the total deaths are due to NCDs. So instead of getting better, we are getting worse, at least in the last 10 years. Let's come to your local population. And this is very relevant as I progress through my talk, because you have still got the chance not to go to the Western route. Everything made in America and UK is not good. Sometimes things made in your country are better. So I'm going to emphasize on that. What we made the mistake of making it, please don't go that route. So I'm coming to that. Let's start with this. In Pakistan, 2025, I know the data from Pakistan is very hard to get, but I go to WHO's and as much reliable data set as I could. But this is what the data came out, that in Pakistan, 1.7 million deaths, 2025. 1 million, which is around about 55%, 20% less than the rest of the world, 55% were due to chronic non-communicable disease. So you are better than the rest of the world when it comes to NCDs. Why they are very important? Because remember, for health economists, the cheapest patient is the dead patient. It is the person who is living with disability, like on dialysis, etc., they are the most expensive ones. For a health economist, yes, he will set a chair, he will hold your hand, doctor, I'm so sorry. Deep down, he's very happy. It's less expensive. But what's hurting the global economy is this, that in 2015, sorry, how can I go back? Yeah. 2015, 1.5 billion years of healthy life productivity was lost. If this trend was to continue till 2030, the total cost to the global economy will be $47 trillion. And this is where the world economy is now taking a note. It hurts if it is expensive. Patient is not expensive when he dies. but he's expensive if he's living and he's losing his productive years. Now I'm going to go into a very different topical issue which is preoccupying the Western world, and that's called immigration. Every day on the news, we have got this news that the people are coming by small boats, or in America crossing the Mexican border, is constantly in the news. So let's try to rephrase the whole CKD in that context. So I said that let's put all the global patients who have got CKD into a country, and we will call it CKD country. And if we were to do that, that will be the third most populous country in the world. The most populous country now is India, overtaken China. Second is China, which is close second. The third country would be CKD on that one. We have got 850 million people living in this world with some form of CKD. And the predictions are that by 2050, if this trend was to continue, CKD, which is we look after that, we are the owners of that country, it will be the second most populous country. Now again, let's go on to the migration. This is the country which we are talking about. We look after that. We are the CKD looking after that country. There are 850 million people living in there. Before we started, right from the beginning, the indigenous population, like Red Indians in America, right? The indigenous population of CKD, when I was growing up, was around about 10% of this, which involves PKD, IgA nephropathy, which are inherent to the kidney. They are primary kidney disease. That is the indigenous population of this country. All the rest are immigrants. They are coming in small boat. So this patient is diabetic, gets a little bit of proteinuria, is put in a little boat, comes to CKD. High blood pressure, half of them don't even know that they've got hypertension. Proteinuria, come to them. Now, if we are governing this government, we should do what the Western leaders are saying. We should stop these boats or put a serious tariff, as we have been hearing, that if you send any patient from there, we are going to charge tariff for every person you send us. Because that will make them to look after their patients better, because if they don't, then they will have to pay a tariff to send that patient to CKD. That's the only way you are going to reduce the population of CKD. There is no other way. Sadly, as we speak today, once they get CKD, as I said, it's a chronic non-communicable disease. It cannot be reversed. You have to live with it. And it is the final point. What will be the healthcare budget if this imaginary country is a true imaginary country, CKD? What will be the healthcare budget of this country? We know from data that by definition, 30 to 40% of this population will have diabetes. Just diabetic kidney disease bill globally is $1.5 trillion, just diabetes. So if I was to extrapolate that, the healthcare budget of this country should be between $3 to $4 trillion. And remember, they are all chronically disabled. They won't be working to give you taxation. Do you want to imagine that scenario? You need to do something now, wake up. And to make the matters worse, which is never in the news, this is the global map of the prevalence of top 10 psychiatric conditions. I know in this country still, if somebody has got psychiatric disorder, you go to somebody and get him depossessed. I know that. That's why you don't come in the statistic. How come that India, Sri Lanka, Pakistan are green when it comes to mental health, when all the developed industrial countries are in red, which is where the highest prevalence is. The only way I can explain is we don't even know how many psychiatric patients live in your country. That is the only way. Don't tell me that depression and anxiety is not common in your country, but they don't appear in any statistics because you don't have the data to share it with the world. And that also is chronic non-communicable disease, psychiatric disorders. And this is the beauty, that all what I said, 80% of every comorbidities which leads to CKD is preventable. They are modifiable. You can prevent it, but these will not cure the condition. You have to act before the crime is committed. So let's go back and retrace my slide. 850 million, total number of patients with end stage on dialysis, that doesn't include transplant, is 4 million in the world, approximately. For a global population of 8 billion, 4 million doesn't sound much. 90% of the dialysis patients live in high and high middle income countries. The population of high and high middle countries in the world is approximately 2 billion. 75% of the people have got no access to dialysis. And when we talk about equity in healthcare, this is the most gross, overt health inequity you can see at the global level. And let's go from my country where I live, which I call my home. In my country, which is UK, the life expectancy of an ordinary person is coming to around about 82, 83. We should be celebrating, isn't it? We are living 82, 83. But the real message is in the line underneath. What is the healthy life expectancy of a UK citizen? And by the way, that applies to America as well, Raj. And it applies to every Western country, except Japan. Around 60. So every UK citizen, on an average, lives the last 2 decades of his life with chronic illness. We are creating a sick society. And if anybody wanted any proof of that, COVID proved it. COVID got rid of all these chronically ill patients, and the highest mortality was in the Western countries. It wasn't in Pakistan. It's not that you were very good, because your population is young. Let's start how it all started. I've got time. Paleogenetics is another field by which you do genetics of the old mummies, and you can find out a lot of tracking, and that's my passion. Paleogenetics suggests that the humans, you and me, came to grace this planet 300,000 years ago. So if we believe the scripture, Adam and Eve came on this planet 300,000 years ago. Up till that time, there were two-legged people then, Neanderthal and Denisovan. They were there. We were better, and we outcompeted them. And possibly we also interbred with them, that most of the people you are living, at least 4% of your DNA today is from Denisovan. And those who are living in Europe, 4% of their DNA is from Neanderthal. So it means some admixture happened 300,000 years ago. We have got the data going up till 10,000 million about the average life expectancy. Average life expectancy 10,000 years ago was around about 25 years. You were lucky if you celebrated your 26th birthday. And that pattern was to continue till the turn of last century. End of 18th century, which is 1899, the life expectancy has risen by 2 years, 27 years. 10,000 years, you have got 2 years of increased life expectancy to show. But the population grew. At the turn of 10,000 years, we were 10 million. We already became 1 billion. Population grew. Population grew in 10,000 years by almost 1 billion. And that was only smartness. We learned to live together. We started looking after each other. We developed, rather than in isolation, hunting together. Everything was community. Community led the population. Otherwise, up till that time point, a hunter will, an animal will come and eat the whole golem. We learned how to safeguard us against. That was the community spirit. It just did not increase the life expectancy, but our population grew. So community spirit took 10,000 years to get us from 10 million to 1 billion. Come Industrial Revolution. And look at the population. In 100 years, from 1 billion, we have become 8 billion. And during this time, our life expectancy also increased. It's not that we were increasing the population. So it means that in the last century, the population grew by not community spirit, that already finished. We were nations. We were now killing each other by countries. Empires were coming in. We now grew by 7 billion in 100 years. That got to be for some other reason. Industrial Revolution. And there is a very good relationship. The wealth of the country increases, the life expectancy increases. If you have got a higher GDP, as is in Japan, USA, Luxembourg, you live longer in that part of the world. If you happen to be unlucky and get born in Sierra Leone, this is the bottom. Can you imagine, in this 21st century, we have a country which we created. People who live in Sierra Leone, the capital of that country is called Freetown. Do you know why that was called Freetown? The people who were liberated slaves, who lived for 500-600 years in UK and Western countries, when slavery was abandoned, those guys were put back in the boat and sent to this new country to create a country which was called Freetown. Now you are free to do whatever you want. A country, a person who has lived 500 years dependent on his master was given with no resources. That country has got the shortest life expectancy in 21st century. And that is how it is explained. It's called epidemiological transition. The hypothesis, which was before called demographic transition, is now null and void. Epidemiological transition is the way to explain what happened. And what it shows that as the population grew, or as the wealth of the country increased, the sanitation got better, overcrowding got away, vaccination came in, antibiotic came. That's what all happened in the last century. That got rid of all the infections. So a person who was going to die at the age of 20 with some polio or some cholera, that is now no longer the problem. That person is now living not beyond that time when he was supposed to. Now he is going to develop something. With apologies to my female colleagues, I always say life is a sexually transmitted disease. It always ends in death. You have to determine what the date I put on your death certificate and how. It's in your hand. So in the first 50 years, when this industrial revolution happened, this is UK data, by the way. This is all UK data. How did we go in the early part from 29 years or 27 life expectancy, where we were going in the first 50, 60 years of 19th century? What happened? Infections is wiping out. You can see. Straight away, infection is on its way down. Oh, sorry. God, I just clumsy. Infection is going down. These were replaced in the first wave. Can you believe it? Tooth decay was the commonest cause in the first decade of life during this transition period. Then came the fast cars. Road traffic accidents came in for the second, third decade. Then came my favorite, obesity and diabetes. Remember, before 19th century, you hardly saw diabetic, because they bloody did not live long enough. But now we are overfeeding them. Then came a peak, you can see, coronary heart disease and hypertension. And we later on realized, thanks to this new classification of CKD, that this is in fact sandwiched, this peak between these two. If you live and survive coronary artery disease, then cancer is waiting for you. If you survive cancer, then dementia is waiting for you. This is what happened to our population, and is happening during this transition. And that was the high stationary period was when nothing was happening, early expanding period. We are now in the low stationary period, and all the predictions are, it's already happening in few countries, that the population of Germany is declining. Okay? Some states in America are already declining. At a global level, predictions are that come 8,000 years, the world population will fall. If you don't believe me, paleopathology and imaging shows that there were people who lived beyond 25. That was the mean age life expectancy. So what about those who were, say, 40 years, 50 years in pharaonic time? This is the mummies dug out from pharaonic time. And when you do EBCT on them, those who already were 40 years and died at 40 already had coronary plaques. It's not what we are doing now, that disease. So if you live long enough, the chronic conditions were happening even then. And if you were to follow what is happening in Europe, look at it. I think that's frightening. That is really frightening. That up to 33% of the people above the age of 85, or even above the age of 75, have got chronic kidney disease. The longer you live, the longer CKD will happen. Yes. The sad thing is, because one of my basic science research is aging, and I'm a part of an aging biology group. And we discuss every 3 months what is it. And the sad thing I would like to say, from what I see here as a clinical scientist, that my scientists, we believe that the person who are going to live up till 150 years are already born in last decade. A person, there will be few, they will live up to beyond 150 years. They are already born based on their genetics, epigenetics, we can predict that they will live beyond 150 years. Will the kidneys of those people able to sustain life at the age of 150, which is my role in that group? Answer is no. Because kidneys are not designed to live beyond 125 years. Said. So if you live beyond 125, you should all be on dialysis. Because nobody will dare do transplant at that age. I come from East London. And you can see we are the most socially deprived part of the city. And this is a message for all of you who are desiring to come, or those people who are coming in boats, that the immigrants, when they come to a country, they live in these ghettos, which are the poorest part of that country. It's called ghettoization with these immigrants. And we have got more than 1 million immigrants, and this is how they live. These are the houses, state-owned houses, unemployment, poor health, everything we score the highest. Every bad social deprivation we score the highest. And when you are poor, you go to unhealthy styles. And this is the most important and disturbing thing I'm going to tell you today. Okay? If you forget about everything what I said, what I'm talking about is man-made disaster. And this is why. Look, global fast industry and processed food sales per year is more than $1 trillion. And it is growing. And the predictions are that this sales will outperform the second line, which is global pharmaceutical sales, which is also $1 trillion, greater than $1 trillion. Both of them are parallel, going up. Okay? And you know what fast food industry does. I have not included alcohol and tobacco in that. If I include that, then the sales of that will be more than $2 trillion. I've just kept to the fast food. And these are the top 10 fast food companies in the world. And these are the top 10 pharmaceutical industries in the world. They are not owned by Elon Musk. They are not owned by one person. They are owned by the funds or your bankers where you put your money. The money spare cash is funded and it's put in these businesses. Okay? That earns you the interest. And I know in Pakistan, interest is forbidden word, so you call it markup. It's the same thing, but it makes you feel better. That's what it is. Okay? Sadly. So who funds them? Hedge funds. It's disturbing for me to say that our regulatory body in UK got found out and called GMC. So if you apply to come to England, you'll have to get a license to practice in hospitals or primary care, called GMC, General Medical Council. We have got Royal Colleges, and we have got health insurance company, which is a big business in America, less so in our country, in UK. I went digging, and guess what? These companies, which should be the safeguarders of our health, they have got their spare cash funded in these companies. Now explain that. Where is the ethics? My organizations, their spare cash is stuck up in this. And also in pharma industries, which are making the drugs, which is very, very expensive to reduce your obesity crisis. Now explain that. Where is the ethics? That you have got a company who has got shares in this and also shares in this. A company which is creating obesity, hypertension, ischemic heart disease, and the same company is funding the drugs, which is companies who is making the drugs to treat them, not to prevent them, to treat them. Remember, focus is not on prevention. If you prevent these, your business collapses. Trillions of dollars go down the bloody pen. Why aren't we having a regulation? Have anyone thought about it? There is always a third government. We are very proud to say that we are democracies. We are not. We are not democracies. The MPs, particularly in America, and senators, everyone is funded by a business. Are these MPs ever going to pass a bill which will make this illegal? I rest my case. So that is the lesson for you guys. That take a fight on. Those who don't believe me, the impact of this fast food, this is the statistical data from my own city where I work in East London. At Millennium, our Jubilee line finished at Westminster, which is our Parliament House. And as a gift to the Londoners, the East London, which is the poorest part, was given this gift by the government that we will extend Jubilee line, which finishes at Westminster, extend it all the way to East London. Because still underground is the cheapest way of commuting in London. What it unearthed as the data is very, very striking. Every station you go eastward, in East London, your life expectancy drops by 1 year. Directly responsible, a proportion to your poverty index and fast food consumption. That's why, Professor Fenn, we are always short of beds. Because we are looking after these sick people who we have created by making them live in those ghettos with no hope for the future and bombarding them with buy one pizza, get one free. A special offer of KFC, today instead of 4 chicken legs, you will get 12 for the same price. Whenever you see those offers, think of what I've said, that you will pay that in form of GLP-1. They are still making the money. So in UK, I said proudly, we spend around about 188 billion pounds to provide care to the sick. And if we were that serious, we would put money toward prevention, isn't it? I said, once you live with this, you get CKD, it's it, done. Label. You prevent somebody going to CKD. How much money we spend of this total budget? 3.6 billion. The preventive, direct preventive cost we are paying to prevent and reduce the cost of this 188 billion is a tiny fraction. And sadly, most of this money also comes from research grants. Remember, everything which glitters is not gold, even though our women colleague will think so. If you go into a gold shop, remember everything what glitters is not gold. At the moment, these 5 pillars have been sold as gold for CKD, cardiovascular hypertension. Even now they say that the fatty liver is prevented by all this. Based on what Raj was saying, clinical trials, prematurely terminated, sir. We don't know the long-term data. Because first 18 months data was so good, it was ethically not allowed to allow somebody to stay on placebo. And they have weaknesses. Everybody knows. But anyway, we have been sold. These have become where the whole glitter is. And in this glitter, we have forgotten about the real gold, which is not glittering. Sometimes the gold doesn't glitter. And this is the gold. Because it takes effort to change the behavior and the habit of the person who's sitting in front of you. Okay? If you take care of these 8, and I would say social deprivation, which is a big problem for us in Europe, and we've just recently about to publish that depression is a very potent source of inflammation, irrespective, by transcriptome work. I don't know how many people are tobacco smokers in your country. Because we have banned all the advertisement and all the things in and always happens that when all the dirty industry finishes from West, we pass it on to the developing world. all our recyclable shit, which we collect, we don't recycle, by the way. In UK, 10% of the recyclable stuff which we collect is only recycled. 90% is going into a landmine somewhere in Pakistan, Sri Lanka, Maldives. And all of them are evidence. There is evidence. We ourselves have shown that if you were to reduce the salt in your CKD population, is equivalent to 2 antihypertensive agents on 24 hours ambulatory, not by office or what, 24-hour ambulatory blood pressure. Now this is Pakistan, and that is scary. At the moment, I said that you are just about to enter what we entered. We are already 100 years down the line. You are at the early phase, which is called early expansion. Based on this data, the average life expectancy in Pakistan in 2023 is 65 years. Almost 17, 18 years less than UK. So it's a lottery. If you get born in London, you tend to live longer. If you live in Pakistan, it's a lotto. You stood upstairs when you were being created in the wrong queue. You came to Pakistan, you'll bloody live 10 years, 20 years younger, or 20 years less. Sad, isn't it? This is 21st century we are talking about. But one thing is for sure, that our women still outperform the men when it comes to living. The future of your renal medicine, from what I looked at yesterday, even they will outperform you in nephrology. Our female colleagues, and I clap you. You are really doing proud. Okay? Don't take any shit from anyone. You are the future. And this is what's going to happen. These are the predictions that come 2015, which is, we are talking of 25 years from now, from 63, your age will be 76, life expectancy. It's still less than Europe, but you are coming close. And in this growth, you are going to go chance to prevent this. This is the crucial time for Pakistan. That if you don't take any action now, your population will go be around about 80, and last 2 decades, like Europe, will be living in chronic ill health. You can't afford that. You can't afford that. This is what you have to prevent. And you have to learn from Japan. I said, except Japan, that is the truth everywhere. In Japan, the healthy life expectancy is around about 78 years. Life expectancy still is 82. But healthy life expectancy is 78. Only last 4 years of a Japanese life is spent with some illness. Because they did not do what we do. They stuck to their cultural practices. They still go out in the morning, an 80-year-old, and will be doing all the yoga and all the karate and all this. They eat very sensibly. They did not go into the fast food. Their delicacies are healthy foods. They eat even raw fish, so you don't have to put oil on it to make it oily. This is the proof I'm telling you. And this is the key. That today, this was the high stationary phase, we have now moved on. You are here. This is my slide when I was talking to India. Egypt, Kenya, and India, you are going through this phase. You are expanding. Your total population is still increasing, you see? Your infection rates are going down. Your birth rate has now stabilized. This is what's happening, I'm just telling you. When you go into this phase, which is called less expanding phase, I've been to Brazil. I'm a visiting professor of Brazil University. This is happening Exactly what I told you is happening there. The same road traffic accidents, the same dental caries, the same
Sir,
obesity.
5 minutes remaining.
Like US, Japan, we are in low stationary phase. We have got rid of all this, now we are here. And we are now living the price of last 2 decades of our life with chronic illness. If you want to prevent last 2 decades of your population to live, act now. And this is the only area where you will be, by cutting down all the fast food, eat sensibly, and adopting the lifestyle which is the goal but is not glittering at the moment. That 8 essentials of life is going to prevent you the disaster which we are going through. And the proof is Japan has done it. That if you're looking for a proof at a population level, where I'm again a visiting professor at Toho University, I go there regularly, and I can tell you, chronic illness in elderly Japan is not there. They are the fittest 75 years I've seen. And it's all down to healthy lifestyle. The only thing which is hurting Japan in the last, even they can improve to 80 years, healthy lifespan. You know what is happening, sadly? Social isolation. They are the most community. They live together like you guys live, joint family system. But now, one partner is dying and another partner is leaving. And the children have moved away because they can't afford a big house in Japan because of the economy. And that social isolation is preventing them to bring life expectancy and healthy life expectancy same. It can happen. We have done all the prediction. We have done all mathematical modeling. So, my friends, with this depressing note, but some optimism, that don't make the mistake what we have done in the West. Act now. Put some serious taxes on fast food industry. Every Coke bottle you buy, I don't know it will, should have 100% tax. Every pizza you buy should have 500% tax. So only those people who want to do it, they suffer, but an ordinary mug who is living away from that, who can't afford, doesn't have to pay to look after those people who have abused their health. And the tax revenue you get from all this taxation, reinvest in the health, but not curing dialysis, prevention. We know that works. When we put the tobacco tax in UK and banned smoking in public areas, the rate of smoking has plummeted. But see the greed of the corporate businesses. We have replaced that with vaping. Same company which was making cigarette are now rebadged and doing the vaping. The vaping sales is more than tobacco in UK. Okay? And remember, vaping is not a saint. They have not been long enough for us to know what that does to your health. So there are a lot of messages, and I wish there were some health planners in this audience, or those who have got influence on those people. And even if they're health planners, they're so useless, because you are put as a planner because you are useless. Otherwise, you will be working for Elon Musk if you are that bright. You've got to be dumb to be working for the government, isn't it? I stop here with this plea. My ex-countrymen, please wake up for this tsunami wave which is coming. It's already upon us. I can see it on your shores. The only way to stop that tsunami will be to change your lifestyles. Thank you.
Thank you, Professor Yaqub, for grounding global experience into actionable lessons for developing countries. As a token of gratitude, I request Dr. Zahir Nabi to please come forward and present the shields of to our distinguished speakers, Dr. Edwina Brown, Dr. Rajneesh, Dr. Mahdi Yaqub, and Dr. Raja Farooq. Dr. Raja Asif. किसको बुलाऊं कहाँ से? I invite Dr. Azazman to present the shields, please. Dr. Rajneesh Mehrotra. Dr. Mahdi Yaqub. Dr. Raja Asif? No, we don't have. I think we all earned a cup of coffee. So the tea is served for the faculty adjacent this hall and for the delegates across the hall in the open area. Just grab your tea and get back because we'll be transitioning to the breakout sessions shortly. Thank you.
Hello, testing. Hello, please be seated. So can we get start the session? Please be seated so that we can start the session. Assalamu alaikum. My name is Dr. Zahidul Zahideen, and I am working as consultant nephrologist in Nescom Hospital, Islamabad. Today, I will be chairing this session, this scientific session of chronic kidney disease. Chronic kidney disease remains a silent epidemic with profound clinical and socioeconomic consequences. I invite our chair, Professor Sami J. Khan, and co-chair, Professor Halim, Professor Salman Imtiaz, Professor Ghulam Abbas, Professor Naila Asif to kindly take their seats. CKD of unknown etiology challenges traditional nephrology paradigms, reminding us that not all kidney diseases fits textbook definitions. This talk explores unanswered questions, environmental factors, and global lessons. I will invite Professor Eranga Vijayavikrama, who is an eminent nephrologist with extensive international credentials. He is a professor of clinical medicine at the University of Colombo and an honorary consultant nephrologist at National Hospital of Sri Lanka. He will walk us through the CKDU conundrum, why the cause remains elusive. Sir, please come.
Good afternoon, everyone. So thank you. First, I would like to thank Pakistan Society of Nephrology for giving me this opportunity to talk today. So this is on topic close to my heart on CKDU and why has the cause remained elusive despite 2 decades of research. So let's start. So as you're aware, since early 1990s, there has been a marked increase in the number of cases of chronic kidney disease identified by clinicians in certain agricultural communities. And this is predominantly seen in farmers residing in Sri Lanka and also mainly paddy farmers as well as sugarcane workers in Central America. And individuals did not have the traditional causes for CKD, such as diabetes, glomerulonephritis, and genetic causes. And if you happen to do a biopsy in these individuals, they classically have interstitial inflammation in association with tubular atrophy and interstitial fibrosis. This is classically described as chronic tubulointerstitial nephritis. And the disease was termed CKD of unknown etiology because the traditional causes were not seen and a potential cause was not identified. And there are many other names, including CKD of non-traditional etiology, chronic interstitial nephritis in agricultural communities, etc. So the disease was first reported in the 1990s in Central America. And as you can see in this map, the countries in the Central American region, starting from Guatemala down to Panama, including countries like El Salvador, Costa Rica, Nicaragua. These were the countries where the disease was first discovered, and now it's seen even in some parts of Mexico. And the disease affects predominantly sugarcane workers, but also seen in cotton and corn workers and shrimp farm workers. And it's commonly seen in men between 20 to 50 years of age, which is not the usual age you get CKD due to traditional causes. And in Sri Lanka, the situation was recognized similarly in early 1990s in the central part of the country, which is called the North Central region. And it's again seen in the male, predominantly in the male paddy farmers belonging to 40 to 50 years of age. And during the similar time period, the disease was also recognized in some part of India, first recognized in Udanam region in Andhra Pradesh, and then subsequently in some other parts of the country. But it's not very clear whether the disease is the same in all parts of the country, because some of these areas, there are inadequate facilities to investigate the disease further. So we are looking at the current situation, and I think after that, so many other places, there have been individual case reports, case series, and small studies coming out, so showing that the disease is not confined to these areas. So and we haven't yet seen Pakistan depicted or highlighted in this map. So what is causing CKD? So this is the main question that we are trying to answer. And there are many hypotheses put forward over the last 20 to 30 years. And the main possible causes were kind of considered, divided into two main groups. One is heat stress, where the patients exposed to repeated high temperature and in association with metabolic heat generation in the body. And this leads to some degree of kidney damage, and this is the hypothesis, which can occur even with or without dehydration. And this is considered to be the predominant hypothesis in the Central American region for this cause of CKDU. Then the other main group of causes is environmental occupational exposure to a toxin. And these toxins could be agrochemicals, heavy metals, hard water, fluoride, silica, and some other infections such as leptospirosis or hantavirus. So these are some of the put forward hypotheses for CKDU in that domain. And this is thought to be the predominant kind of cause, one of these in South Asian region. And not everyone in these regions gets CKDU, and therefore some predisposition to kidney disease also thought to be there in these individuals, and this could be a genetic susceptibility, low nephron endowment, and also low socio-economic status may be also playing a part. So why has the cause remained elusive over the last 2 decades of research? And that's the question I'm trying to answer, and I would like to, over the next few slides, I'm trying to try to give you some insights into this. So one of the main issues with studying chronic tubular interstitial nephritis, because CKDU is a chronic tubular interstitial disease, is inherent to this particular disease. For example, if you know that chronic tubular interstitial nephritis has a wide range of causative factors. There could be infections, drugs, toxins, genetic causes like autosomal dominant tubular interstitial kidney disease. So there's a wide variety of causes leading to same histopathological changes. So this has led to kind of this being a disease which is difficult to study. And most of the changes you get in histology are like non-specific, tubular interstitial inflammation with tubular atrophy, which is the final common pathway of most common kidney diseases. And also we don't have any specific marker to identify this disease, a urine, serum, or image marker. And also the disease is chronic. It's a long latency between the possible exposures and the clinical manifestations, making it a disease difficult study, a difficult model to kind of work on. So one of the main issues with regard to CKDU is the inconsistent terminology being used, which comes with the gray or non-specific nature of the disease. So current definition excludes early disease. So basically the disease is recognized when the EGFR drops to below 60, which is generally the cutoff for any CKD. And therefore this particularly miss the early stages of the disease. And also we need to understand that many alternative diagnoses meeting the CKDU definition and they may not be classically seen in the traditional CKD hotspots. Although they meet the CKDU definition, they may not be having CKDU, such as the diseases I've mentioned earlier, such as the autosomal dominant tubuloinsular kidney disease, late presentations of glomerular diseases. They sometimes meet these criteria, but they don't have CKDU. So this brings me to this particular slide where I would like to highlight what is CKDU and what is not CKDU. So CKDU is not CKD without a cause. That's something that we need to keep in our mind. CKD without a cause is very common. Any CKD registry, a certain percentage of proportion of cases you don't have a cause. And that's not because they have CKDU. That could be because the cause is not identified despite extensive evaluation, which are the truly idiopathic cases of CKD. And they could be, the identification of the cause could not be possible because of delayed presentation. And also there may be not enough facilities in centers to investigate adequately to identify the cause. So these are the reasons for not identifying a cause in a group of patients with CKD. In comparison, CKDU is a specific disease which is confined to specific geographical locations, and in these areas the disease is discovered in large numbers, where large number of people have CKD without a cause in a specific geographical region. And they classically have chronic tubulointerstitial nephritis on kidney biopsy, and there are other typical characteristics such as that this is common in young and middle-aged men, and they belong to lower socioeconomic class and engaged in farming and manual labor. So therefore this is important to first differentiate. So most of the time we fail to identify this distinction, and therefore we end up pooling everyone with CKD without a cause under CKDU, and that's one of the main obstacles to study CKDU. And most of the studies which have been done on CKDU have been limited to cross-sectional surveys of low EGFR. And they come with their own issues in interpreting these studies. So for example, EGFR equations used to are developed in high-income settings, and they have been not validated in most of the settings where CKDU is found. And for example, these CKD EGFR definitions have been poorly translated to sub-Saharan Africa and South Asia. And we use this cutoff of EGFR of 60 in most of these populations to identify the disease. But in most of these countries, EGFR of 60 may not be the ideal cutoff. So it may be even lower than that, because some of these populations, their normal EGFR threshold or normal EGFR ranges we don't really know. And there are equal issues with direct comparisons of urine ACR between populations. For example, 24-hour creatinine production may vary depending on the body composition. So if you have a small body composition, small body habitus with low muscle mass, then your urine ACR may be erroneously low. So this could be a problem. And source populations can vary, making the comparisons difficult, because studies have been done in different populations, sometimes on populations as a whole, or sometimes in high-risk groups. So, such as certain occupation groups. So therefore the prevalences, incidences might be very misleading. And also there could be methodological disparities in case identification. For example, we know that KDIGO definition says that the CKD has to be confirmed with a second test after 3 months of the first test. But in most of the studies that have been done, this has only been limited to one test. So this is classically shown in this particular study published recently in the Lancet Regional Health. This is a study done in Tamil Nadu in South India. So where they looked at 5 climatic zones. Basically they divided the Tamil Nadu state into 5 climatic zones and looked at the prevalence of CKD in this region involving the agricultural workers. So I'm not going to detail about the study, but the most important thing is about the prevalence. So if when they did the first one-time measurement of EGFR less than 60 was found in 17.4% of the population, but on repeat measurement, the figure dropped to 5.3%. So So therefore, you realize that the true CKD prevalence is much lower than the reported prevalence on a single measurement. So this may be also playing part in sometimes overestimating prevalence of CKDU in certain populations. And this is another study which was done in Bangladesh in a rural area, and which highlights how the CKD identification affects the causative factors. Now here the identification on the left hand pie chart, you can see that on this side, you can see that the CKD etiological factors on a one-time measurement, you see that suspected CKD is 59%, but when you do it as a two-time measurement, it goes down to 23%. So this highlights that depending on how you confirm CKD, your possible etiological factors or CKDU prevalence may change. Then there's some school of thought that CKDU is a multifactorial disease, whereas there may be not maybe one single cause, maybe all these causes may be contributing to a lesser or greater degree. But we need to understand that. 5
minutes remaining.
Yeah, we need to understand that most of the diseases that we know have of multifactorial origin to a greater or lesser extent. But most of the epidemics we know have a single cause contributing to the epidemic, such as smoking in lung cancer and H. pylori in duodenal ulceration. And this is mainly because of this particular model that we need to understand, is that you have the initiating factors as well as exacerbating factors. So in CKDU, sometimes the initiating cause may be well before we actually identify the case. So initiating factor may be hidden, and we basically look at the exacerbating factors when we are trying to study the disease, and we sometimes mistakenly identify exacerbating factors as the cause of CKDU. And here is a classic example of hypertension being identified as a causative factor. We know that glomerular disease can lead to CKD, but they can also cause hypertension, and sometimes you end up thinking hypertension is the cause rather than the result of glomerular disease. And same type of modeling can be thought of for a CKDU as well, where some unknown exposure may be causing CKDU, but we are looking at the exposures or exacerbating factors and maybe identifying them as the cause for CKDU. And then finally, there are difficulties in identifying the disease onset has become a problem, because we know that disease onset is an important factor, because we can identify the initiating factor will be very closer to the initiating time point. But as I told you earlier, it's very difficult to identify the disease onset in CKDU because we don't have an easily measurable biomarker, we don't have an imaging method, and also it might take some time for meaningful eGFR changes to occur because of losing the renal reserve. And kidney biopsies are also not very helpful in CKDU, because most of them we do at an advanced stage where these changes will be non-specific, and there's a lack of signature histopathological lesion to identify CKDU. So I'm going to run through these slides pretty quickly, because this was some time back, few years back, this was published in Kidney International, where these dysmorphic enlarged lysosomes in proximal convoluted tubules in CKDU patients were thought to be a signature lesion. But subsequently, it was found that these lesions were also seen in many other kidney diseases, so this is now no longer thought to be a signature lesion. Then, and also there are potential problems in identifying the exposures, because most studies depend on self-reported exposures, and these are subject to recall bias, relies on individual knowledge of an exposure. And biomonitoring, which is more accurate, is subject to errors of sample collection and analysis, and intermittent exposures can be missed in these type of situations. And exposure of interest might be a factor not yet considered, so therefore we might not be checking for that. Then, and on final side, is how we can overcome. So in realization of the difficulties and challenges in identifying, identifying the cause for CKDU, we might have to find a way to overcome these difficulties, and these are some of the suggestions. And one thing is we have to avoid inconsistent terminology and specifically stick to KDIGO criteria to identify or detect CKD. avoid pooling cases of all cases of CKD without cause as CKDU in low CKD prevalence areas, recognizing the limitations of EGFR and UACR comparisons between and within populations, incorporating a model with initiating and exacerbating factors rather than multifactorial, and identifying novel biomarkers to identify the disease onset, and looking at both all epidemiological, clinical, and molecular biological studies in coming to causations, and then interventions aimed at ameliorating, initiating, and aggravating factors should be supported, and that might give indirect evidence for the causes. Thank you very much.
Thank you, sir, for shedding light on one of perplexing, complex nephrology challenges of our time. We all know that stone disease is recurrent, preventable, and often underestimated. A structured metabolic evaluation can significantly reduce recurrence and morbidity. I invite Professor Stanley to speak on metabolic workup for kidney stone patients. Dr. Fan is a consultant nephrologist at Barts Health NHS Trust and the Royal London Hospital. He has contributed a lot to developing ISPD guidelines for the treatment of peritonitis. Sir, stage is yours.
Right, so thank you to the organizing committee for inviting me. It's a great pleasure to be here. Okay, so I've listed my disclosures, but the real disclosure is that actually I don't know anything about metabolic stones. I never looked after a patient with metabolic stones until about 2 years ago when the local urologist started referring me patients. So if you're tired and you want to have a short nap, now's a good time to have it, okay? So when I was started to get these referrals, I turned to this publication, which I would recommend, because I carried it with me at all times. And it's a very comprehensive view about how to manage these sorts of patients. So I thought, well, okay, since I don't know very much about this condition, maybe I should just read through it. But you can't see it. It's 120 pages long. I've got 20 minutes. I've been told to speed up. So by now, I need to be on page 30 or 40. So clearly, I'm not going to be able to give you a comprehensive story about how to look after patients with metabolic stones, even if I knew myself, which I don't. Okay, so instead, what I'm trying to do is going to give you just 3, maybe 2 if time runs out, 3 cases, which I hope gives you a flavor of how I'm approaching these patients. And at the end, it'll be important for me to get feedback, and you can tell me whether I'm approaching these patients in the right way or wrong way. Oh, by the way, another disclosure, I'm sorry, all my slides are in SI units. I know you'll have to just convert them in your head yourself, sorry. Right, okay, so first case. Referred to me, a 45-year-old woman with a recurrent stone disease. So they're all coming to me after they've seen the urologist several times. So they've all had the sort of the standard urological care, the standard dietetic care that you would get in UK, okay? And they're coming to me, and stone analysis showed that it's predominantly calcium phosphate, although there is a component of calcium oxalate within the stone. Past metabolic history includes polycystic ovarian disease, gestational diabetes, twice in her 2 previous pregnancies. Kidney function was good, she's not acidotic, and that's her 24-hour urine collection results. So the first thing which jumps out to me when I saw her is that this was a collection of 4.2 liters. You know, that's a huge amount. I don't often see people passing 4.2 liters unless they're on tolvaptan. So the first question is just, how accurate is this collection? Okay, is this a complete collection? Is she passing even more and she doesn't collect everything, which is the usual case? Or is she over-collecting, trying to impress me that she's drinking a lot? Okay, so how can we calculate that? How can we estimate whether this is correct or incorrect? So there is a publication, okay, and so it's about done in Switzerland, Caucasian cohort on a Caucasian diet. So the first thing immediately that stands out to me is that, you know, I'm in Pakistan. it'd be great if we could have actually this data repeated within your own local community, so you can do this with your data rather than having to rely on data from a completely different background. But this data is very useful because they estimate what is the creatinine excretion, 24-hour creatinine excretion of men and women, and they even give BMI adjustments. So you can look at this graph and you can say, okay, you know, BMI of this much, I'd expect this much in a woman, 150 micromoles of creatinine excreted per day per kilo. Okay? And the implication they found is that only 56% of collections were accurately collected, and in fact in the elderly, incomplete collections were even less. So 67% were inaccurately corrected in the elderly. But how about my patient who I was seeing? Okay, so it's very simple. You can do the calculation, and essentially she was, according to her 24-hour collection, excreting 14.7 millimoles of creatinine per day. The data, if she was Caucasian, living in Switzerland, would suggest that she should be around 11. So it does suggest that perhaps she's over-collecting. Okay, maybe that she wanted to impress me, so she did a day and a half instead. So how do you then interpret the 24-hour urine collection? Well, if you go back, the two things that really stand out was calcium excretion in the urine was high. Okay, that's the upper range of normal for my laboratory. It was high, but it's probably not that high because she's over-collecting. Okay, so it's probably not 11, but probably something closer to 9 or so. But what it does mean is that the citrate in the urine, which already is low, is actually very, very low. So when I see this lady, the main issue I have is how to correct the urinary citrate. Maybe by increasing urinary citrate, I can reduce her risk of getting recurrent stones. So it's all very easy, you know, you just ask her to take, what is it we recommend? I think the guidelines would suggest potassium citrate. You know, I'm sure we've all tried that. Well, I haven't, I must admit. You know, I've read it, I've talked to patients who've taken it, and it's horrible, isn't it? It's bitter, you can't taste it. So it's very difficult to take, although this is officially the ideal treatment to improve low citrate in the urine. Not because the citrate which you take is absorbed and excreted in the kidneys. No, it doesn't work quite that way. Obviously, the citrate that's absorbed is metabolized into bicarbonate, and then it's because of the bicarbonate that you can increase your urinary citrate. Otherwise, of course, you're acidotic and you don't excrete this bicarbonate, so you have low citrate. So don't think that you have to give citrate. What essentially you have to do is to correct any acidosis. And of course, it does mean to say that in this lady who's getting recurrent stones, especially calcium phosphate with low citrate, you have to exclude renal tubular acidosis. And there was a lovely talk in the plenary session about doing genetic testing, and there was a Claudine 1 mutation they found in a family here. So, of course, that is something which we should be doing. But in terms of the management, in terms of the treatment, it's all much the same. Correct any acidosis. If you can, if the patient can tolerate potassium citrate, brilliant, but she couldn't. That's why she's coming to see me. That's why she's still getting recurrent stones. So if she can't tolerate potassium citrate, what's the next best thing? Well, sodium bicarbonate. Like I say, you don't have to give citrate. The whole point of citrate is to correct acidosis. We all give sodium bicarbonate to our CKD patients, so it is effective. Okay? The problem with sodium bicarbonate, of course, is the sodium load, which works antagonistically. So it's not as good as potassium citrate, but it's better than nothing. Actually, she was on potassium bicarbonate, but again, she couldn't tolerate it. Okay, so then, what's the next level? Okay, so now we're really reaching down. I'm giving you my experience, and you can tell me if you have a better solution. So taking potassium citrate is very difficult, but we all have taken fresh lemon juice, fresh orange juice. Now, the only problem is, of course, that's difficult to take unless you add sugar, but that's the downside. If you are able to tolerate citrus fruits, such as 3 freshly squeezed lemon juice in the morning, 3 freshly squeezed orange juice in the evening, that actually can correct the citrate quite well, can correct some of the acidosis. So that's what we've tried. Now, it's all very good to make a suggestion, but actually what then is important is to make sure that it's having its effect that you want. Ultimately, it's to reduce the burden of recurrent stones, but how else can you monitor? What other biomarkers can you look at to see that your treatment is having effect? And of course, we can measure urinary citrate, but doing 24-hour urine collections is very time-consuming. The patients don't like it, and as we saw, it's subject to error in terms of incomplete collections. So we monitor by using citrate to creatinine ratio. Now, one of the problems in calcium phosphate stones, of course, is that if you correct the acidosis and you make the urine alkaline, that promotes stone formation. So if we embark on these sorts of treatments, it's very important, again, to monitor urinary pH. So how do we do it? Well, we could do 24-hour urine collections, or we see the patients, we take their MSU. So I always send off a urine specimen. Now, this is an struvite stone, so I'm not really worried about the infection causing the stone. But what is important is this, where you have no pyuria, but you're growing. Okay? In other words, it's a contaminated sample. Now, if you do a 24-hour urine sample and you're expecting to measure the pH and it's a contaminated sample, of course, if the bacteria produces urease, that's going to affect the pH. So in this situation, where you suspect the patient isn't very good at producing sterile, uncontaminated urine, 24-hour urine collections for pH is a waste of time. So it does mean that we have to get good clinic urine specimens tested immediately before the contamination can affect the pH. So get yourself a pH meter for the clinic. Okay? And the other area, of course, which you can monitor is the blood. So maintain sodium bicarbonate between 21 to 28. Don't go above 28, because then there is the risk of causing extravascular calcification if you overdo the correction of acidosis or causing alkalosis. And what else? Okay, so polycystic ovarian syndrome, gestational diabetes, it all suggests that this woman also has a metabolic syndrome. Okay, and that's important. People with polycystic ovarian syndrome have a 60% increased risk of getting kidney stones. So don't forget this. Treat the metabolic syndrome, metformin, very useful. So that's case 1. So how about case 2? So actually quite similar. A 50-year-old male this time, but very similar kidney stone. Okay, a mixture of calcium phosphate and calcium oxalate. 24-hour urine. I haven't given you the volume. I'm not going to go through the calculation because actually this was a pretty good collection. Okay. What stands out? I suppose calcium excretion is high, phosphate excretion is a little bit high, but actually citrate is remarkably normal. Okay, in the blood, again, he has no CKD, very good serum creatinine, calcium level, phosphate level, all normal, alkaline phosphatase, which is total alkaline phosphatase, normal, PTH slightly on the high side, vitamin D, normal. Okay, so, you know, he's got hypercalciuria. But what else do I look for? So this is a young man. He's excreting calcium. So where's it coming from? Is it just purely dietary, or is it also coming out of the bones? So I always do a DEXA scan to measure bone mineral density on patients of mine. Okay? And I was quite surprised. He's actually a fit, energetic young man, but he's got very low bone mineral density. Interestingly, mainly in the spine. The femoral neck wasn't too bad, but a T-score of minus 3.8 at the spine. Okay? And just to highlight again, the things which you can measure, and that is sodium, okay? 186, that's equivalent of 11 grams of salt. What do we know? The WHO recommendation is 5 grams of salt a day, so he's over double the WHO recommendation. Although it wasn't a uric acid stone, he was definitely high in urate.
5 minutes.
Okay, so therefore, what treatment am I going to recommend for him? So the worry is that the urate may be precipitating the nidus for the precipitation of the calcium phosphate stone, so I gave allopurinol, salt restriction, no calcium restriction, because I'm worried about the osteoporosis, and I gave bendrofluoroside. But you in the audience will say, yeah, I know, Professor Fan, don't you know there's this study coming out from Switzerland again, which says that thiazides are useless in kidney stones. Okay, it doesn't reduce the incidence of kidney stones. And yes, you know, it's a very good paper, New England Journal, no apparent efficacy. However, the drawback for this study is that there's maybe a dose response. So they were giving quite low dose, and also the drug that they were choosing had a short half-life. Okay? Which is why when you go back, my decision was to treat, but to give as a twice a day. So don't give bendrofluoroside as a once a day drug because it has a short half-life. If you want to treat it, then do give it as a twice a day drug. Okay, but what else? How about the bones? So this is where it becomes a little bit controversial. He's very osteoporotic. He has a high PTH. I must admit it's unusual. My thesis is on actually renal osteodystrophy. If you have high PTH, you actually expect the femoral bones to be more affected than the lumbar spine. So it's a bit unexpected. But there is definite link that hyperparathyroidism may be driving the hypercalciuria, may be driving the hyperphosphaturia. I sent to our endocrinologist. They were not interested. So I did a trial. I gave cinacalcet. You can see hypercalciuria, gave cinacalcet, and then it fell. You will argue, why didn't I repeat more? I didn't repeat more. Well, I asked him to repeat more, but he said, I don't want to, because since you gave me cinacalcet, I've stopped producing any kidney stones. Now, I don't know if it's a cinacalcet or the salt restriction or the other changes I made, but it does suggest that there has been something going on there. And obviously, cinacalcet does what it says. It reduces your PTH. And going back, you can see that cinacalcet hasn't improved his bone mineral density, but at least it stabilized it. So if I have time, my very third case, a female, someone with known family history of renal tubular acidosis, recurrent stones, and with RTA, of course, it was what you expected, calcium phosphate, nephrocalcinosis, you can see there, good EGFR, low calcium, lowish phosphate, high total alkaline phosphatase, and of course, all of this is a hallmark of osteomalacia. Okay? And bear in mind that this is someone coming after being seen by the general practitioner, by the urologists, by the dietitian. Okay? What they missed, what they didn't tell me is that actually you can see she's quite obese. And what they didn't tell me is that she actually had bariatric surgery, and she had Roux-en-Y malabsorption and osteomalacia. Okay. Oops, sorry. So the advice, of course, actually is a micronutrients for bariatric surgery, IV iron because she was iron deplete, and despite the risk that repleting with vitamin D will increase her calcium and increase calcium excretion, of course you still have to protect the bones by giving the vitamin D. Salt, last patient had 11 grams, this patient had 22 grams. Okay, so clearly salt restriction here is important. And she's acidotic from her renal tubular acidosis, so giving sodium bicarbonate, if possible, potassium citrate. She couldn't tolerate calcium bicarbonate either, or even if she could, we didn't want to give it because she's already got 11 grams of salt. We didn't want to increase the sodium load even further. So actually in her case, even though it's a calcium phosphate stone, we're giving calcium citrate to bind, to correct the acidosis, and also to give it as a phosphate binder to help with the oxalate. So my summary. So I had to delete my summary slide because interestingly, about 2 days ago in CKD, they published this review article on the tips of how to work up a patient with stone disease. So they said there are 10 tips. I'm just going to leave it here, and hopefully, actually, by 3 cases, we'll have covered all of these 10 tips. Okay, I hope. So in particular, I highlighted lifestyle modifications. As Professor Yaqub said in his plenary, it's probably the most effective, although the hardest thing for us to affect. Thank you.
Thank you, sir, for translating evidence into practical preventive strategies. As the cancer survival improves, nephrologists increasingly manage therapy-related complications like acute kidney injuries, chronic kidney disease, TMAs. Our next talk bridges oncology and nephrology in daily practice. Professor Ahmed Sokwala is invited to speak on a primer on onconephrology. He is an associate professor and section of head of nephrology and kidney transplant at Aga Khan University Hospital, Nairobi. His professional interest includes interventional nephrology and critical care. Sir, please come on the stage.
Thank you very much, and thank you everyone. I know it's time, almost getting lunchtime, so we'll really go fast. Obviously, you know, onconephrology is a big topic. There's a whole journal on onconephrology, so I'll just give you some snippets here, go through some simple cases as well. And I'd like to thank the organizers for inviting me to talk about onconephrology. So I'll start with a case. We have a 62-year-old man with metastatic melanoma, presents to the ER with fatigue, reduced urine output, and lower limb swelling for 5 days. He was on PD-1 inhibitor, that's pembrolizumab. It's a checkpoint inhibitor for the last 4 months with good oncological response. His past medical history had hypertension, hyperlipidemia. Baseline creatinine was 90 micromoles per liter, around 0.8. He denies NSAIDs, herbal medication, PPI, recent exposure to contrast, no fever, arthralgia, or flank pain. So we see a lot of, you know, as my earlier introduction, a lot of oncology patients surviving, and we'll see more and more of these patients referred to us for kidney disease. Vitals were okay, exam was normal. Now the creatine's gone up to 240, urea nitrogen is 12, electrolytes are fine with a bicarb of 18, potassium 5.1. Urinalysis had 1+ protein, 10 to 15 white cells, white cell casts, and ultrasound was normal. So, you know, as my earlier speaker said, go to your basics. When you go to your basics, you will get to know what your diagnosis is here. So I understand a lot of trainees in this crowd as well. So what would you do next for this patient? Start steroids, stop pembrolizumab, kidney biopsy, or reduce pembrolizumab. Really fast with the show of hands, start steroids on the back. Stop pembrolizumab, kidney biopsy, reduce pembrolizumab. So excellent. So we did a kidney biopsy. It showed interstitial nephritis, started steroids, obviously stopped pembrolizumab at that time, and then restarted with a smaller dose of pembrolizumab. So as we know, cancer is going up, 50% increase from 2012 to 2030, and this will also increase the patients with chronic kidney disease, and AKI. So kidney and cancer connection it causes AKI, CKD, electrolyte acid-base balances, and we'll go through a little bit of all this and see how we can help our patients. So AKI, what's the most common cause of AKI in these patients? And a good friend of mine, Good Sukur, had done this study. And patients with cancer in the first year, they have an 18% chance of getting AKI, goes up to 27% in 5 years. And those who are critically ill have at least 40% requirement of renal replacement therapy. Usually, initially if you get them early, there's usually hemodynamic, prerenal, but then the other causes, you could divide them into cancer, or cancer itself causing AKI, or the treatment-related injury, or injury to the metabolic complications of cancer. So if it's cancer-related, then we have thrombotic microangiopathy, direct infiltration, paraproteinemias, obstructive nephropathy, not to forget that. Treatment-related injury, chemotherapy, different nephrotoxic chemotherapy, immunotherapy. We looked at one of the causes earlier, bone marrow transplant, nephrectomy, and metabolic causes are hypercalcemia and tumor lysis syndrome. If you have time, we'll cover all that, but let's see. So again, risk factors are divided into two, either patient-specific or cancer-related. If you have underlying CKD, they're in high predisposition to AKI. You age more than 65, patients getting chemotherapy, probably dose adjust their drugs. Other potential, patients who get chemotherapy, nausea, vomiting, prerenal on the background of NSAIDs for pain, etc., and other comorbid conditions like heart failure. Cancer-related, hematological, and we'll look at that, like TMA and tumor lysis syndrome and hypercalcemia. So that's an interrelated diagram showing us, both treatment-related and cancer-related can cause AKI. And if you go through again, where you go to pre-renal, renal, post-renal, and you get the diagnosis of AKI. So start with pre-renal. These patients have nausea, vomiting when they get chemotherapy. They've got NSAIDs on them. Renal, we'll look at different types of renal conditions which cause AKI in these patients, and post-renal with cancer of prostate, etc. These are the anti-cancer agents, conventional agents like cytotoxic drugs, anti-tumor antibiotics, and targeted agents are more now causing more immunological conditions into the kidney, like the proteasome inhibitors and immunotherapies. So different agents affect different stages in the glomeruli. If you look at the vascular, glomerular, proximal cumulotubule, interstitium, DCT, and collecting duct. So the vascular are usually the proteasome inhibitors, VEGF inhibitors, and TKIs, as well as VEGF inhibitor and mTOR inhibitors. For interstitium, cisplatin, carboplatin, our case proteasome inhibitors as well, and cyclophosphamide cisplatin affect proximal cumulotubule, distal cumulotubule affected by the cyclophosphamide and ifosfamide, collecting ducts, and the more common drug we know is the methotrexate. So TMA can be caused by gemcitabine, cisplatin, collapsing FHGS, and we've seen that if you use pamidronate, toxic acute tubular injury, ATN, things like platins, ifosfamide, and zoledronic acid, crystalline acute tubular injury, things like methotrexate can give you that. Minimal change disease, anti-VEGF inhibitors and LLK inhibitors gives you AKI, ATN, BRAF inhibitors. So if this is picked up early when a patient comes to you in the clinic, and pick up early, adjust the medicines, reduce your dose, stop the medicines, you can prevent these patients going into AKI. You can treat the underlying conditions and improve the renal function, because these patients are already having cancer, they need the drugs, and if you treat and improve their renal function, they're going to get the chemotherapies and get treated. So I'll just put them up there. Really a little fast on that. So another huge topic with cancer in kidney is tumor lysis syndrome, and most of us have seen this in our inpatients. So I'll have a case there again. 19-year-old boy referred with rising creatinine of 180, proteinuria, hematuria, and large kidneys, and biopsy done actually on the kidney. So case we had a few months ago showed ALL. Receives chemotherapy, creatinine goes up to 250 micromoles. potassium 5.1, phosphate 4, calcium 1.5, non-oliguric. So with the show of hands, who's going to dialyze this patient? Okay, excellent. So we've shown to early dialysis of this patient, especially with patients with high phosphate, which is not coming down, have better outcomes. And what are the risk factors for TLS? Again, divided into tumor-related factors and patient-related factors. If you have huge number of white cells, more than 100,000, higher risk. Things like Burkitt's lymphoma, diffuse B-cell lymphoma, large tumor burden will give you, a high risk of TLS. Then you prevent by, preemptively helping these patients by giving them fluids, putting them on rasburicase, allopurinol, etc. Patient-related reduced GFR, older age, and dehydration could be one of the reasons. Treatment-related, intensity of the cytoreduction therapy, concomitant use of nephrotoxin drugs, and inadequate hydration. So there's a classification of grading the severity of the tumor lysis, and it's called the Bishop grading, so 1 to 5, and I'm not going to go into detail on that. Lack of time. So you assess the risk of tumor lysis syndrome. If you have low risk, oral hydration, avoid nephrotoxins, and you should be good to go. Monitor your labs. If patient is high risk, give them IV hydration, and we looked at patients who are at high risk earlier, give them xanthase oxidase inhibitor and avoid nephrotoxic drugs. If you get tumor lysis syndrome, hyperkalemia, you monitor your ECG, early dialysis, as I said, hyperuricemia, hyperphosphatemia, monitor your serum calcium. One of the things I've seen people do is if your calcium is low, you start giving them IV calcium, which is not good because your IV calcium is just going to bind your phosphate and just precipitate on your blood vessels. So make sure you don't just give calcium because the patient has hypocalcemia unless the patient is symptomatic. If the patient is symptomatic, yes, give them calcium. So let's, one of the snippets we need to look at. We went through this. Next one is cancer and thrombotic microangiopathy. Again, it could be due to cancer itself or it due to be the drugs we give for chemotherapy, divided into type 1, type 2. So different cancers can cause different types of TMA, GI cancers, endocrine system cancers are more predisposing to TMA. This cancer-related TMA and chemotherapy-related TMA usually for metastatic disease, usually gives you cancer-associated TMA. DIC is more common in cancer-associated TMA. For therapy, if it's cancer-associated thrombotic microangiopathy, then plasmapheresis does not work for them. But if it is drug-related, then if you have Adams T13 deficiency, then it works. So you plasmapherese these patients, and they improve on the TMA. I'll go a little fast on that. Okay, different GARES, paraproteinemia-related renal diseases, and we've seen this as well. Different types of paraproteinemias cause different type of renal diseases, from tubular disorders to glomerular diseases and to electrolyte disorders like hypercalcemia, glomerular diseases like amyloid, tubular diseases like light chain nephropathy. And if you don't biopsy these patients, you won't know exactly what the problem is. So I've diagrammed there. I'll share up my slides, and it'll tell you where exactly. If you have smaller chains, then you get amyloid, you have a lot of proteinuria. If you have heavy chains, then you get light chain nephropathy, and your urine protein is much less. So you get tubulopathies, you get Fanconi syndrome, renal tubular acidosis, electrolyte imbalances, etc. Cancer-associated glomerular disease, as we can see, cancer can cause huge, from your glomeruli to the tubule to the interstitium. So I have a case here again.
So 5 minutes remaining.
Thank you. We had a few months ago as well, grade 3 astrocytoma treated with temozolomide, and it's and vascular endothelial growth factor called bevacizumab. After 2 biweekly treatments, he develops nephrotic syndrome. Despite cessation of the bevacizumab, his renal function deteriorated. What would you do next? So we did a kidney biopsy, and kidney biopsy showed minimal change disease. So don't be scared of doing biopsy in these patients as long as it's safe. And you know, if you get, so we got minimal change disease, he got his steroids, patient did well after that. So you can get from IgA nephropathy, different tumors gives you different types of GNs. IgA nephropathy, you know, we know it's a thinking that tumors only give membranous nephropathy, but no, it gives you IgA, it can give you minimal change disease, as we saw in our patient. With the newer drugs, it can also give you FSGS, MPGN, and crescentic GN. To last but not least, radiation can cause AKI as well. So we look, the patients are getting radiation, make sure you're checking their kidney function, and you know, they get, after a long exposure of radiation, they can get a chronic disease, kidney disease with lots of fibrosis, and that's the pathophysiology, how they get, with stimulation of the TGF-beta, how they get fibrosis on the kidney. So don't forget, when a patient's getting radiation, look at your kidneys as well. Take home, AKI is commonly experienced by patients with cancer, increasing morbidity and mortality and healthcare costs. AKI in patients with cancer may be secondary to hemodynamic derangements, thrombotic microangiopathy, as we saw some cases, renal parenchyma infiltration or obstructive nephropathy, knowledge of adverse kidney effects from conventional therapy, targeted therapies and immunotherapy is crucial, and I think nephrologists should know that so that they can help those patients. Obviously, more research is needed to clarify on the utility of new biomarkers. The one topic I didn't touch is how do you test for renal function in a patient who's got cancer, who's getting chemotherapy, is cachectic. Does creatinine clearance with the eGFR still works, or do we need better methods of calculating the eGFR? Thank you very much.
Thank you so much for such a comprehensive talk on such a vast topic. It gives me a great pleasure to invite Professor Adnan Sharif to shed light on cardiac screening in kidney transplant recipients. He is an expert in the field and knows no introduction. I've known him for a very long time, and I can tell you that when the guidelines were here, his expert opinion was over here, and over the years, he has pulled the guidelines on this very delicate subjects towards his scientific and professional opinion through academic excellence. Brace yourself, because it's going to be a roller coaster ride. Thank you so much.
Cool. Thank you very much, Rashid. And I'd like to thank the PSN for the invitation to come and speak to you today. It's always a pleasure to be here in Pakistan. So I'll apologize right at the beginning. I mean, I've learned the hard way that when my wife is mad at me, the most dangerous time is when she's hangry, which is when she's angry and hungry at the same time. And I know the talk sometimes kind of gets some people upset when we're talking about trying to change something that you're so familiar with. But the fact that it's just before lunch is honestly not my fault. So when we're talking about cardiovascular disease, what do we mean by cardiovascular disease? So there's different things which can contribute to the burden of cardiovascular disease. And we see a lot of this in our CKD patients and in our dialysis patients. And how do we assess for cardiovascular disease? So there's different things that we can do. So of course, we can ask our patients, we can ask them about what their symptoms are. We can do an ECG. And sometimes we may want to do an echocardiogram. Now, I don't have a problem with any of these things. I don't think we really need to do an echocardiogram for every single kidney transplant candidate. And for all young people, it may be unnecessary. But certainly this part of a cardiovascular workup is probably perfectly fine. The part of the workup which I have a problem with is the cardiac screening. It's the non-invasive tests, whatever tests you may do, and then the possibility, we've heard some talk about this earlier this morning, about doing angiograms for people who are asymptomatic of heart disease. And those are the kind of testing which I think we should not be doing for people as we work them up for kidney transplantation. So there are lots of guidelines out there. These are the American ones, and this is probably what most of us are using to some description or not. So I'll just kind of highlight what they are. So they split the guidelines into the people with known coronary heart disease and those without any coronary heart disease. And if someone has no symptoms, then that's the bit where problems arise. So if people have symptoms, they need to go see a cardiologist. That's very sensible. But for people who don't have any symptoms, then you can see that there's a cascade of tests and investigations that we need to do for these individuals to somehow rule them to be suitable from a cardiac perspective for a kidney transplant. And these are the arguments that we will use for screening individuals. So firstly, we think that by cardiac screening a kidney transplant candidate, we will somehow be able to it'll be some informed decision making, and we can counsel that patient about what their risk is of maybe having a heart attack in the first week or the first month after the transplant. We also think that if we pick up a problem, we'll be able to fix that problem. We can maybe do an angioplasty or do a bypass operation, something, and that will improve their chances in that early period after a transplant. And the third rationale, and this is used in many countries where there's a disparity in the supply versus demand for organs, we think that by screening individuals, we may pick out some who are very high risk for having a cardiac event, and therefore we will refuse that individual an opportunity for a kidney transplant, and by doing so we will prevent the wastage of what is a very valuable gift, that donor organ. Now the problem with this is that the evidence base to back any of these three points is completely lacking. The use of non-invasive tests, for example, they completely lack any sensitivity for picking up significant coronary artery disease. And even if you do pick something up on a non-invasive test, and then you do an angiogram, and you may find a mild, moderate, or severe amount of lesions, what's the evidence base that intervening on people who don't have any symptoms makes any difference? But this is what most of us will do. So this is what we think when we look at our patients. So we know that the cardiovascular risk for people when they're on dialysis is very high, and that's our red line. And we know that in the long term, kidney transplantation will reduce the risk of having a heart attack or a stroke in the long term. But most of us feel that in that early period after surgery, because of a general anesthetic, because of the surgery, we are pushing up their cardiovascular risk. So this is the high-risk period, and as long as they survive that red period, they will then get the benefit, the long-term cardiovascular benefit. So we think these kind of investigations that we do pre-op will help mitigate some of this early post-operative risk. I've told you that non-invasive tests lack any sensitivity, but if you put these people forward for an angiogram and possibly some kind of percutaneous intervention, is that advantageous for patients? And there are lots of studies in the general population which have shown that intervening on asymptomatic coronary artery disease doesn't lead to any improvement in outcomes. And what a lot of people will say is, well, those are not kidney patients, our kidney patients are different. But then this study, ischemia CKD, which I'm sure many of you have read, was done in this very specific group. So this was comparing an invasive strategy versus optimal medical therapy for people with a moderate amount of ischemia on some kind of a stress test. And they either had to have CKD stage 4 or 5 or were on dialysis. And what they showed was in the primary outcome, which was death or a kind of MI, and a slightly broader secondary outcome, which included a few other cardiovascular events, there was no difference when you compared an invasive strategy to a conservative strategy. And if you look at any subgroup, whether somebody was on dialysis or whether somebody had diabetes, there wasn't a single subgroup where an invasive approach, so these are asymptomatic people, putting them through an angiogram and intervention did not lead to any improvement in their outcomes. So there's no benefit, but it did pick up a risk. So people in the invasive strategy arm had a much higher risk of stroke, and for people who were not on dialysis, they had a much faster progression to dialysis, about 12 months faster. So I think ischemia-CKD was an excellent randomized controlled trial, but all randomized trials have some limitations. So does ischemia-CKD answer all of our questions? The answer is no. There were some exclusions. So there are some individuals who were excluded from ischemia-CKD that we don't have some information for. So for example, people with significant left main stenosis. The recruitment for ischemia-CKD was a little bit slower than anticipated, so there was a little resizing of the sample size. So you could question maybe some of the subgroup findings. So for example, in that chart I showed you, for people with very severe disease, the hazard ratio was 0.7. Now that wasn't statistically significant, but you wonder whether if they had a few more numbers, then maybe there would have been some kind of positive effect for people with severe disease. But I guess the main criticism for the purposes of this talk is that only 12% of that original report were on the transplant waiting list. So then the ischemia-CKD team published this subsequent study. So this is now looking at double numbers, so about 194 patients within that 777 who were on the kidney transplant waiting list. Did the same analysis and had the exact same finding. So again, even if you are on the transplant waiting list, there is no benefit for you to have this invasive strategy. Now again, there is still some criticism. So some people say the main question is what happens when they actually have their transplant surgery? And that's the trial that we need to do. And that trial has never happened. And I'll show you later why that trial will never happen. But the closest thing that we have is this. This is the CARP study. Now this is 20 years old. And this is looking at people before they were going to go for elective major vascular surgery. It was a very clinically high-risk group, and they compared an invasive to a conservative strategy. But even though it was 20 years ago, still the same findings. So for asymptomatic people, there is no advantage of an invasive approach versus a conservative approach. And this is the closest evidence that we have, and probably the only evidence we will ever have. So what do the guidelines say? So these are the KDIGO guidelines. And I like these guidelines, but it starts off with the recommendation that we should be screening people at high risk so that it can guide medical management and inform their risk. But then the second bullet point is that but we shouldn't be excluding people who are asymptomatic. And I don't find those two bullet points are compatible with each other. And if you look at the third point, it kind of raises a couple of things that we're really needing some evidence for. But that last line, the utility of coronary revascularization in asymptomatic people, ischemic-CKD has shown us there is no advantage for that. There is a trial called CASK, which is looking at surveillance screening for people once they've joined the transplant list, whether you should keep screening them every 3 or 5 years. That's still recruiting that I may report in the next few years. But I think the main question is why screen them in the first place? Why are we screening these individuals who don't have any chest pains or significant shortness of breath for cardiac disease? And that's the study that we should be doing, but that study will not happen. And even 10 years ago in the US, Bert Kosicki looked at a power calculation for how many patients we would need for this trial, and he estimated that you would need about 4,000, but I think you would need 3-4 times that, and I'll tell you why later. So, there's no benefit from cardiac screening, but there is lots of harm. So we delay and we sometimes deny kidney transplant candidates the opportunity for a kidney transplant procedure. There's the risk of contrast nephropathy and angiography for people, especially when they've got advanced CKD. There's the risk of surgical bleeding and people who will be on dual antiplatelet therapy who then have to wait until they are off that before they can have their surgery. There's the psychological burden for patients being told that they have this disease which they can't feel and it may cause a problem for them. And of course, there's quite a lot of morbidity and mortality from these interventions for people when they have CKD or if they're on dialysis. This is just as relevant for the UK as it is in Pakistan. There's a lot of cost.
5 minutes.
Thank you. And obviously, there's the radiation exposure as well. So to go through these, I don't think cardiac screening allows any informed decision-making. I've shown you that we can't modify any of these things. And what we're doing is that we are actually discriminating these very high-risk candidates by rationing their access to kidney transplantation. So I think you should scrap this and you could simplify it by simply listing people for transplantation if they don't have any known cardiovascular disease and if they have no symptoms. And that is backed by the very good evidence, systematic reviews, meta-analysis, randomized controlled trials that go back over 20 years. And people who have a problem with this are relying on the worst type of evidence. It's your personal bias. It's that N equals 1. I once had a patient 10 years ago who had a heart attack the very first day. So because of that, everyone has to go through this cardiac screening. That's the worst type of medicine that we can do. So what do we do in the UK? You can see that most centers do some kind of screening, and they'll have various criteria for who gets screened. But diabetes is always a criteria, and we've already heard how much diabetes there is here in Pakistan. The investigations that centers will do will vary depending on which unit they work at. But you can see that all centers have had people who've been denied an opportunity for transplantation because of their tests. Now, nearly everyone in the UK suggested that we needed a clinical trial. We will never be able to do a clinical trial for this. We did think about this, but it's an impossible trial. You would need so many people to go down that green pathway on this chart. And because not everyone who gets seen gets listed, not everyone who gets listed gets a transplant, and not everyone who gets a transplant has an event. And you would need over 10,000 patients for this trial. And the other reason why you would need so many is because we don't see that much in the way of major adverse cardiovascular events. That's not because we're screening them, it's because we just don't see that much of it. So you can see there's only 2.6% in the UK, and only about 1% of people will actually have an MI, most of which is in the early period after their surgery. But look at this, very few deaths, only 1 in 1,000 deaths from a cardiac event. That's not to say it's a benign event. People who do have a non-fatal MACE will be at a higher risk for long-term mortality, but still, their mortality will still be lower compared to being on dialysis. And I just want to finish off with this one centre in Belfast in the UK, which has stopped doing all their testing. So this is what they used to do before 2015. And then they've pretty much adopted a kind of a very relaxed approach to who gets testing when they are asymptomatic. And this is what they reported, and these are their figures. So if you just compare that to what I showed, which is English data, if you stop all your testing, you will double your rate of fatal major adverse cardiovascular events, and you will double your rate of non-fatal MACE. I think the advantages of stopping far outweigh these disadvantages, which is a doubling in your MACE rate. But we do need to have very good guidelines. I've quoted you the American guidelines. These are the British guidelines, which are currently being reviewed, but they will take a very laissez-faire approach. So they will support centers to do less and less testing. And hopefully these will be available in the next kind of 3 to 4 months. So just to kind of summarize, I think our strategies for cardiac screening for asymptomatic kidney transplant candidates, there's no evidence behind it. It's all dogma. It's all personal bias. And I think we cause far more harm than benefit by testing these kidney transplant candidates who don't have any symptoms for cardiovascular disease. And I think if we were to exclude that testing, then we would actually have a much better benefit for our patients. And if you look at the evidence base, then that really does suggest that we should have a far more kind of less is more approach for our individuals, no matter how high risk we think they are. And of course, there's the issue about the equity of access, the cost of doing these tests. And if anybody says we should wait for that randomized controlled trial, forget it. There are many things in nephrology where we will never, ever have a randomized controlled trial, and this is one of those things, so we shouldn't wait for it to happen. And I appreciate that it's not an easy change. There's surgeons, there's anaesthetists, everybody has a say in these things, and you need to have your entire team on board to make such a change. So just to finish off, if you have an interest, there's some further reading, and this is a debate article, so people arguing for arguments for and against. But this is just something which I've published recently, and I think what we as nephrologists need to do is we need to change our thinking. Our kidney failure patients are very high risk for cardiovascular events. The single biggest intervention that we can do to lower their cardiovascular burden is to give them a working kidney transplant. It's better than any pharmacological intervention we can ever do. So we need to rethink what kidney transplantation means for our kidney failure patients. Thank you.
Thank you, sir, for clarifying a clinically critical area with a practical insight. We now open the floor for question and answer session. I request concise questions to allow broader participation.
Dr. May I ask? Zahid?
Yeah.
So, Dr. Adnan, thank you very much. You said for clarifying, but I am now confused actually. Because what we are doing here as a transplant physician here, we are doing a lot of screening, you know. What you have said probably is contradictory what most of us are doing here. This is my understanding. The problem here is that how to relate it to a setup where you work and where we work here, because here, if Professor Sami is doing a transplant, a lot of burden is on his shoulders. There is no institution which is just supporting you for that. And the other thing is that what kind of transplants we do here, most of them, the people, they are paying for it. There is a very healthy amount of money which they have to pay, and they have to bear that cost. So do you think that people like us who are working here, do you think we should be brave enough just to do no screening or some screening? And the other thing is that how you will guide us to individualize, because the cause of chronic kidney disease could be anything, like someone who's 60, 70, diabetic, hypertensive, history of a stroke, or someone who has polycystic kidney disease is in 40s or 50s. So he said clarified, but I am confused.
Sure, no problem. So, I mean, they're all very good points, and I'll just go through all of them. So firstly, yeah, I mean, transplantation, it's a team sport. I mean, we're all mainly nephrologists here, but, you know, we'll have surgeons, we have a cardiologist. When I used to tease my nephrology colleagues, why we're doing these tests, they'd say, oh, it's because the surgeons will refuse to do the operation. So then I would start to tease the surgeons and say, well, why are you doing this? Then they'll say, oh, it's the anaesthetist will refuse to do the anesthesia. And it went on and on. So we had to all sit down together to decide that this was the right thing to do. But you're right, there needs to be some governance for it. Because if you do this approach, at some point, and this is what I say to my colleagues, at some point somebody will have a heart attack in that first week. It's guaranteed. But I always say that, we need to have complications with kidney transplantation. Okay? We need people to have heart attacks. We need graft loss. We need death, because if we are achieving 100% patient survival, 100% graft survival, 0% cardiac events, it means that we are picking very easy people to transplant. Okay? And so these guidelines, I think, are just as relevant for people in their 60s, 70s, people with diabetes. I think as long as someone has no symptoms. Now, that's the gray area. How do you say someone has symptoms or not? Some of our dialysis patients don't walk, can't even walk very much, so how do you know whether they have symptoms? And that's the bit I will accept can be a little bit difficult. But I think the issues here, we're clinically causing more harm than benefit. That's just as relevant here in Pakistan as it is in the UK. The resource issues, they're just as relevant in both countries. The wait for some of these cardiac tests can be many, many months. But the main reason for stopping it is the clinical evidence base would suggest we should be stopping it. There's not a single trial in the last 20 years that suggests you will help these patients. They all suggest that we cause harm. But it's a real culture change to change what we've been so used to doing. And even in the UK, most centers are still doing testing.
Okay, I think we are short of time now, and lunch is being served. So if there are no other questions, only one question is allowed. And if there are none, the meeting is adjourned. Thank you very much.
Sir.
Thank you. I have a question regarding the metabolic workup of kidney stones. Is this thing called supersaturation? And do you do it routinely because it's not available to us? We do the metabolic workup apart from this one thing. And how do you interpret it? And what's the value beyond the absolute values that you get on the
Yes, a very good question. So the supersaturation, actually, it's not difficult. It's just getting access to the program. It's an equal 1 or equal 2 program. I must admit, we don't do it because by doing it, I don't think it really helps you a huge amount. If it's high, and in other words, you're at high risk, and you know the patient is at high risk because they're producing stones, what you need to then look at is what is pushing it into the supersaturation range. And you don't need the equation. You can just tell, which you go for example, the first case. Yes, there was a little bit of hypercalciuria, but there was a lot of hypocitruria. So you go for where you think you can make the biggest difference. And where you can make the biggest difference, yes, you have to say what is the lowest, that was really very low, and where the intervention has effect, because actually correcting low citrate is very difficult. Improving, reducing calcium in the urine is slightly easier. But that's your clinical judgment. So yes, there is equation. I don't think it's difficult to get a hold of that equation. It's 20 years old, so the difficulty is actually finding a computer which will still run it, because it's on the very old basic programming language. But I don't find it's helped me in any way of managing my patients.
Thank you very much. If there are any other questions, the speakers will be available in the lunch area. Thank you.
Yes. Thank you, sir. So it's time to get fruit for your attendance. So there's also a lucky draw. So please keep your badges ready. Dr. Asma Mughal. Next. So she's absent. So we will do it again. And the winner will get Samsung mobile. Dr. Nabila Fayaz. Is she here? So this is the last chance. Dr. Adnan Yunus Malik. He's here? No. So there's the end. So may I request Dr. Ghiyas Ahmed and Dr. Shehzad Saeed to please come on the stage and present shields to our esteemed speakers. I would request Professor Aranga Vijayavikrama to please come on the stage and receive your shield. Sir, please come on the stage. Professor Vijayavikrama. Next is Professor Stanley Fan. Next is Professor Ahmed Sokwala. And the last one, and last but not the least, Professor Adnan Sharif. Before lunch, we know, Sir Adnan Sharif. Sir, I think I said, sir, Dr. Hina will collect his shield on his behalf. Before lunch break, we will now proceed with the Industrial Symposium supported by Hilton Pharma, a long-standing contributor to healthcare development and medical education in Pakistan. I will invite Dr. Saima Bashir to speak on role of new generation parental iron therapy in anemia associated with chronic kidney disease. And the panel of experts are Associate Professor Aisha Ijaz, Professor Ghulam Abbas, Professor Izaz Mand, Professor Amir Azhar, and Professor Abid Hussain. I request all of them to please come forward. Please, Abbas.
So what is anemia? It is basically defined as a condition where the number of red blood cells or the hemoglobin concentration within them falls below the normal range, and that results in impairment of oxygen delivery to the body tissues. So the WHO defined anemia as hemoglobin level less than 13 grams per deciliter in males and less than 12 grams per deciliter in females. So we know that the burden of anemia due to CKD increases as the CKD stages are increasing. There is 15.4% of the patients who have anemia, those who have CKD, they have anemia as well. And as the stage progresses further, and at late stages, it increases up to 50% and above 50% in stage 5 CKD. So what is the pathophysiology of anemia in CKD? It basically occurs because of the erythropoietin deficiency. We know that in chronic kidney disease patients, the erythropoietin generation is impaired due to nephron loss. There is iron deficiency because of the reduced iron absorption, increased blood loss and inflammation. There's chronic inflammation. CKD is a chronic inflammatory state, so that results in less iron utilization and EPO response. There is reduced red blood cell lifespan due to uremic toxins. Bone marrow suppression is also there, and there are nutritional deficiencies as CKD patients have poor appetite and malabsorption. So what are the symptoms? We all know that anemia results in fatigue, weakness, shortness of breath, dizziness, pale skin, cold hands, and chest pain and palpitations. So there were a few studies done that showed that the patients who had anemia, they had higher number of cardiovascular related comorbidities, mortality rate was also higher, there was increased cardiovascular burden, and that resulted in increased hospitalizations. Although the fatigue was more common in those patients who had, in CKD patients who had anemia, activity impairment was also increased with disease progression, and the accelerated CKD progression was seen. The average time to progression in those who had anemia along with CKD, it was around 18 months. They reached the late stages like stage 4 and 5. However, those who do not had anemia, the late stages were achieved over 28 months. So CKD progression was accelerated in patients with anemia. So this is basically what we need to do to maintain hemoglobin in CKD patients. We need to achieve a target hemoglobin levels. For that, we should give iron supplementations, erythropoietin stimulating agents, and regular monitoring should be done to adjust the treatment. So what is the treatment protocol for iron deficiency anemia? Normally the non-dialysis CKD patients, they are given oral iron supplementation. However, those who are non-adherent or non-convenient, they can also be given IV iron therapies. For CKD patients who are on dialysis, often the IV route is preferred due to better absorption. So these are the KDIGO, updated KDIGO guidelines that suggest that patients who are on dialysis, CKD 5 stage 5 patients on dialysis, iron therapy should be given to those who had ferritin levels less than 500 and transferrin saturation less than 30%. And patients who were not on dialysis or peritoneal dialysis patients, the targets were if the ferritin is less than 100 and TSAT is less than 40%, IV iron therapy should be given, or ferritin is between 100 to 300 and TSAT is less than 25%, IV iron therapy is recommended. So these are the common formulations. In all of these, the common formulations that are used in our setups is iron sucrose and ferric carboxymaltose. So for monitoring, the recommended guidelines are for non-dialysis patients or the patients who are on peritoneal dialysis, the hemoglobin, ferritin and transferrin saturation should be checked every 3 monthly. However, patients who are on dialysis, the hemoglobin, ferritin and TSAT should be checked every 1 to 3 months to balance the deficiency and prevent overload. So this was, there are some studies that were done. This was a study done in Netherlands in 2018. In this study, the patients were compared, those patients were compared who were given IV iron therapy, iron sucrose versus ferric carboxymaltose.
Ma'am, 2 minutes remaining.
So results were that hemoglobin increased in all groups, and the iron dose was significantly lower with the ferric carboxymaltose group. This was another study in India. It was performed in the CKD patients. The higher doses of IV carboxymaltose resulted in better stability of hemoglobin. This was the study that was done in Spain, and it was done in peritoneal dialysis patients, and IV ferric carboxymaltose was also recommended for these patients. Results were very positive. So ferric carboxymaltose is efficacious, that it increases the hemoglobin levels rapidly. It is safe as it has less adverse outcomes, adverse effects as compared to the other formulations of iron. It is convenient to administer this ferric carboxymaltose, as it can be given in higher doses over a short period. And it is very cost effective. The oral formulations, we have Ferrosoft and Fercari. This was the comparison that ferric carboxymaltose 500 mg, if we give 500 mg in one sitting, it's around, it's cost effective as compared to the iron sucrose injections 500 mg. So it rapidly increases the hemoglobin level, easy to administer, no test doses required as there are no anaphylactic reactions reported with it, less visits are required, and it has a better safety profile. So, thank you.
Thank you, Hilton Pharma, for their continued support of evidence-based practice and professional education. Now, it's time for lunch and prayer break. Lunch for faculty is available on the right side, whether inside the hall, and for delegates, it's outside in the lobby. And we will be back here at 2:30 p.m., inshallah. We will be back at 2:40.
नहीं मैंने भी स्टार्ट ही नहीं किया. मैं देखना चाह रही हूँ कि मैं कितना बोलूँगी तो वो ऑडियंस तक जाएगी तो मैं चीख रही हूँ. हाँ. Assalamu alaikum and very good afternoon to all of you. I am Dr. Hajra Arshad, resident nephrology at Kerala Hospital, Islamabad. It's an absolute privilege to conduct and moderate the second session of this 15th Biennial International Conference of PSN 2026. This program begins with a focus update session designed to address evolving concepts, emerging therapies. Assalamu alaikum and good afternoon to all of you. I am Dr. Hajra Arshad, resident nephrology at Kerala Hospital, Islamabad. It's an absolute pleasure to moderate and conduct the second session of this 15th Biennial International Conference of PSN 2026. This program begins with a focused update session designed to address evolving concepts, emerging therapies, and current challenges in nephrology. First of all, may I respectfully invite our esteemed session leadership to please take their seats on the stage. The chair of the session will be Professor Nisar Anwar. Sir, please take your seat. Now, I would like to request the co-chairs and panel mentors of the session. Professor Dr. Umair Ahmed Siddiq. Sir, please take your seat. Professor Dr. Syed Munib. Professor Dr. Imtiaz Masroor. Professor Dr. Abdur Rahman. Professor Dr. Bilal Jamil. Thank you so much, sir, for gracing our session. Your guidance continues to shape academic rigor and clinical excellence. Now, let us proceed with the first talk of the session. Acute kidney injury is no longer a single event, but it's a part of a dynamic disease trajectory. This talk examines how acute kidney injury transitions to acute kidney disease and chronic kidney disease, and why early recognition of this continuum matters for the long-term outcomes. The absence of dialysis doesn't always mean recovery. For this, I would like to invite Professor Iranga Vijay Vikrama to please come on stage and discuss a complex interplay of AKI, AKD, and CKD. Sir.
Okay, so we met in the morning for the first talk that I gave. So this is on a different theme. So this is about AKI, CKD, and AKD. So let me start. When you look at the epidemiology of AKI, the annual incidence of AKI globally is around 13 million. And AKI occurs in about 20% of hospitalized patients and occurs in more than that in ICU patients, which is about 67%. And most of us feel that AKI is not a problematic thing and it's a transient illness, but it is not the case. Complete kidney recovery occurs only in about 40 to 60%. 20 to 40% progress to chronic kidney disease, 1 to 5% end up with kidney failure, and 20 to 40% develop recurrent AKI, 10 to 25% in hospital mortality, and obviously higher in ICU AKI, and 20 to 30% have partial or incomplete recovery. And obviously this highlights the fact that AKI is not a benign disease. So if you look at the terminology and nomenclature of AKI, we are all familiar with AKI. The KDIGO has defined AKI as an illness which occurs within the period of 7 days, either an increase in creatinine or a drop in urine output. And obviously this is a functional definition. And we are also familiar with CKD, which is defined by either structural or functional abnormalities persisting for more than 3 months. But there is a gap between AKI and CKD, and that is filled by the definition of this condition called AKD. So basically, there is a gray area where the patients don't have AKI and neither have they moved on to develop CKD, and this period is not a silent period, and this is basically covered by this term AKD. So basically AKD, or acute kidney disease, means where there is either the patient has got AKI. So AKI is also included in the diagnosis of AKD. So basically any kidney functional or structural abnormality persisting within the 3-month period is considered as AKD. So It also contains AKI, but in addition, there can be situations where the functional definition of AKI may not have been met during this period, even within the first week, and those are also included in the AKD group. So essentially, it's a continuum of kidney disease from AKI to AKD to CKD. So AKI is part of AKD, and this can be associated with complete recovery of the AKD, or it can eventually lead to other complications, or including death and CKD. And there's a considerable overlap between AKD, AKI, and CKD. So this is something that I wanted to highlight. So as you see that AKI is part of AKD, and also there can be overlaps with AKI and AKD with CKD. And if you look at the progression from AKI to AKD, some of it may be completely recovery with eventually leading to no kidney abnormality, but sometimes you can just have a drop in GFR but fully recovery but end up with a slight functional deficit. But sometimes you can have more significant deficits in the GFR and obviously ending up with more severe kidney disease. So how significant is AKD? Is it, so what is one thing what we need to do is find out what is the incidence or the prevalence of AKD, and also what are the outcomes of the AKD. So this was a study done in Canada, in the region of Alberta, and this was a population-based study in an area where there was universal health coverage, and people undergo regular laboratory checks. And in 2008, they looked at this population of individuals and selected individuals who had undergone creatinine evaluation and urine albumin creatinine ratio evaluation, and they picked up these individuals over a period of 1 year and then followed them up for a period of 8 years. And what they found was the AKI incidence in this population was 1.4%, but they had far more numbers of AKD individuals, and obviously a majority were having CKD. So this highlighted the fact that AKD was approximately, it's about 1 in 3, about 1 in 3, 1/3 as common as CKD, and also it's 3 times more common than AKI. And if you extrapolate to the population of the province, then it came to about 1.5%. So it's not uncommon. AKD is common. And then moving on to the outcomes, it's quite a busy slide, but just focus on the graph B, which on CKD development. When you compare the outcomes of AKD compared to AKI and NKD, you see that there's a higher risk of developing CKD compared to even AKI in people who have got AKD. So this highlights the fact that AKD carries a significant risk of complications, including CKD, CKD progression, and end-stage kidney disease, and increased death. Then this is a study, so basically this was a population-based study that I highlighted earlier, but this is a study that was done in hospitalized patients. So again, this was done in Australia, Melbourne, where they looked at hospitalized patients with who were in hospital for more than 24 hours, and looked at the incidence of AKI and long-term complications of people who had AKI and AKD. And when it comes to CKD and death, you can clearly see that people who had the people who had AKD was associated with more significantly worse outcomes than people who had AKI alone. Obviously, because AKI patients recovered, but AKD patients with or without AKI carried a more long-term risk of CKD and death. And this was a meta-analysis which was subsequently published incorporating both these studies, and it highlights the fact that patients who had AKD has clearly higher risk of all-cause mortality and end-stage kidney disease. So essentially, AKD defines abnormalities of kidney function and or kidney structure with implications for kidney health, as highlighted in my previous slides, lasting for 70 to 90 days. Important populations of patients with evolving kidney disease. This is an important population of patients with the evolving kidney disease. So this is not a static phase, and the patients could be either undergoing process of recovery or worsening. And the importance of this identification of this phase of the disease is it provides a window of opportunity for clinicians to act in order to prevent them from going to develop these complications. So how do we recognize the individuals with AKI who are likely to progress to AKD and CKD? So this is another fundamental question that we need to figure out, because this is of practical importance. So these predictors include obviously the severity of AKI. So if the patients had a higher level of serum creatinine or serum cystatin C and had required dialysis, or if the patients had a longer duration of AKI, then they are likely to go into develop AKD. And then there are factors like older age and presence of comorbidities like smoking, hypertension, diabetes, cerebrovascular disease, congestive cardiac failure, peripheral vascular disease or liver disease. So essentially, if the patients have other comorbidities, they're likely to end up with some residual kidney damage causing AKD. And several clinical scoring systems have been developed, combining these clinical parameters with urinary sediment in order to make predictions on development of AKD. And then there are novel biomarkers, urinary biomarkers like IL-18, KIM-1, and GAL, IGF-BP7, TIM2, and urinary angiotensinogen and albumin, which have been developed to be predictors of going into AKD. And also some of the imaging techniques, such as Doppler-based elevated renal resistive index, might give some indication that the patients are having likely to go into develop AKD. So this is a study done in Taiwan, where they looked at AKI patients who required dialysis, and then looked at their post-discharge follow-up, and they found that the patients who had been followed up by a nephrologist during the AKD period after being discharged, after they discontinued dialysis, they had better outcomes in the long term in lowering their mortality, major adverse cardiovascular events, congestive cardiac failure, and severe sepsis. In relation to those, they had much better outcomes than individuals who had non-nephrology follow-up. So this highlights the importance of looking after these patients in the immediate discharge period after developing severe AKI. So what are the things that we could do in this period in order to improve their better outcomes? So the most important thing is that you need to monitor their kidney function, keeping an eye on their creatinine, estimated GFR, and maybe initially you can decide when you want to do this, but then subsequently you can decide how frequently you want to do this. But the essential part is that you need to monitor these patients. And in addition to that, you can check for structural damage markers such as protein, urea, or hematuria. And the important thing is it's just not the snapshot of the kidney function or the damage markers. You need to keep following up to assess the recovery. Then we need to address, we need to optimize their blood pressure and volume status. So this includes blood pressure measurement regularly and assess the volume status, because obviously most of these patients are having either subclinical fluid overload, or might sometimes end up being over-diuresed and leading to pre-renal additional damage. So it's important to make sure you follow them up and optimize their volume status. Then the other important thing is looking at the medications, because some of the medications may be detrimental in the post-discharge period, and you need to avoid nephrotoxins such as NSAIDs, COX-2 inhibitors, and sometimes people may be taking traditional medicines, and you have to cut down the unnecessary drugs like PPIs. And also, you need to review the renally cleared medications in order to adjust their doses. And it's important that some of the drugs we have stopped during the AKI or AKD period may need restarting. These include the RAS blockers as well as the SGLT2 inhibitors. So it's like, you know, these drugs are useful in the long run in preventing going into develop CKD. So I think it's important that these drugs have to be restarted cautiously once the kidney injury is more or less improved. And also you'll have to check the drug and to drug interactions introduced during the AKI admission. And it's also important to understand whether there's evidence of different types of renal disease. For example, especially when the renal recovery is incomplete, whether we are dealing with a glomerular disease, interstitial nephritis, obstructive uropathy, or a TMA or vascular disease. So might have to end up doing imaging and biopsy. So this is the important fact that we need to be kind of, the patient should be followed up under a nephrologist. And we all know that kidney injury carries a cardiovascular risk, even if the AKI is completely recovered. So, we have to recognize the fact that AKI is a cardiovascular risk amplifier, and we need to optimize the cardiovascular protective drugs like statins, antiplatelets, heart failure therapy, where appropriate during this phase. And obviously we need to monitor the metabolic and laboratory complications such as electrolyte abnormalities, acid-base status, hematological and bone mineral markers. And crucially, we have to look at their nutrition and lifestyle counseling, which carries an important contribution to their renal recovery and cardiovascular outcomes in the long term. And finally, the patient education and self-management. Obviously, if a person has developed AKI, that is, they need to understand it's not a benign event and they carry a risk of recurrent AKI. So they need to understand these and avoid the risk factors for AKI. And obviously, we need to teach them sick day rules where they might have to discontinue some of the medicines during the period where their kidney function is impaired. So my take-home message is that every AKI survivor and individual with AKD is a CKD patient until proven otherwise. So this is the kind of important thing we need to remember. It is not a benign situation where we need to just forget the fact that once they're discharged that they'll be okay.
Sir, 5 minutes.
Yeah, and thank you. So, so it's important that we need to have a structured follow-up plan for these patients, and ideally these patients should be managed under care of a nephrologist. So this is something that we need to keep in mind when we are dealing with people with AKI and AKD. Thank you very much.
Thank you, sir, for clarifying a clinically relevant continuum that often goes under-recognized. Thank you for reframing how we interpret recovery after AKI. Your talk highlights the critical windows for intervention that can change the course of chronic kidney disease. Now, let us proceed for the next talk. This will explore the interventional strategies beyond pharmacotherapy for difficult-to-control hypertension. Professor Umar Farooq is invited to speak on a renal denervation in the spotlight that is a novel approach toward the resistant hypertension. Sir, please.
अस्सलाम वालेकुम एवरीवन। पोस्ट लंच सेशन जो है ना मुश्किल होता है, मुझे तो खुद नींद आ रही है। तो सबसे पहले आप सबका शुक्रिया इनवाइट करने का। पाकिस्तान से हम चले तो जाते हैं लेकिन पाकिस्तान तो दिल में रहता है, और आपका शुक्रिया आप इनवाइट करते हैं फॉर द अपॉर्चुनिटी टू प्रेजेंट। तो रीनल डीनर्वेशन ए टॉपिक काफ़ी अरसे से इस पे काम कर रहा हूँ। इट्स बिन क्लोज टू माय नियर एंड डियर। These are the disclaimers. So active trial, I highlighted some of the trials which either are active or just completed. One is the target BPI, which is, so this device is not FDA approved yet, it's on the pathway. इनका एक ट्रायल खत्म हो गया, दूसरा भी चल रहा है, रेडियंस जो है. The other one is the, I have an NIH grant for developing a 3D printable bioadhesive device to be applied on the carotids to see if this also controls the blood pressure. Again, it's a device in evolution, still in the biomed people, so it's in very early stages. No discussion about that. So blood pressure, we all know, is a silent killer. Interestingly, you can measure this. So this is so important and easy to measure this. We have all of these devices, but yet, you know, a big chunk of the world population goes uncontrolled. So these are the Pakistan statistics. These are old. They say that the average blood pressure was 129, which I doubt. I'm sure you see higher blood pressure. Like, we are on rise with the blood pressure. We are on the rise with diabetes in Pakistan. Targets are getting lower and lower, even for regular blood pressure control, not necessarily for the resistant hypertension. So I was at the American Heart Association meeting last year, and what I highlighted is the new overarching blood pressure goal, less than 130/80, which is overarching, but if the devil is in detail, ideal is less than 120/80. This used to be long time ago, then we had relaxed targets, now we are going back to the stricter targets. But look at the number of societies that actually agreed. So there was always a fight between societies about their target blood pressure. Primary care wanted to keep it higher, some of the societies lower. More and more, there is consensus. And what is the target we are using in Pakistan? I'm sure lower is better, or we are still letting, what's the general trend? Ahad? No, low is not too low. So this is think global, act local. So we have to make sure that global guidelines we need to interpret in the Pakistani context, similar to the cell-sep dose, like mycophenolate dosing. We don't tolerate, our Pakistani population, we don't tolerate it that much. So these are I think again the blood pressure categories. I don't want to bore you with the details, but the trend is that go low in like where we practice in US as well as in Europe. So this is a pathway of what happens to the population in general. So maybe on the right-hand side, if you see the adult population, half of them, they're not controlled. Even the half which takes the medicine, it's not controlled, and 18-20%, you know, is the only control of the world population you can see despite taking these medications. We all know when you bring the blood pressure down, it actually decreases the overall risk of major cardiovascular events by pretty decent percent. If you bring it by 5 millimeter down, the risk reduction is 10%. If this is 10 millimeter of mercury, it's 20%. The problem is the more you give, less they take, plus adherence of blood pressure medication is not very optimal. And how these data come to forefront was when people were doing these trials to look at the blood pressure after some device. They were doing the pharma studies to measure the drug levels, and they found that 44% of the patient, they don't take all of their medicine, and only so 17 of them, 0 meds, described it being prescribed. A subset of the blood pressure category is resistant hypertension, and we in nephrology, and I'm sure the cardiologists in the room, we see this particular condition more so in our clinics than some of the other regular, you know, blood pressure issues. So resistance is defined if you take 3, including a diuretic, and blood pressure is not controlled, resistant. When people take 4 medicine at the maximum tolerated dose, this is called controlled resistance, when the blood pressure is still controlled. So the idea of the denervation, I think I built some case for, like, we need an alternative. The interruption of the sympathetic nerve activity to treat hypertension, it's not a new concept. I don't know if anybody remembers, or have you seen the patient with the sympathectomy? Has anyone seen. So these are some of the published literature, 1950s and 60s and 30s. The problem was that blood pressure was controlled, but patients were living with very intolerable side effects, including bowel, bladder dysfunction, sexual dysfunction, etc. More recently, instead of really denervating the whole sympathetic trunk, if you can actually go specifically in the renal arteries, and you will say it's a renal artery, there's a blood flow, what about the nerves, right? So where are the nerves? How do you denerve like an artery? So that's the concept, and then the issue is, so I'll show you in the next slide. The nerves actually travel on the wall of the artery. So the kidney is a big kind of mediator and a central to autonomic nervous system in this regard. It actually receives the activity, and the result is increased RAS activation. But kidney also sends the signal back to the brain, and then there are some other downstream effects: vasoconstriction, insulin resistance, sleep issues, cardiac hypertrophy. So kidney plays a role, so it must be part of that whole sympathetic, parasympathetic nervous system. So this is where the renal nerves actually lie, inside the renal artery. Just for the orientation, the top left is vessel lumen. So vessel lumen, and there's intima, there's media, and there is adventitia. So renal nerves actually, they stay in the adventitia, the outside, so of the renal artery. So they actually run into this. So that you can see in this picture. Okay, I can't see it. That's fine. We'll let it go. So they come on the aorta, then they actually branch off these nerves which are yellow in the picture, and then they actually connect. I call it touchdown. They call it, I think, arborize. So some of them actually very close to the origin of the renal artery, some of them slightly distal. So if you want to denervate something, then you must ensure that it is actually reaching to all the areas, and also it goes through the branches as well. So this is, I think, another schema. On the right hand, you go through a femoral artery, you go up, you enter in the renal artery, and then you perform the procedure. And you can see on the very right one that how the energy, which is the denervation energy, is actually released from inside of the artery, but it actually goes through all the walls and reach to the nerves. So these nerves often bypass the main renal artery and actually converge sometimes on the branches. So it's important that we reach out to the branches. And this is important because some of the trials show some success and some failure. Maybe not all the branches were captured earlier on. And then the 30% of cadavers, when they said had accessory renal arteries. So it's important that when we plan for these procedures, this is done properly and as prescribed. So one of the fundamental, really early trials that set the stage. So this was in the lab. If you denervate the renal artery, what happens to the norepinephrine surge? So main renal artery, it really brings down the norepinephrine, that surge level, by 71%, branches 83%. When you combine main artery and the branches, then it's above 90%. So timeline, trials are important. I will go through some of the trials. So this was, I think, back in 2000, like somewhere in early 2010, 11, when the Simplicity trial came. So the earlier trial showed that there was significant blood pressure improvement, both with Simplicity hypertension 1 and 2, to the point that when they were doing a Simplicity 3 trial, which was a very large, randomized, prospective, the sham control. So sham control is how we do it. You bring patient into the cath lab for the procedure suite. They actually have a cut here. Sometimes some of the protocols showed that they go in and took the picture, so really look at the renal artery to see how it looked, and did not denervate. Other protocols have just the cut and to the tape, so patient know that something was done. So that is the sham control. Of course, the other arm has the patient which is getting the treatment. So in this particular, they have more than 500 patients. The difference between the two, either the treatment and sham, was not significant. So, you know, there were two trials, 1 and 2, that showed significant 30 plus millimeter of mercury improvement, especially in somebody who has extremely resistant hypertension and very high starting blood pressure. Now you do a Simplicity Hypertension 3 trial, which does not show any major difference. I remember when the study came out back in 2014-15, our center was actually getting ready to participate in one of the trial, but then we had to shut it down because the results were not very favorable. So there was a discussion. People thought, okay, what happened? Maybe patients, there were a lot of changes allowed during the trial. It was not done very standardized. People thought maybe the operator experience was quite inadequate. So they came back in one of maybe conference like this. All the experts sat together and tried to have some ground rules and guardrails for doing the clinical trial, which, you know, okay, let's settle down for appropriate targets, not go for the, you know, like super high targets, bring it down. Make sure there is sham, make sure you do trial on drug and off drug, so you can actually tease out the difference generated by the device itself, not the combination of the medication. And then the next generation of the devices. No need to read all this, that's not the purpose. These were all the trials that completed afterwards to accomplish something that we arrived today. And I summarized in this cartoon. This was available nicely. So if you see something which is in this oval, this means like the studies that are meeting the primary endpoint. Anything which is a rectangle is study that did not show any difference or meet any red point. And the different colors are 3 different techniques used. So you can see that there were still some of the trials that did not achieve, but more and more with the standardized way of doing the trials, we were achieving some of the results. And these are, you know, spiral hypertension, off med, on med. You will see all of these radians, the different trials that showed what was the improvement in 24-hour blood pressure as well as the office blood pressure. And you can see the difference anywhere between 5 and 10 in those different trials. So these are the 3 systems currently being used. 2 of these are already approved. The first one is the Medtronic spiral system. So that uses radio frequency, energy delivery. The middle one is ReCore, which is the ultrasound system. It's also approved by FDA. And third one is the ablative, which actually, this is the trial we did. You go in and you inject alcohol to really sclerose the arteries. Can we play this video? Let's see. So these are the renal nerves. I don't know if the video is playing. So a catheter which generates the ultrasound energy. So this is the transducer that will actually, you know, control everything. So you go in, there's a cooling mechanism built into this. So you deliver the energy, and really the energy is going through the renal arteries to denervate the nerves which are on the outer side. So similar is the Medtronic spiral system, which the spiral, it's actually, when you touch it, it's very soft. So it goes inside, it conforms itself into the renal artery, and it can go into the branches. You can go really down. The newest devices are up to 3 to 4 millimeters. So it's actually really, you know, 30 minutes procedure done in the same day, and then patients are released. So who is the right patient? And I think this is a question all of us are familiar. I see 2 types of patient. Somebody who is truly resistant, there are multiple medicines. The other is who cannot tolerate due to allergies. So some of the contraindications, if there is any structural problem in the kidney artery, fibromuscular dysplasia, some scarring, pregnancy, and we don't have data on ESRD and GFR less than 40 or transplant patients. Pretty safe. Earlier, there were some complications with the first trials. More recently, the overall safety outcomes are, and this is very tightly controlled. This is the kidney function year over year. You can see 3 years, the function was like not statistically different. So it remains stable. One important thing that they talk about is
the effect is always on. So you have turned this button on, so it's not like you take the medicine in the morning and 18 hours later the effect is gone. So this is always on phenomena for renal denervation. Simplicity, they have a 3-year registry. So, and then year over year, the effect actually improves up to 16 millimeter of mercury at 3 years, and 24 hours, 9 millimeter of mercury. And it's actually consistent across other disease states as well, including CKD. The biggest bang for the buck is either resistant hypertension or somebody who has very elevated blood pressure before you do the procedure. So last couple of slides. How do you actually do it in your system? So you confirm it that this is true hypertension. You rule out white coat. Of course, make sure there is no contraindication by the renal artery duplex in other studies. And then try to maximize the therapy first. And if that is not successful, this is one of the therapy that you have in your back pocket to use for those patients. So this reduces the sympathetic nerve activity. It is equal to one effective blood pressure medication if you add to the therapy, but the effect is always on. Add this to med control and lifestyle. It definitely needs careful patient selection, and you need a multidisciplinary approach. AHA this year, when they revised their guidelines, they included renal denervation in one of the guidelines and should be considered. So that's where after the FDA approval, AHA guideline, at least in Europe and US, more and more centers are participating. And I hope that at some point we bring this therapy to Pakistan as well. And I want to thank you for the opportunity. And I'll be happy to take questions at the end, right?
Thank you, sir, for highlighting where technology and physiology intersect in hypertension management. Now it's time for the next talk. Progress often lies in re-examining what we thought we already knew. An update on one of the most common yet heterogeneous glomerular disease worldwide. Professor Magdi Yaqub, sir, I would like you to come, please invite and come on the stage and enlighten us with update on IgA nephropathy.
Thank you so much. Thank you. Right, thank you again. I think by the time I finish, you'll be sick and tired of listening to me. So I apologize, already you've had enough of me. I promise you, this is the least controversial talk I'm going to do to you. And I'm not going to lose any temper or get emotional. Because it's a very straightforward, hopefully, talk which will be useful for most of you. Because just recently, as they do, they published the KDIGO guideline on IgA nephropathy. And it will save you guys reading 67 pages of this guideline for a condition which is very common. And I think it could all be summarized, in my opinion, in one diagram. But those people who write guidelines, they don't see patients because they are always in the air. They've got a lot of air miles. And when you read any guidelines, my advice is that read right at the end conflict of interest of all these people who write these guidelines. And they are pushing the drug in these guidelines where they are getting honoraria. So before I go anywhere, I am going to summarize what I think is IgA nephropathy should be treated and how the politics has gone into this as well. So now we know, but when I was a registrar, IgA nephropathy we didn't understand. To the extent that we just saw IgA in the glomerulus, we didn't know what that was, and we called it IgA nephropathy. There was no treatment. We just gave some supportive treatment. Mainly it was antihypertensive. And I think it is the best drug. Any antihypertensive for IgA still, possibly in my opinion, has got the longest evidence that it works. Which antihypertensive? We will come to that. So now we know a bit more, that it is an autoimmune disease. And it all came from the discovery that IgA1, remember there are two IgAs. One is IgA1 and one is IgA2. We are not interested in IgA2 because we don't even know what that does most of the time. So IgA1 is produced mostly in the pars patch. That's what we are made to believe. But every epithelial lining, which is the GI tract, tonsils, and even bronchial epithelial cells, underneath there are plasma cells which are making IgA1. So remember, it's not only pars patch. But pars patch has got the biggest publicity at the moment. They make IgA1. Some of that IgA1 is galactose deficient, which is present in all of us, by the way. But the amount of this galactose deficient IgA1 varies. In some people it's very high, in some people normal, in some people it doesn't even exist. This galactose deficient IgA supposedly becomes an antigen and mounts an immune response, and your body thinks that this is something different. It's a foreign protein, so they start making IgG. That's its second hit. These two then combine, and what happens? Immune complex is formed. When you get immune complex, in some people, if you've got the right Fc segment of either IgA1 or IgG, that binds to complement and causes immune complexes. Why this? This is the third hit, that do get complexes, and you need to have a right Fc segment to attract complement and becomes an immune complex. The fourth hit is that it goes and deposits in the mesenterium. Now, it is a systemic disease. It should be present everywhere, isn't it? Why poor mesenterium gets the bulk? And this is because of this receptor. It's a CD71. We call it CD71, but it is in fact a transferrin receptor. This is the receptor where your body goes and binds with transferrin-loaded iron and deposits in the bone marrow. This is how iron goes into the bone marrow. It is the same receptor. I don't know why it is in mesenterium, what is the evolutionary advantage. I've got few ideas, but this receptor is there. It got to get upregulated for it, fourth hit to happen, upregulation of this, and immune complex deposits here. Fourth hit. Now, when you have immune complex, you've got to bring complements in which we didn't have any clue when we were registrars. We saw a lot of complement, and we didn't know what that means. Now we know why. That if there is a complement, it means either these immune complexes are causing by classical pathway, immune complex disease, classical, like lupus, like any other immune complex disease. But it's not that simple. This galactose deficiency, or galactose deficient, even galactose deficient IgG4, remember in membranous context, IgG4 disease. It is IgG4 which binds to PLAR2. IgG4 is the weakest complement activating IgG. So how come you activate complement? And that is the reason how. That galactose deficient, which is IgA or IgG4, binds to mannose binding pathway of complement. It bypasses C1q, it goes straight to C3 convertase. And it's called mannose binding pathway. And this is the pathway where it is highly defensive. And I'll come back to it about IgA1. This is what causes activation. It is, in my opinion, is defending our body against infection by bringing in this complement pathway in all the epithelial surfaces. The story doesn't finish there. Any galactose deficient IgA or IgG can activate alternative pathways. And depending upon what sort of a complement you see on your biopsy, you can quite easily determine whether it is this. If you've got C1q with IgA, it means it is coming through this. If there is only C4D but no C43, it is coming from Manos, and if it is only C3 and no C1q, it is alternative pathway. Very simple. If I can just simplify, only C3 with IgA, possibly this. Any C1q, it can't be these two. If it is C4D as well as C3, it got to be Manos pathway. Now come to the main political bit. IgA, we say, is the commonest glomerulonephritis in the world. And look at the incidence. The global incidence is 2.5 per 100,000. The incidence of IgA is highest in Asians, 2.7 per 100,000, and lowest in blacks, which is 0.1 per 100,000. Is IgA a rare disease? Now, this is where the whole FDA discussions happen. And it is very important to understand that a rare disease definition was derived by pulling a number from the air. And it was said that if the incidence of any condition, which could be IgA, which could be any rare genetic condition, if it is less than 1 in 2,000, it will be regarded as a rare disease. Now remember, this is the most important point. Why we needed that definition? Because the drug companies were not developing any drugs where their sales will be very, very low. And there are strict criteria that if you develop a drug, both by America and us in UK and as well as Europe, that you meet certain criteria. So for example, in UK, the cost of the drug should be less than £30,000 per collie year. If the cost economics comes that say that it adds 1 collie year, but the cost of that would be less than 30,000, you get approved. So the drug company will charge in a way less than 30,000. In order to make profit, you need to sell a lot of drug with that cost. In America, the level is $50,000 US. In order for drug companies to encourage develop drugs about these rare conditions, this was lifted, that you can charge whatever, but develop a drug. Remember what I told you. As soon as that law was passed, floodgates opened. And this is what we are going to go through. We have heard this from Raj in the morning. I think one of the best paper published, and C. Jason, was, and that was again, the gun was put by the pharma industry, that we are not going to develop any drug till you approve a surrogate marker. We don't have the money to do 5-10 years studies because the rate of progression is very slow in most of these rare conditions. So we had to adopt a surrogate marker, and this is what this paper suggested. That if you get all these studies, and when they looked at the rate of decline of proteinuria, and then they looked at the rate of decline of GFR, they found that if you reduce your proteinuria by 30% at 6 months, with whatever strategy, no matter what, that translated into a better renal protection by reducing the eGFR decline. That was adopted for drug development. If a drug is marketed and it reduces the proteinuria by more than 30%, it was assumed that they will translate into better renal protection and reduction of end-stage renal disease. And as soon as after 6 months they show that the proteinuria has gone down by more than 30%, they get a license called orphan drug. The drug company already gets the license while the study is ongoing. So that is a bit of politics for you. And what this rare disease, because the drug will be very expensive. Remember, we have lifted the cost. You can charge whatever. So they collected the data. This is the pharma industry data, where the IgA nephropathy is prevalent. And they have chosen the country who could afford to pay for it. They have not chosen Pakistan, which is very common. India is not there. South Asia is not there. They are the places where there is IgA nephropathy very prevalent as well. Look at the 4 regions chosen. They are targeting EU, US, Japan, and China. The drugs which are being developed in IgA is for this population. Because they are the countries which will be able to afford the new drugs which I'm going to mention. Pakistan is not the country where you'll be able to afford them. So I'll tell you, but just listen, it's not for your country. Until and unless one of your politicians was to be down with this condition, okay, and he comes to UK, because none of your politicians gets treatment in this country. They fly there, and it is sadly the summary of your health system that your own rulers don't trust your health system. Now we know that what level of proteinuria is risk. When I grew up, I said anything more than 1 gram per 24 hours was bad. Then it was reduced to 0.5 gram. Now we know from this very big UK study that even less than 0.5 gram with IgA means bad news. 1 in 25% of the patient will be on end stage in that group over 10 years. So any proteinuria is bad. And this is the way you are going to manage IgA in future, according to the guidelines as well as my indication. First, you will do what we do already, hemodynamics, control the hemodynamics within the glomerulus. Second thing, when the immune deposits are there, before you start doing anything, you'll just prevent the damage it does, like in vasculitis. You give anti-inflammatory agents to reduce the inflammation in the glomerulus before you go after ANCA or PANCA. So you give anti-inflammatory drugs to calm down the inflammation in the glomerulus. Then you go after reducing the production of galactose-deficient IgA. Usually we do this both in parallel. And finally, we want to be anti-fibrotic. Those therapies are being developed and they are not yet even phase 1 yet. So these are the 4 pillars of IgA nephropathy. Glomerular hemodynamics, reduce inflammation, reduce the production of antigen. Remember, this is the difference. In immune complex disease, we reduce the antibody. We are not reducing antibody here, which is IgG, which what we do in lupus. We reduce anti-double-stranded DNA. We reduce ANCA level. Here, we are reducing the antigen. That is the difference between immune complex and this. This is my beautiful diagram. This was the diagram I fell in love with, and I became a nephrologist. Okay? In all my books, this diagram is there. It's very simple. We know there's an afferent arteriole, there's an efferent, and this is the glomerular pressure. And in a normal person, usually, and having done micropuncture studies myself in Boschweier lab, you'll have to trust me that everything what I'm going to say, I have done it with my own hands. I put a needle here, I put a needle here, and I put a needle and measure all the pressure. Usually, no matter what you do outside, pressure within glomerular capillaries remains 70 millimeter of mercury. And it is not like in the initial part throughout, same. That is called autoregulation. That is the difference between glomerular capillary and any other capillary in the body. Capillary pressure is higher at the initial phase and falls at the tail. Because at the tail, fluid goes back into the capillary. Here, you want filtration throughout, so the pressure is maintained. And this is how macular denser. And we have learned now that this macular denser, my very good friend Farouk just now was talking about denervation. This is basically a receptor for sympathetic nerve system. Okay? This is the reason we have found. And we have also found vagus nerve fibers here that will put all the denervation etiology in context in future. All this is happening, but in chronic kidney disease, I did 5/6 nephrectomy and said, what happens? When the nephron mass goes down, this dilates, this constricts, and this becomes hyperfiltration. So you do more filtration to maintain GFR. And we want to reverse that because any glomerular hypertension and hyperfiltration eventually, like hypertension, when you have got hypertension, you get atherosclerosis in it. You get sclerosis in the capillary, and you get FSGS and sclerosis. Now we have got tools to reverse that. You can give ACE inhibitors to dilate efferent arteriole. By giving SGLT2 and bringing adenosine from macula densa, you cause vasoconstriction of efferent arteriole. And now we know that endothelin receptors are also very present in efferent, so you need to block that. So we have got 3 agents by which we can restore the glomerular pressure to around about 70 millimeters. And how you will determine that you have achieved, look at the proteinuria. When the proteinuria is less than 0.5 grams, I would assume that you have achieved the pressure which should protect that glomerular capillary, even though your GFR will decline, but that's what you want. You want GFR to go down so that doesn't cause problem in the future. Let's go to ACE inhibitors. This is what you have got to show for ACE inhibitor studies. These are all ACE inhibitor studies in IgA nephropathy. Remember, these are the pre-rare disease classification of IgA. Most of the studies were done single center or 2 centers. Most of those studies were done placebo-controlled. They did not even use another antihypertensive. All ACE inhibitor treated patients had 3 to 4 millimeter blood pressure less than the placebo. Despite that, the latest Cochrane, which in my opinion are the best unbiased reviews they write, what have they said? Probably reduced proteinuria may result in little or no renal protection. This is your gold standard first to go therapy in. And I always say that any blood pressure tablet which controls the blood pressure will give you the same effect. Because those studies have never happened in IgA. Then came SGLT2, which is glittering even despite not being gold. These are the studies which were part of DAPA-CKD and EMPA-CKD. They included patients with IgA. And they did post-hoc analysis, which has never been accepted as a guideline up till now. You need to demonstrate efficacy in IgA nephropathy itself, but they were part of big 2 studies. In DAPA, the proteinuria went down by 26%. And in EMPA, exactly the same study, proteinuria went down by 15%. If these studies were done in primary IgA with SGLT2 on top of ACE inhibitors, the requirement is you've got to demonstrate proteinuria more than 30%. Even in post-hoc analysis, they missed that mark. They would not have been approved. But guideline writers said that there is no harm. There is harm, but there is no harm. So that has become a second agent to go to. If you get IgA with ACE inhibitors,
Sir,
and then proteinuria is not gone down, you add SGLT2.
Sir, 2 minutes remaining. We are running short of time.
I will talk till I drop. Okay? You stop. Then came sparsentan. This is the drug which has got a combination of ACE inhibitors, ARBs, properties of ARBs, and endothelin ACE, one agent which has got both. Right? And that, I think, is an eye-opener. for you guys. We have been seduced to saying that ACE inhibitor is the best antiproteinuric agent in every drug, isn't it? That's what you do. I do that. Now, this is the first study where they compared valsartan in the maximum tolerated dose against sparsentan, which also had valsartan type effect plus endothelium. So I would have expected that valsartan should have given me more than 30% drop in proteinuria. And whatever more I got with sparsentan would be good, isn't it? We got 15% decline with valsartan. That is the control arm. And we got sparsentan more than 40%. I rest my case. If valsartan was launched today, and instead of sparsentan, you had used placebo, FDA would not have approved valsartan as a drug for IgA nephropathy. This is the only, just remember, sparsentan is very expensive, so another company came and said that we will just build atrasentan, which is only endothelin, and we will add that on ACE inhibitors. It shows the same. It works. And again, look at the drop you get with ACE inhibitors. Now we go quickly. Inflammation. The study, which I think was very well done, but they overcooked it with the dose, but the second phase was very good, and I still recommend that in a country like you should use it in select cases. They use methylprednisolone, but whatever the dose, 30 milligram of prednisolone given for 6 months, but with protection, with particularly Septrin against PCP. It works. And the results are as good as the new modern drugs. By the way, sparsentan, the annual cost is $110,000. Okay? And steroids doesn't cost much. It's only given for 6, but you have to be vigilant. And the reason why these people get infections is because IgA1, galactose deficient, is a better mannose binding molecule and is more protective against the infections. That is the evolutionary advantage to this region. Having galactose deficient IgA1 is more protective against parasitic and GI tract side effects. This is where the glitter is, iptacopan. This is 60,000 pounds a year, oral drug which inhibits factor B, which is again anti-inflammatory and prevents complement activation, reduces complement activation. Again, works. It does what it says on the T, because this is what the pathogenesis is. Have you got 60,000 pounds a year? And we still don't know how long to use it for. We have started using it, by the way. Now we go on to another mega clever drug. Now we want to stop the production of antigen from Piaspech. And this budesonide, which cost £1, was converted into a target release molecule which will be released at Piaspech. That's what they tell us. They develop this drug and they say that it is released only at Piaspech, so it will only work at Piaspech and reduce galactose deficient IgA1 production. Trial was for 9 months. It did reduce proteinuria, got licensed. This got licensed. The cost of 9-month course is £56,000. Okay? But all the patients in my unit we got in the trial, they were all coming back as Cushingoid. We were told that budesonide doesn't get absorbed. But when you release it in the ileum, 20% of that budesonide gets absorbed. So was it the absorbed steroid which was causing the problem? Was 20% of the 16 milligram will equate to 20 milligram of prednisolone. What is the difference between this and the Chinese study which gave 30 milligram of prednisolone? And after 9 months, you can see proteinuria started going up. It's not sustained, but still we have got the license. Another drug which is cheap for you guys, again come from China. They've used MMF, 750 milligram twice a day, without steroids, on its own, for 9 months. And it reduced the proteinuria, more than 30%, with renal protection as well, with EGFR. If that drug was a new drug, it would get licensed by FDA, but it is already licensed and it's out of patent. It's cheap. So Chinese did it, and it works. Now is the battleground. We are now going for serious money, right? We want to block all these pathways, which is APRIL, BET, B lymphocyte, everything will be gone after. And one of the drugs which has recently been applied for getting a license is etacicept, which blocks both APRIL and BET. And this is what the results are. It works. We don't know how much it will surprise, but I'm sure it will be in excess of $100,000. There's another drug called SIBI, works only at APRIL, phase 2 or past phase 3 is going on. So, in brief, this pathway, we can alter all these pathways. But we don't know which drug will work for which element. And this is where we will have to modify MES histological score and also get a very good assay for galactose deficient IgA1. It is available, but not every lab can do it. All the latest studies in IgA1 are mandated to show that galactose deficient levels go down. It's a very simple assay. It's an ELISA. There's an antibody called EM55. You can both do histology as well as you can do in the plasma. So this will be modified. What I do, I just do common sense. Simple. And where I don't understand, I just randomize them into another trial to get more people. If it is complement-rich environment, which is showing alternative pathways, as I said, it's only C3 in IgA, but no C1q or C4d, I will go for a tractopamine. This all depends upon what is. IgA1 is not a single enzyme, it is heterogeneous. That's what we need to learn, that how we are going to use which drug for which patient. One thing will show that you can quite easily go with either ACE or any alternative antihypertensive. Bring the blood pressure down to less than 120/70. That should be your target. Then you can move on to steroids or whatever. And when you are doing glomerulonephritis treatment, don't forget the heart. You need, any proteinuric patient is a high risk for cardiovascular disease. And thank you. And I apologize. Because I've saved you reading 67 pages of that rubbish. Okay? Maybe I gave you 30 minutes, but I think you will appreciate when you start reading that rubbish.
Thank you so much, sir, for a clear and clinically grounded update. Now, the last arc of this session. Peritoneal dialysis offers a physiologically sound and underutilized option for managing refractory ascites, especially in patients with concomitant kidney failure. This talk will explore its rationale, practical considerations, and clinical outcomes. This presentation will highlight the innovative use of PD in complex clinical scenarios. Dr. Malik Abdurrahman is invited to speak on treating ascites with peritoneal dialysis.
Hello, Assalamu alaikum. Today we'll be talking about a very common scenario that you might face despite of the complex conditions that you treat on daily basis. I'm pretty sure that in all of you, in all your practices and hospitals and your clinics, you would routinely see an ESRD patient with the ascites, and these patients are usually very neglected in a sense that there is not a lot that we are doing for them. So, and these patients, they are coming back again and again with the hypotension on dialysis and poor quality of life and all those things. So I just, not that it's not done before, I just started working on this a year ago, and I started treating these patients with peritoneal dialysis, or I would say I started treating these patients in general so that their quality of life is, improves. And I was lucky enough to face very good outcomes, and I'll be sharing those outcomes with you today. So just a brief overview, I won't bore you much, but like for a dialysis patient or an advanced CKD patient, I won't say dialysis related ascites, I would say nephrogenic ascites. A patient coming to you, so what could be the cause of that abdominal swelling if it's of those ascites? So nephrogenic ascites is, to be honest, is a diagnosis of exclusion. Most of the times it is actually nephrogenic ascites, but it can be a lot of other things as well. Patient can have cardiac ascites and all those things. All you have to do is take a good clinical history and then put a needle in and just get the sag levels. Make sure that out of this list, patient is not suffering from any other form, like is not suffering from cirrhosis and is not suffering from cardiac ascites. If you're not left with anything, then it's nephrogenic ascites. It's a diagnosis of exclusion. But if you want numbers, you would find that that patient will have a low sag with a high protein. So make sure that you do the ascitic fluid protein as well. So now that you know that how to diagnose these nephrogenic ascites, another thing is that how do these patients, they get these ascites? It's very simple. Chronic uremia, hypoalbuminemia, and all those things, you're looking at that. So what, usually these are very, you must know all of them, but how urea does this is a very interesting phenomenon. So the uremic toxins, they exert a degree of oxidative stress and cell apoptosis at the level of the submesothelial layer and the capillary endothelium of, and those capillaries are in the peritoneum, so the peritoneal blood supply. So all these mechanisms and the effect of urea and all those things, what it eventually leads to is the manifestation of ascites in those patients. So coming to what should we do with them? So a simple and the most common thing, and I'm pretty sure in Pakistan these patients, they get enhanced thrice weekly dialysis because most of them, they are already on twice weekly dialysis. So, and other things, what we tell them is like restrict their fluid intake and salt intake and all those things, intensifies the hemodialysis. To be honest, this rarely works, and you know that this rarely works or this poorly works, except for those patients who are even non-compliant with twice weekly dialysis and are getting once weekly dialysis. They do get better, but most of the time this won't work. Another thing you can do is the shunts, but it's rarely done. Another thing, I must mention that it's not PD, it's rather kidney transplantation, which is the actual way of treating these nephrogenic ascites once the patient develops them. But the thing is that a patient who is poorly dialyzed and is getting nephrogenic ascites, there will be other reasons that will stop him getting a transplant because he will be in a poor state of health. He might be suffering from a lot of other things. So, and I've successfully done it as well. I think you would require PD in all circumstances because even if you are going to transplantation, you would require a bridge before you would go to transplant to stabilize the patient. So, we already talked about this. And so I'll be sharing my experiences about like a dozen of patients that I have treated with nephrogenic ascites or ascites of further region with peritoneal dialysis. So when I started this, the first thing that came to my mind was there was very limited studies and data I could find from internet. So I was thinking on my own that, okay, I'm going to start it, what's going to happen? So I was thinking about the worst case scenarios. The first thing that came into my mind was, okay, the patient is going to have pericatheter leaks because you know these abdomens, they are really distended. And this is what I anticipated prior to starting that. And the other thing was, I was worried that patient would get hypotension while I would drain the fluid out of the abdomen, just like he was getting hypotension on the dialysis, because he was unable to get the dialysis because all the fluid was in the third space, i.e. the peritoneum, and those patients are poorly dialyzed then. And it's a vicious cycle. They get ascites, the future dialysis, it gets poorer and poorer and poorer. So, and the third thing I was concerned was that whether the peritoneal dialysis will be effective in this case, because the peritoneal membrane is already, due to the long-standing ascites and uremia, is it already damaged? These were three concerns of mine prior to starting that. But I studied over that and I started it because, to be honest, there was no other thing that I could have done. These patients, usually they are having a blood pressure of 90 or 60 or something like that. So they're barely making it. So anything that works, it actually works for them. So that was the starting point for me. So what I did was like percutaneous catheter. As I told you, these patients are not fit for GA. These patients are really in a poor state of health. How can they actually go directly to transplantation? I can't even get a laparoscopic, I can't even concern the anesthetist and the surgeon to put a laparoscopic catheter in, because he would say the patient is too sick for that. So definitely percutaneous catheter, and these are the patients you should start putting peritoneal dialysis catheters in. Very easy. Just prick the needle, and the catheter will be in, because there is already a medium protecting you, pricking the gut, that is ascites. So I did percutaneous catheters under fluoroscopic guidance in all patients, and I completely drained the ascites over the next 48 hours. And I would drain 3 liters or 5 liters, 10 liters, whatever I wanted to, as long as the patient was tolerating it. And only gave albumin if the hypotension was worsened, or I was draining more than 5 liters of fluid at a time. And I would bear in mind that I won't start PD until I would empty the abdomen first from the ascites. So, as I already said, immediate start PD plan, no catheter and break-in period. Usually you put the catheter in and then you wait for a few days for the cuff to heal. But in this case, I couldn't wait for like 2 weeks or 1 week, because the patient was already sick. He was already not getting dialysis, so I had to do something for them. First 48 hours, I would just empty the abdomen. That's it. Second thing, these were, again, the things I was worried. Okay, so now coming to the outcomes, that what I ended up with. So, to be honest, ascites control, it was excellent in all the patients. I just put in the catheter, and I drained in 2 or 3 days, batches at a time. I used to admit the patients, drain 3 liters, 4 liters, wait for a while, wait for a few hours, let the next nurse come in, and then just do a job. And then the third shift, nurse coming in her shift and doing a job of draining the ascites, and that's it. Not that I just wanted to remove all the fluid in one single setting. And it was good. The patients, they did tolerate it. I never faced a lot of complications. I'll come to the complication that I actually faced. But I am just, at this level, I'm just telling you that what actually happened. So, ascites control excellent in all patients. Patient continues to produce ascites. So, after the first 2 days, I stopped draining the ascites. I started putting in 1 liter of fluid, small exchanges. But every morning when the patient would start doing the PD, he would tell me that, okay, there was 1 liter fluid coming out of the abdomen in the morning. So, what was happening was these patients were actually producing more ascites. The peritoneal cavity acts as a dump. The good thing about ascites is the patient will not get peripheral overload. They will get it, but it will be improved. The patient will not pour into the lungs. The peritoneum will act as a dump, because now your capillaries allow fluid to go into the peritoneal cavity, and now you have a place where you can just directly do all the ultrafiltration from. So my patients initially were doing small exchanges, and daily in the morning they would get, say, 600 or 700 milliliters of fluid out of their abdomen, and that was they were ultrafiltrating, although it was a really bad ultrafiltration, but because the protein count would be high. So I did put them on a high protein diet for that, and that was the only thing I could do about it. So now coming to one of my initial concerns, as I told you, protein losses. To be honest, it was a very small number of patients. I told them to eat as much as they can. The PD fluid, it has got glucose in it, so it gives a drive to put the protein intracellularly, and that was it. And overall, the nutritional status remains stable or improved despite ongoing PD, because their dialysis was so inadequate and they were so poorly dialyzed that they were not eating anything to begin with. And so once the mechanical effects of the fluid of the ascites was taken off, their appetite actually improved and their protein intake actually improved. Technical catheter leakage. So I didn't observe any leakage. I have passed almost 15 or 20 catheters in patients with ascites. I've never faced catheter leakage. And the reason is that I don't go through the linea alba, just go through the rectus muscle, just save the epigastric vessels, and trust me, you won't get any leakage. The rectus is thick enough to do that. And the other thing is that in the first 24 to 48 hours, I'm taking a lot of fluid out, removing the pressure in the abdomen. So leakage, I never faced leakage. I did face leakage, the soaking of causes and all those things, but it was not significant. Peritonitis, no episodes of peritonitis was observed as long as they were in the hospital with me for the first 3 or 4 days. Some patients that did presented with peritonitis, but I think it was late enough, and the rate of peritonitis was equal to my other patients who are on peritoneal dialysis but not having ascites. That is like in my Pakistani experience, I think every patient comes to me almost 2 times per year with ascites. I have no numbers, but that's what I think of. Now coming to the most important thing and the worst fear that you all have. What would happen if you will remove the fluid out of the abdomen? Will the BP go down? What if I told you, no, sometimes it will go up, sometimes it will go down? How to know that when will the BP go down, when you will do the ascitic tap, and how to know when it will not go down? And it applies to the therapeutic ascitic drainage, not only on peritoneal dialysis, but other ways as well. So blood pressure, I did I had to give albumin to 2 patients while I was draining the fluid out, and most of my patients, their BP blood pressure stayed same, very lowish, and I never had to stop PD because or draining the fluid out because of the hypotension. 1 patient died, but that patient was already in a septic shock due to he came to me with an infected tunneled catheter, and it was not working as well. So it was clogged as well as infected. I took out the catheter, started him on antibiotics, but for renal replacement I started him on PD. He actually died, and he couldn't sustain the removal and fluid and blood pressure, but that was a concurrent septic shock as well. So overall blood pressure improved in all the surviving patients. And actually some of the patients, after a few weeks, they would require antihypertensive mechanism. So it's in a single statement, this suggests restoration of effective circulatory volume. The peritoneum stops acting as a dump of water. The vessel then stays in the fluid then stays in the vessels. So in a very small study of mine, and I choose personally I have a thing for these patients, and I choose the patients who are not getting treated anywhere else. So one of my patients was had hepatocellular carcinoma. He is already dead. One patient has septic shock. He died as well. The rest of the patients are alive, and they're doing very good. Now, what happened with me was that after 3 or 4 months, some of my patients started complaining that it's very expensive. Pakistan is a resource-limited country. So what I did in those patients is that they get hemodialysis now. When they come for hemodialysis, my dialysis technician just uses a bag, drains the fluid out. These patients get hemodialysis as well as peritoneal dialysis. Now their blood pressure is improved. Now they're getting hemo, but 1 session of PD per week where I take the fluid out. And the reason why I had to do this because I had to maintain the catheter patency as well so that no fibrin gets clot. Just to finish, because I think I'm short on time, 5 minutes left? So I have 3 minutes left. I will just tell you just one important fact, that in what patients blood pressure improves with the ascitic tap and in what patients it does not. So there is a group of patients in which the pressure of the fluid in the abdomen is so high that it's compressing the IVC. And that pressure of IVC would cause a decrease in the right ventricular preload, and that would cause the blood pressure to be down. When you take this fluid out, when you're taking the pressure out of the IVC, sometimes in very few patients, I am not confident about this because the patient number is very low, sometimes the blood pressure goes up. Now, those patients who have a reserved cardiac output, who have a good heart, they would actually tolerate it, and then they will be more hemodynamically stable. But a patient who has a mixture of cardiac ascites, a mixture of cardiac failure as well, mixture of diastolic dysfunction, those are the patients that will actually become hypotensive. But I think the draining the fluid out of the peritoneal cavity, as far as I'm concerned, never was a hurdle for me to put those patients on PD. Actually, the message I just want to give is that for the patients who are just lingering on and having poor dialysis, I think PDs are just a remarkable thing, and these patients actually deserve to be on PD, and they don't deserve to be on hemodialysis while their blood pressure is 90 over 60 or 100 over 60 with a swollen abdomen. It does not make a real sense that you're filtrating their blood when actually they're dumping the fluid into the peritoneum, and you're trying to pull more water out of that blood, and they are already intravascularly depleted. So my message in Pakistan, nephrogenic ascites is very, very common. Every unit will have 2 or 3 patients, reason being poor country and a lot of patients with this diagnosis, and we need to put them on PD, and we need to pass PD catheters in. It's very safe, and you actually have this ascites in the peritoneum, and you are far from the gut as well. So that's what you need to do. I just faced one issue in this, and that was that catheter malrotation. Catheter would displace with the fluid. So now I have a new strategy. I put a double lumen catheter in, fluoroscopically guide into the deep pelvis, drain out the fluid, and over next 2 days, I would override a CAPD catheter over it once I'm done draining the fluid out. So that's the only strategy I adopted, because otherwise, if you directly put a CAPD catheter in a patient who has a very large belly, trust me, you will end up losing the catheter getting stuck somewhere with the gut. That's what I've seen with experience. Now I do it this way, and this is it. If you have any questions, you can ask me later, and please make sure that all these patients, they get this beautiful and easy treatment for them. Thank you.
Assalamu alaikum. Umar, thank you so much for highlighting the renal denervation updates. I was wondering, what's the criterion that you select in practice for watch and much? So like the white coat uncontrolled hypertension and the mask uncontrolled hypertension, because it seems like the European Heart Association's updates and the US ACC updates haven't really reconciled with some of that terminology. And yet it seems like you alluded to the fact that when you do have white coat hypertension, you exclude that from the resistant category. But what about those who have white coat uncontrolled hypertension? Is that a category that you deal with in practice, or is that just a guideline by guideline developers to keep us confused?
So the question is, what is white coat hypertension? What is masked hypertension? And what is white coat uncontrolled hypertension? Okay. Is that a thing? When you have white coat uncontrolled? Uh-huh. Yeah, I didn't read those. Mm-hmm. So no, that's a good question. So renal denervation device space is like you have to exhaust all the first line, second line, and then go to the third line. Even if there is a secondary, like somebody with hyperaldosteronism, you should treat that if there is like other causes. So I don't know the best answer to this, but to me it looks like that you have to go with the ABC first and then go to the denervation if they are truly resistant. But once they have hypertension and it's resistant, I wouldn't call it white coat anymore.
That none of the drugs patient can tolerate. Tried every drug. And I personally think that those are the type of people we should be offering this treatment, which is for me the attraction, that then you can reduce the pill burden, and that is a highly select group of patients. What I think Mustafa is asking, that you get hypertension, white coat hypertension, which is high, which is okay, and still when he goes and does his otherwise smartwatch or whatever, is a bit higher. That would be called uncontrolled. Controlled white coat is that when he goes home, everything is okay. Mask, we know what it is. So I don't think so that there's any case for those patients to be in this. You're right, A, B, C, D, whatever. But I personally have done few or referred few who cannot tolerate any medication. And I think those are the type of people who we should, I think they are the ideal one for this. I personally think there's a lot of placebo effect still, even though sham operation and the effect is much less. Even those who had sham, why don't they become more compliant? Nobody has looked at the drugs. Have the lung levels got better? There is some placebo effect of even sham with the blood pressure does drop. So they do become more compliant with therapy. Whatever, I don't want to count the trees, I want to eat the banana. I just have blood pressure control and the patient is happy.
I conclude that I have the patient I have in trial is this exactly the same, could not tolerate more than 1.5 drugs. So one drug at the maximum dose, other drug, the moment you go above 20 milligram, he gets symptoms, so we enrolled him in the trial.
One quick follow-up was, for device-related, trials, is there still room ethically in 2025-26 for sham control, where you give incisions and do not give that actual signal or the actual radio frequency ablation or whatever? Is there still a role, or I think these are now ethically not kosher anymore?
Sham control, I consider this as the placebo. This is your control arm which is on placebo. So as I mentioned in the sham, one is patient is taken to the OR and you just take, you don't do anything, just a skin cut and a band-aid. The other one in the protocols which we did, everybody got renal artery angiogram to look at the anatomy, to look at everything. The sham one did not get the procedure, the others got the procedure done, the actual study arm. So sham is just a placebo control arm, nothing more, nothing less.
Mustafa, our cardiologists were very, very naughty in doing a non-specific chest pain, did an angiogram, found a little bit of coronary artery disease, and went the balloon. Okay? And the insurance company got sick and tired. And then they insisted that we should do a placebo control trial. What the placebo, the wire went in, no balloon, versus balloon. 3 months later, angina symptoms, no difference. That study, because Americans didn't believe it, but they believed to get angiogram. They did exactly the same study, because anything which is done in UK got to be repeated in America to satisfy American audience. They found exactly the same. But they have come with some caveats, because money making does not stop there. So they are saying and they're questioning and everything. But I personally think that all the interventions we do in our patients, there is a place for that. Because there is a lot at stake. You need to put a wire and then see whether it is a proper placebo. And it is shown by simplicity first. The blood pressure drops for 15, 20. I've never seen that blood pressure. And when they did the placebo sham, it all disappeared. And the program was suspended for years before they revisited. Now the modest degree of blood pressure, yes, it is good, but I personally think that there's still room for placebo control, interventional placebo control for all this. And you will see more and more of this, in my opinion.
Do we have time for more questions?
So no more questions. We are running out of time. Sorry, sir. Okay. Okay. Okay.
Thank you very much. In a way, I could understand the electrophysiological, the cardiologists, they have been doing radio frequency ablations of the accessory pathway. In a way, this resembles that or this differs from that? So we are electrophysiological nephrologists as well. Thank you.
Thank you so much,
thanks
sir.
to speakers, and with that we end this session.
Now I would like to request the chair and the co-chairs to please come on the stage and present the shields to the presenter, Professor Omar Farooq and Dr. Malik Abdur Rahman. Thank you, sir. Thank you so much. So now it's time to get lucky. And as you know, it's based on attendance. It was a heavily attended session with 126 attendees. So let's see who wins.
चल रही है वहां से
Dr. Muhammad Sajid. Okay. Dr. Kiran Shahzadi. We now move into another industry symposium supported by CCL Pharma. It will be comprising of 5 minutes of talk, followed by MOU signing. And at the end of the symposium, there will be another lucky draw supported by CCL Pharma. So for the talk, I would like to invite Dr. Sajid Rafiq Abbasi. He will talk about the B-cell depletion therapy in nephrology.
Bismillah ar-Rahman ar-Rahim. Thank you very much, PSN. Thank you very much, all the organizers. And thank you very much to my audience. First of all, I would like to say there are no conflict of interest. And I would like to say, hopefully, everyone would be enjoying the nice weather of Islamabad. And I would like to say my message to all the members of PSN, please
keep on voting because election is going on for the CEC members, so keep on voting. Please, I would like to call all the panel of experts. Can you give me the name? Who are the panel of experts for this session? Gigi.
Dr. Nisar Anwar from Peshawar, Dr. Samijay Khan from Islamabad, Dr. Izazman from Lahore, Dr. Amir Azhar from Peshawar, Dr. Tasaddu Khan from Karachi. Thank you.
So today I would like to talk a bit about the rituximab. So you know that in the last few years the practices in the nephrology has been changed and we are going more towards the monoclonal antibodies. And so before I start my talk, I would like to ask how many of you from here, the nephrologists, you are confident while using rituximab? So I think quite a lot, so that's good. So basically this is just to review and I would like to just see that what is the evidence and how we have come to this. So this is just before I start my talk, I would like to talk about few of the cases. So these are the real-time cases. So the classical case of ANCA, so you can see that the crescentic GN, the patient presented with a mild renal impairment, ANCA positive. So what do you think, what should be the treatment of choice? Okay, so you want to use the cyclophosphamide, the creatinine is around 2 with a classical crescentic GN on renal biopsy more than 50% of a fibrocellular crescent. So let's see at the end how we treated this patient. So another patient, the classical, again the crescentic GN, so patient landed in it initially with a 5 to 6 creatinine and finally progressed and finally required dialysis. And again, it was a rapidly progressive GN. So what should be the treatment choice? Okay, so you think plasmapheresis, and what else? Okay, done. Nothing else? Sorry? Okay. Okay, so this is the third case. He is a 46-year-old male with a history of body swelling. So this is a classical membranous nephropathy. So only the different one here is that this is a, you can say it's a high-risk membranous nephropathy. PLA2R is a very high risk. But he was a TB gold positive. He was engineer by profession. And the only issue was he was not very much comfortable with the cyclophosphamide. Okay, so let's see how they were treated. So this is the classically how the glomerulonephritis, we know that these are immune-mediated diseases. And if we go back and see how the treatment evolved over the period of time, we know there was an era when the treatment, the standard treatment were the steroids. And then when the treatment was evolved, initially we see that more or less the cytotoxic agents, they were the standard of the care. And the most popular was the ponticillin, the cyclophosphamide era was, there was a long time when it was standard of the care. And finally now we are coming to the, so this is what probably the slide which explains everything. So we can divide the treatment era in the I think in 3 eras. So pre-2000, the more the steroids and cytotoxic agents. But with cytotoxic agents, what was the main problem? So that was more side effects. And if we go after the 2000 era, we see that CNI predominantly, we treated most of the diseases with CNIs. And now we are coming more towards the biologics. Why the biologics? Because it's a more targeted approach. So let's see. And what are the bases? Because we feel that the B cell differentiate, basically in all the immune-mediated, or most of the GN, the B cell plays the role. So so what is the main? The rituximab, if you look at the rituximab, the main is the rituximab is a chimeric monoclonal antibody. 1 minute, that's it. मेरा टाइम टोटल कितना है? बस फिर मैं एक आधे 2 स्लाइड्स ही हैं मेरे पास. अच्छा, मुझे तो बड़ा कम टाइम दिया है. So this is the evidence we have. So landmark trials, from where we got, this is in membranous nephropathy. The main trials are, we know, I think all of you know, the Gemritux was the first trial, the Mentor and the Starman trial, where they showed us superiority. And this is the Recyclo, again showed that where it was compared with the cyclophosphamide, showed us the superiority, basically non-inferiority trial. And Mentor trial was the landmark trial, where it was proven that initially the results at the 12 months, at the 1 year were the same, but in the long term you see that there were more, as compared to the cyclosporin, the remission rates were much better. So I think everyone has gone through this slide, and we see that rituximab in the moderate risk and high risk is the drug of choice. And CNI as well. So this is about the ANCA. So I just want to see that this is how the treatment in ANCA was evolved. So when I was talking about the ANCA, so what to use in ANCA? So the cases I was talking about, that when the cyclophosphamide should be preferred and when the rituximab should be preferred. So these are the guidelines. So I need to skip now most of the slides, but so here पीछे नहीं जाती हैं कोई, मेरी तो सारी स्लाइडें आगे ही करा दी हैं आप लोगों ने. So I think I want to discuss one point over here, that in few of the patients we see that there is resistance to this rituximab. And the reason for that is, and probably I think most of you who are using this rituximab, they feel that the patients are not responding, and that resistance is due to the, because there are either antibodies or there is we call it it's due to the pharmacokinetics, and that's the reason that there is a failure to the drug. So this is what my key home message. And then if, for example, there is a failure, the next generation drugs we have, that is abantuzumab or the ofatumumab, they are available. These are the two slides. And what is the future in the, we see, our 3 patients, I was talking about, all 3 patients, they were treated. The first patient, he was treated only with the pulse steroids, with rituximab, and the patient went to remission with a normal creatinine. The second patient was treated with a severe renal injury with steroids, cyclophosphamide, and with rituximab. I personally use all the patients with, I use only cyclophosphamide 2 doses, generally with 15 milligram per kg, and with a rituximab, and for the remission maintenance, I also use the ritazarin protocol. So that's why I always feel comfortable with this one, because I feel that actually decreases your exposure to the cyclophosphamide. And the third one, basically, he was not willing, initially was started on a tacrolimus, he was non-responding, and he was not willing to go for a cyclophosphamide, and that's why he was treated for the latent TB and given the rituximab, and finally went to the remission, and there was no activity of the tuberculosis. So this is whatever I think Professor Magdi Yaqub has highlighted all these treatments, but these are the B-cell therapy for the future. This is what we see, whatever the future is coming. So all the future is, personally I feel that the future, all the nephrology future would be monoclonal antibodies, whatever is coming, ASN, the future would be the monoclonal antibodies, whatever in all, summary of, so IgA nephropathy and treatment. So new horizons in the treatment of membranous nephropathy. So any question and comments? So I think maybe some of you have already have fun at the snow. So this is the Department of Nephrology. Thank you very much.
Thank you, sir. So now it's time for MOU signing, but before that, there is a one important announcement that at the end of the last session, that is, which is after tea break, there will be 4 lucky draws. So let's see who will win and who will be 4 luckies who will get those mobile. So there is a MOU signing between PSN and CCL Pharma to strengthen academic collaboration and enhance clinical skills, knowledge, and professional competencies related to dialysis care across the Pakistan. For that, I would like to invite Dr. Zahid Nabi, Dr. Aizaz Man, and Dr. Sami Jehan from PSN, and Sayyid Umar Maroof and Mahmood Hassan from CCL Pharma to please come on the stage and sign the MOU. At the end of this MOU, there will also be a lucky draw supported by CCL Pharma. I would like to request the panel, please stay here for the lucky draw. Dr. Aizaz Man, Samijay Khan, and Professor Zahid Nabi Saab. This lucky draw is for 3 lucky winners who are available in this hall and they have registered themselves. Lucky draws are for 3 winners. The first winner will get the prize of 100,000 K. 100,000. 100,000. 1 lakh. Second, 1 lakh, and the winner for 1 lakh is
from Lahore, Dr. Amir Khan.
I would like to request Syed Umair Maroof Saab from CCL and the Mahmood Saab from CCL, please come on the stage.
Dr. Amir Khan Babar.
Dr. Amir Khan Babar from Lahore.
Dr. Amir Khan Babar.
Lahore, Gulbarg 3. If he is not available, then he would not be eligible for this winning gift.
Okay. No.
So, because Amir Babar is not available here, then let's see who is the next lucky for first winning prize.
Dr. Wakasur Rahman, PMDC 24267.
Dr. Wakas is really lucky because the first winner is not available here. So, sir, you are double time lucky.
Who's next?
Winner for second prize is Dr. Noshin from KRL, and she is getting a smartwatch of amount 50,000. Worth 50,000.
Good.
Congratulations to the winner first and second. Now the third winner is Dr. Humayun from KRL. Again, Dr. Humayun from KRL. KRL is Dr. Humayun is again won the prize of smartwatch worth 50,000. So now, sir, I would like to say it's CCL show and the KRL show again. Thank you so much.
So now it's time for tea break, and after tea break we will resume shortly with the session. 10 minutes of tea break, please be back. And there will be 4 lucky draws at the end of the session. So please come back soon.
बोल रहा है तो तुम उतर जाओ। आज तक किसी ने मेरे को उतारा है? कभी स्टेज के ऊपर हम नहीं उतरे। हम कभी आज तक स्टेज से उतरे? जब हमारी मर्जी आएगी अब बोल रहा है कि उतरे, अबे कैसे उतरता? हम जो बोलेंगे वो होगा। हम इस मीटिंग के आसिफ मुनीर, समझ गए रूटीन? हम इस मीटिंग के आसिफ मुनीर, जो हम डंडा मारेंगे वही होगा, सब बच जाता है। हम आपको उसको तो पीछे वाले उठा सकते, आर्मी वाले।
One,
गाइड को भेज दे, पता चले कि कैसे स्टेज पे उतारता है।
Sir, in 2019 PSM, I won second prize on oral presentation. आपसे बड़ी डिस्कशन हुई थी, बिकॉज आप कहते ये नो दिस इज सेलुलर रिजेक्शन, दिस इज नॉट AMR. इट वाज अ लॉन्ग डिस्कशन में आप
वो तो SIUT में हुआ।
नहीं सर, इट वाज इन लाहौर सर 2019 अलोंग दैट। उसके बाद 2 और हो चुके हैं।
एक आपके पिछले वाला तो कराची में, लाहौर में आया था।
जिससे मैं लाहौर में, आप आए थे
तुमको भूल गए लग रहा है
सर। मैं नहीं भूला आपको।
तुमने नहीं भूला, हम भूल गए आपको, क्योंकि तुम इतने शहजादे हो, हमारे दिमाग में खराब हो। कहाँ पे काम कर रहे हो
सर? मैं नेस्कॉम में हूँ सर। सर ये जिस तरह केरल, इसी तरह नेस्कॉम, ये SPD की ऑर्गेनाइजेशन है
इंशाल्लाह।
सर वहाँ एज ए कंसल्टेंट नेफ्रोलॉजिस्ट हूँ और अभी रिसेंटली सिलेक्ट हुआ है एज असिस्टेंट प्रोफेसर पाकिस्तान इंस्टीट्यूट ऑफ मेडिकल साइंस। सर सुना था कि रेटिनल सेंट्रल रेटिनल वेन इंक्लूजन, मैंने भी उधर देखा, ज्वाइन नहीं किया कि मैंने
वो तो उसने समझी है, वो मरने वाला तो है नहीं, इसके अगेंस्ट तो कैसे केस मिल गए, फोटो को तो चाली मार दिया जब भी शर्ट नहीं आती हाई कोर्ट की जिसकी जल्दी वो क्या बोलते थे, जिसकी लाठी उसकी बहस। दिस इज द ट्रू डेफिनेशन ऑफ व्हाट गोइंग ऑन।
सर आपकी एक बात जो बहुत ज़बरदस्त, मैं खुद इसका हूँ, मैं आई वर्क ऑन 2021 अप्रैल 2025 PhD। गवर्नमेंट में तो दिन से काम ही नहीं करना चाहता, कोई मरीज ही नहीं देखना चाहता। हम सब ये नहीं सोचते कि ये लिख रहा है। सर आपकी भी बात सर, लेकिन कहाँ से लाएंगे ये डॉक्टर दिन के दिन?
They don't realize the worst thing is Namaste, Gari they come running to London for the thing. In their rule, they haven't built a hospital where they can trust and go and get it. इसकी आई अपलोड हो गई है, लेकिन ये कभी नहीं बोलेगा मैं तो लंदन में गया। ये वो तो अभी का अड़ियल है, उसमें तो कंप्रोमाइज तो करना नहीं। और इनकी सिर्फ फट रही है, इसको तोड़ने की कोशिश कर रहे हैं, वो इतना और मजबूत है। अंधे revolution always has bloodshed in the world. And I don't think the Pakistani population has gotten to that death mode. Even Bangladesh no खा दिया, Sri Lankan no खा दिया, Nepal no खा दिया। You have to give something. Nothing without something. हमारी कॉम्प्रोमाइज
सेम पूछ रही हूँ।
इसी में कहना कि वो शोले में जब नाम बोलता है जो डर गया मेरे को सिर्फ एक सब वो अमिताभ के लेक्चर वो सब याद रखते हैं मेरे को सिर्फ एक याद है अमिताभ गुंडा था वो अपने दूसरे गुंडों को बोलता है माँ खा के आ गया डर गया सब करोगे सब बात भी नहीं तुम्हारे जर्नलिस्ट दिखेंगे तुम्हारे लॉयर्स दिखेंगे जजेस दिखेंगे तो वो डरते से बोले देखिए एक लाइफ बैग है वो आपको अभी दे दिया जब तुम्हारे ने इसके बाद वो आया
जिनकी सिस्टर ने डिजीज डोनर में वो किया
मैंने तो तेरे को इसलिए ट्रेन किया तो आपको बोलता है सर आपने पैकेज नहीं देखी वायलिन बजा रहे थे जैसे हमको पता है हम नीचे जाएंगे लेकिन हम वायलिन बजा
Assalamu alaikum. Please be seated so that we can start the session. Developing renal services in Pakistan. This session addresses workforce development, surface expansion, and suitable renal care models. May I invite the session leadership, Chair Professor Rubina Naqvi. Ma'am, please come on the stage. And the co-chairs include Dr. Tasnuma Sara Khanam, Professor Aranga Vijay Vikrama, Professor Sajid Abbasi, Professor Sohail Iqbal. Sir, please come onto the stage. Conservative renal care is an essential patient-centered approach for individuals with advanced chronic kidney disease. This session will address why it matters and how it is delivered, and why it should be integrated into routine nephrology practice. Professor Katie Richards is invited to speak on conservative renal care, why, how, and why we should. Professor Katie is Senior Consultant Nephrologist and Medical Director at the Barts Health NHS Trust, London, UK. Ma'am, please come onto the stage.
Thank you very much for inviting me to speak today. I was very excited to have the opportunity to come to Pakistan, so thank you for that. I'm going to talk today about supportive or conservative care and how it might fit into the setting that you have in Pakistan. And you'll have to forgive me because I'm not so familiar with the situation here, but I hope that we can learn something together. So the first thing to say is that, oh, what happened there? Sorry, it's gone. Sorry, yeah. The no dialysis option is not a no treatment option. Patients can choose not to have dialysis, but they would need the right support to make that kind of decision, what we would call shared decision making. In order to help our patients make that kind of decision, we need to have the right information at our fingertips. So what does this mean where resources might be limited, where there is not dialysis for everybody who needs it? I'm talking about a situation where dialysis is available for everyone, but should everyone have dialysis? So how did this come about? This is data from America. You can see that after the initiation of hemodialysis as a treatment for kidney failure, there was an exponential increase in older people going on to dialysis. Rather interestingly, the level of younger people has stayed very much the same. It was quickly realized that some patients would not benefit from going on dialysis and that their mortality might be worsened, in fact, and certainly their quality of life might have a significant impact. So people began looking into other options for these patients. And you can see here around about 2010, the number of older patients going on to the renal replacement therapy programs starts to fall. And this is American data, and I suspect the UK is very much the same. So in around about that time, it became an acceptable treatment for kidney failure, that is to say, the no dialysis option. So what about the rest of the world? So this graph shows us from the Lancet in 2015, roughly the world's prevalence of renal replacement therapy on the left-hand side. And on the right-hand side, you can see that high-income countries, this is the higher, upper, lower, middle, low, describes the countries, that is about 2/3 of the patients are on renal replacement therapy. But I don't think this really means that we have an excess of patients who require kidney failure treatment in the high-income countries. So what about Pakistan? I thought I should have a little look into the data and use the kidney atlas from the ISN. The prevalence of kidney failure, according to this, there is no data available to the ISN, so we're not sure what's the size of the problem that we might be dealing with. Yes, dialysis is available in Pakistan, hemodialysis, and we have discussed that earlier and yesterday. What is the funding mechanism? Well, Pakistan, you can see, and you know very well, is the mixed funding system. So some is available for free, and some is in private, and some will be in charitable sectors, as you will know better than I. Is there a national strategy for chronic kidney disease in Pakistan? It doesn't look like there is. But there is a registry for dialysis patients, so there is some potential there. What about conservative care, which is hopefully what I'm going to talk about? Actually, you're not alone. There are very few countries, including the UK, who don't have a registry. That's not to say they don't have the service, but they don't have the registry. So this is a slide from the London Kidney Network to try and describe a little bit to others in healthcare, providing healthcare to our patients, what might be the sort of patient who may not do well on dialysis. It kind of helps us, which something I didn't understand until I really prepared for this talk, was the difference between conservative care, which is the non-dialysis option, and supportive care, which can be patients on dialysis, but where the focus is on quality of life rather than meeting the certain parameters and standards that we're expected to. This infographic I thought was quite useful because what I haven't really mentioned is the choice-restricted patients and how they might fit into this. So you can see that where conservative care, the modalities are in the green, so we have conservative care, transplantation, dialysis, but you can see that supportive care becomes, kidney supportive care is an active part of all of these modalities, but primarily amongst conservative care patients. So there's a slight trickiness in the definition here, and I think that we use them interchangeably, but actually they mean different things. So I'd like to talk about a case history just to demonstrate our experience in this. This is a 73-year-old Caucasian lady, and her GP dutifully started her on an ACE inhibitor for her hypertension and her chronic kidney disease in 2007. She had a not insignificant past medical history, but not dramatically comorbid, with previously treated endometrial carcinoma and hypertension. The GP diligently checked the creatinine after initiating the ACE inhibitor and found the creatinine to be 500 with an equivalent eGFR of 6, much to his surprise. And she was referred to the kidney unit in the Royal London Hospital, and myeloma was diagnosed. She progressed to treatment, her calcium was optimized, her blood pressure was optimized, and she was referred to our low clearance services and opted for hemodialysis as a modality, noting that she probably couldn't have PD because of her previous brachytherapy and radiotherapy. And her myeloma responded nicely to the treatment. About a year later, the patient came to us and said that she would like conservative care. She was no longer interested in dialysis. Her creatinine had improved to 350. We revisited this in 2010 to make sure that she was still for the conservative care decision, and she said absolutely yes. I'll tell you a little bit about what we did. The input was 2 monthly appointments with the supportive care team, our specialist nurse. She had regular dietetic reviews, she had home physiotherapy, she had her anemia treated, and her care was optimized. So you can see that the no dialysis is not the no treatment option. She continued under the hematologist where she had active treatment, and they offered her further bouts of chemotherapy. The symptoms she had were pruritus, pain, gout, and insomnia, but her gains were that she was very well. She had holidays with her family, and she peacefully died at home, which was her wish. So we have 10 years with a patient with a survival with an eGFR of 7 or less. She died at her preferred place of death. She had a supportive family and a proactive family. What do you think this lady's survival on dialysis might have been if we'd put her on dialysis earlier on? What did this patient know that we didn't know when we counselled her in the clinic? This is a plot of her GFR over the 10 years, and you can see with the right sort of input, the right sort of family support, she was able to maintain a reasonable GFR, partly that possibly due to the pathology she had, but she had 10 years of, I would say, good quality of life. Carers are a significant role if we're going to go down this route of supportive or conservative care, and I asked our specialist nurse about her comments. It is quite intense in that the family will contact, but the gains made are quite extraordinary, as you can see. They had to be particularly strict with her diet. The nurse was very happy to tell me that she just died in her preferred place of death, which was at home. Supportive care, as I illustrated, was a slightly different scenario, and this is a PD patient. So if a PD patient is failing or becoming more frail on dialysis, they may want to talk about having supportive care, where the focus is on quality of care, quality of life, not on dialysis. And they also can adjust the dialysis regime. It's not fixed, they're not meeting any specific parameters. So what did this patient, Jean, I know her well, know that we didn't know? Had she been reading the literature? Had she done her ChatGPT research? Observational data suggests that if somebody spends more than their 50% of their waking hours in a chair, they're not likely to do well on dialysis. If they're over 75 with significant comorbidity, or if they're over 80. But in our patient's case, you have to remember that every patient is not necessarily the average. The data which support this one is from 2007 from NDT. It's very difficult to get data around controlled trials in this sort of area, so most of it is observational and most of it is retrospective. But this group quite nicely demonstrated that if you were over 75, you still might gain from being on dialysis, but if you were over 75 with comorbidity, you're not likely to. So that was our first statement. That was what the first paper our patient must have read. The second paper is actually from the UK, from a palliative care team, and they looked at the impact purely of age. And you can see that if you're less than 80, you might gain some survival advantage from dialysis, that if you're over 80, that's very unlikely, even without significant comorbidity. This is also from that same group from Leeds. The World Health Organization classification of that you are likely to spend more than 50% of your waking hours in a chair is categorized as 3+, and you can see that you're not likely to gain much survival advantage if that is your classification on your baseline functionality. So I think these three pieces of information are really quite useful when thinking about the first slide and how we're going to counsel our patient and how we're going to give them the best background information on which to make their decision. So what's the cost for the patient? We've told them what the survival advantage might be. This is quite nice. I think this followed residents of a nursing home in America who were put on dialysis, and you can see that their functional status drops off pretty quickly, and by the time you get to 12 months, there's very few of this group had adequate functional status, and a significant number died and lost their functional status. So this is a big price for our patients to pay. This study, I think maybe you've seen before, which was also a retrospective study, but it shows that the survival advantage of some patients who opt for supportive or conservative care over dialysis, any survival advantage, any time that gives you, is likely to be spent in the hospital, either with a complication or on dialysis, and you're more likely to die in the hospital than you are at home. So this is the price that the patient may pay. I thought maybe I would look at our own data to see how we are doing. So this is real data from Barts Health from the last 5 years, and you can see that our average survival in the supportive or the conservative care scenario is just under a year. There's obviously a huge range, and I don't think our patient is part of that because I think she might have died before I collected this data. But where do the patients come from to our supportive care or make the decision not to have dialysis? They come mostly from our low clearance services, which I think is the right place. Where do they go to? So the pie chart on the left, they go to the right place in the main, that they die, and some of them may change their minds, which is perfectly fine, and some of them may choose to go into other services, or other things will happen to them. We're quite proud of this. What patients would like to know a lot is where they're going to die. They desperately do not want to die in the hospital. This is an audit from our department. It's a little bit old, 2020 to 2021, and we were a little bit disappointed by this because the supportive care patients, half of them were dying in the hospital. But if you remember what happened in 2020, if you pull out the ones who died from infection or COVID, you can see that the ones who died from kidney failure or withdrawal from dialysis were a much higher percentage. So I think our team are pretty proud of this data. I asked them what the challenges might be. I don't face these patients every day, but they do, and they have the relentless phone calls. They say that there's a lot of polypharmacy, a lot of polymorbid patients, and in their experience, they're more likely to die of something else. About 50% of them will die of something else. It's about communication between the tertiary centre and the primary care physician, because when you get into this territory, you rely on others to help you look after the patient. There's the geography to contend with. You don't want to be bringing patients up to the unit. And there's some change in family expectations, reassurance and support. You may come across a family who can't agree. The patient can't necessarily express their own opinion because of the language barrier. And you can get into muddles unless you have the whole family on board and the patient on board in the correct language. So an important part of this is people's attitudes towards patients on this supportive or conservative care pathway. And this paper looked at professional attitudes towards this. And they came up with this fact that we're very aware and very familiar with how we manage other kinds of patients who are going to palliative care, but we're not that familiar with this active treatment but not having dialysis. Carers play an important role in our department. We looked at the role of carers, and it became clear that this is very difficult unless you have adequate carers, good carers on board who are invested in the patient. So what are the resources? So as I said, it's a mixture of primary care, secondary care.
Ma'am,
so,
4 minutes remaining. 4 minutes remaining.
Thank you. There's a lot of online availability of how to manage this, and it can be done in a regional way. This is the London Kidney Network. They produce excellent flowcharts for how you might want to manage your patient. Please ask for help from other people. This is not palliative care. We are actively managing other problems. So falls, memories, clinics, and generally other specialists can help maintain that patient's quality of life. I thought I might look a little bit about where maybe in lower income or middle income countries, what might be the perspective, whether it's choice restricted. This was quite interesting, and this looked at North Africa and the Middle East and their experience of conservative care. So 51% of the countries of the respondents, experienced inability to offer dialysis. And interestingly, that was both in high resource and high income and low income countries. As you can see, the numbers go down until we reach 6% had formal training, which I think is not really acceptable. They talked about the various barriers they may have, and finances was a significant one, but also was education. So I looked again at this other paper, which is a global access, not just North Africa and the Middle East, and I was quite reassured to find that conservative care management is available in many countries for both choice-restricted and shared decision-making patients. The ISS, International Society of Nephrology, picked up on this and are trying to improve the education in some of these other countries where it's both choice-restricted or shared decision-making, and there are a lot of resources online. So, in summary, it shouldn't matter where you live or what your experiences are. You have one life, and you should be able to live it well, and there should not be any unnecessary suffering from kidney failure from the symptoms or the lack of treatment. But I hope I've convinced you that conservative care is an acceptable treatment and a good treatment for some of our patients. Thank you.
Thank you, ma'am, for clearly outlining the principles and practical application of conservative renal care. Now, coming towards our next talk, this talk will highlight capacity building and procedural nephrology in Pakistan. For this, I would like to invite Professor Saeed Ahmed. Professor Saeed has come a long way from UK. He is working as consultant interventional nephrologist and medical physician in Sunderland. Sir, please come on the stage.
Okay, thank you very much. Thank you very much for the invite. I'm really pleased to be here. So Sunderland is a small city in the UK. It's not London and it's not Edinburgh. It's just below the River Tyne, if you don't know. And I'm really pleased to present our work. Now, this work is more of a journey. It's a personal journey of trial and tribulations, tears and good moments and highlights. And it ends up in this country when it started in a different country. So let's take this journey. I have no disclosures pertaining to this topic. So, in the UK, where the journey started, we feel this as nephrologists all the time, a complex web, and I don't want you to look at the web itself, but vascular access, the Achilles heel of our patients' dialysis options, and we have a multidisciplinary approach, but it's usually disjointed, silo thinking, and very much related to tariff and the way it works. So this is the situation in my unit, probably 2007, and definitely before 2016. And the different modalities, you know, surgeons, ourselves as nephrologists and radiologists were all involved. And we thought we would make a paradigm shift. You went around the UK, you heard the same story, patients waiting on wards, waiting for procedures over weekends, and having temporary access. So we didn't want to do that. So we changed and remodeled it, and we put a lot more green in. So as a director, I like to take control of the patient's journey. And when the patient's journey is controlled by yourself, you can make change. When you rely on others, you are either begging for services or you're getting good favors from people because of your relationships just to get one patient through the system. And that cannot be a way to work. You need a process which is equitable to everyone. So we made it more green. So as nephrologists, we came out of our silo and took over other skills that other specialties were doing. In a way, in a collaborative way, not to upset anybody. So we learned ultrasound, we learned vein mapping, we learned how to teach, we learned how to enthusiasm in our programs. So we changed, we went to green. But that green took almost a decade. So our mantra is, nephrologists form the core of unified care. We have one thing for our patients, continuity of care is so important. As the previous speaker said, if you have disjointed care, you cannot provide continuity. In the UK at the time, 20% of our inpatient beds were taken over by vascular access. And we are well positioned to learn new skills. We need to move out of our curriculum, which is really quite tight. So this was our mantra. And then we went on forward and went on a journey. You come to conferences. All of you have come to a conference. You will be inspired for about 2 days. And then you'll go back to what we call the grind, to your work, and you'll think, maybe I should make the change. But actually, because you're on your own, you will not make that change. I always inspire people, when you go to conferences, take a team with you. Because you'll go back, and one will be inspired, the other one will have a bad day, and then actually they'll be inspired again and push you through. So I said, and I'm the one in the middle with the long hair, okay, just to remember that. So I took my team, and most important in that team, I took no other consultant, because many consultants have fixed ideas. I wanted a team with no fixed ideas, a new neural network, as I call it. So I took a registrar, I took a nurse, and a medical student. And their journey with me, you'll see next. So we took a journey to America, and we came back, and that's 2016. So it doesn't do justice, because it's 10 years on one slide of your life, on one slide. And you go, this is not fair, but it is. So you develop a team. So you come along, again, I'm the tall one. If you don't recognize me, I'm the tallest one in all these pictures, okay? So nurse, registrar, not a consultant. He went back in 2018, this is Dr. Clark, went back to Tom Vesely, Steve Banda in St. Louis, learned some skills. And guess what? Free of charge. Fellowships in America are very expensive, many thousands of dollars. But if you have the gift of talking and making relationships, free of charge. He paid his own way. He came back, taught us a few things. I got team members. I nicked a doctor from Professor Mugdi. He hasn't forgiven me yet. But I nicked a doctor called Shalab, brought him into the team, and the team has grown over those years. Slowly but surely we've grown, and we brought a lot of elements. We brought Pakistanis along. You'll see here in this team, we have my first fellow here, Haroon, from Lahore. And we brought other team members along. And then we're into 2024, and we've got new team members. And I'm very much of succession planning. The day I took a job, I'm thinking of who's going to take my job. I'm not in here to stay. I want to stay in this position forever. So this is how much forward planning we've done. This is one of my new colleagues. And those who are astute enough, who've got good eyesight, can see she's got a little bump. She's pregnant. That's the next nephrologist in our department. Already we're thinking about that. So we're here, and I'm trying to entice people to come, these new generation, this one here, because the best generation has already gone past. The post-war generation. These are the brilliant, the giants that we stand on. But these guys on TikTok, we're trying to make them do what we did. We're trying to move them away from those social media. So we're looking for new heroes, really. So we move on. And I really want to thank PSN. 2019 gave me an opportunity, gave me a break, because we were not getting this break where we were in the UK. We had the ideas, but we didn't have a platform. They gave us a platform. I came to this country, and by some miracle, we brought a few people together. But what I did, we did some procedures in Sheikh Zayed Hospital. It's the foreign dignitary sort of power which normally local people couldn't do, but I said, give me your theatre. And they said, you can have it at 7 o'clock in the morning on that day before the cardiologists come in. I said, that's fine. So we went to Sheikh Zayed, we went to the ward, found a patient, and said, why is this patient still on a neckline? They go, the fistula doesn't work. I said, are you sure? So I scanned the fistula, had a stenosis. I said, bring him to the cath lab tomorrow morning, 7 a.m. And they allowed me to do that. And we showed them that within what resources they have, they had more than I have. That was the fistulogram, done by a nephrologist, plastered it. We took the neckline out and she went on to dialysis. That's the neckline that I placed. We did an angioplasty. That's another neckline with a fibrin sheath. I don't want to dwell on the technicalities, but you cannot say you don't have the resource. You do, because I did it here for you, in front of you. I'm sure that it could be done. Now, sure, I had, the respect of a foreign dignitary. You may not have those barriers that I produce, but it shows that we can overcome. So we overcome those barriers. And then we did a workshop in 2019 in the Lahore PSN, and that was actually my first workshop. So we take from UK, which we couldn't do, we came to Pakistan where we could do, and then we learned and take it back. So workshops is what I do. I've done quite a few around the world. This is one. This is my very first one. I made a lot of mistakes, but I did a lot of learning. So I got a lot of learning out of it, actually, fistuloplasty and so on and so forth. And POCUS is what we come back to. We published. All is published. We published it in any journal, just said we could do it, so that was published. But this is the idea that came to me on the plane back from Pakistan. So we start looking at all the structures. So just for the audience, in the UK, to be a nephrologist, right now, in the curriculum, you just have to pass a temporary line, and that's it. You can be passed off in something called ARCP, and you can become a nephrologist. However, when you get to the ward, somebody's got to do all these for you. And if you can't do it in your team, then you're relying on radiology. And radiology, hopefully there's no radiologists in the audience, are notoriously very busy. They don't answer their emails. They make you do something called begging. And you send your junior doctor to their room, and they live in dark spaces, so they have to wait outside that dark space for a while until you get your patient through. And that's not process. That's just reflection of busyness. So we thought, well, we should do some of these, and we do, as nephrologists, but we do it in staging. So I've been around the UK and looked at all the places that are doing these procedures and qualified them and say, what kind of stage of procedures are you doing? I also look at the nursing provision on that side. And SDIN stands for Sundaram Diagnostic Intervention Nephrology. So that's when it was born as a conceptual idea. And we've just pushed this on all the way through. So, but it didn't happen overnight. It took time. Just like here. This is training in many countries many years ago. It's much better in this country now. All the grey-haired people learning and the odd female there. We're moving on from the stethoscope to the ultrasound machine, and pocket machines are coming. So it's going to take time. So I didn't run around finding new jobs. I stayed in one place for a long time to make the change. And then a break came in 2022. We launched UK Diagnostic Intervention Nephrology at the conference, and these are the first people, and it was multidisciplinary nurses, patients, myself, and I'm the oldest one in the picture. So we've got lots of bright faces in there. And that was our first launch, and this is our sort of mission statement. You don't need to read it, but we want to put access first, put the team first, put the team together. So when we did that, we moved on. And we did our first, actually, workshop in Birmingham. So the Pakistanis taught the UK people how to do a workshop. So you should be proud of that. It should be letters, you know, I always relate it back to that, because I was not getting a break. They said, well, why do you want to do a workshop? This is not a paper. And then these lot heard of me. I got invited to go to Hong Kong, right? So I went to Hong Kong, we met there. I was, again, the tallest in the picture, right? As you can imagine, in Hong Kong. And there was a big audience. And we did a 2-day. I'm afraid the people in Hong Kong are super organized, as you can imagine. Everything ran on time, right? Anyway, the next thing was, we got accredited by the ISN. So ISN Interventional Nephrology here recognized us, which is down here, as an Interventional Nephrology Training Center. There's 17 of those in the world, and 2 of them in the UK. We're one of them. I'm very proud, reached BBC News. So we made the news because of the work we're doing, the volume of work we're doing, which means now I can take international fellows back into the system that was developed in this country. So all a web, everything's interrelated, everything's about relationships. So we're proud that we achieved this status. And if I map around the UK, we're blessed. We have the provisions, but we don't sometimes have the barriers that are stopping, and we do have a lot of silo thinking. So these are just mapping the IN centres, I believe, as the lead in the UK DIN. I go around the country. I've been teaching in all these places. And we've been, have a nice collaborative family. We have a great WhatsApp group. You put a question in the WhatsApp group, it'll get answered in 24 hours. Or we'll find somebody to support you, and it's been very supportive. Really, people having difficult times, we support them. And then we published again. So this is our first data from about 2019, showing that when you have a provision of an interventional nephrology unit, then you can produce better work, efficiency and timely procedures, and day case, and reduce your inpatient beds. So as a director, I was very happy with this, that we could reduce our number of inpatient beds. And these are all the collaborators, and mainly junior doctors that helped us do that. So how does that relate to these guys? So on the background, being of Pakistani origin, I always felt I need to bring something back, because in 2019 they gave me a lot. So we thought we'd do something back. So what did we do? Well, I created a program through the ISN Education Ambassador Program. So I was lucky enough that this sort of proposition, where I'll bring proper teaching, a curriculum, into learning one aspect of interventional nephrology called POCUS. So I sold this to the ISN. They agreed I could do lectures, MCQs, logbooks, and also do some didactic teaching, and then do an examination and quality evaluate it, all those kind of things we like to do in education theory. And we started our journey. First one in Lahore, done in Beria Hospital. I was the only sort of teacher. These are the local mentors, and this was the team. It was a hard job in 2024. We had a lot of candidates, so we had 27 candidates. This was their sort of feedback, pre and post, and we managed to pass 16 of them. So a very high bar for quality, right? Not nepotism, quality. So we had a high bar for that. And we had, a few of us became mentors. The idea was to create new mentors locally that could do the work after I leave. And we had quite a few delegates as well. And the PSN president was there, he was inaugurated, and I got another shield, by the way, right? So we went on and did same thing in Karachi. So the momentum was growing. People were getting jealous. Why have you got one and we haven't got one? So we did it in Karachi as well. Organization, a bit larger team this time. And this time we had 48 registered, 19 passed on the first go. There was the feedback, pre is in blue and the orange is the post. All positive, 33 delegates. The delegate angle was interesting to think about. People who went on the course were students. Delegates just came for the practical sessions. But they were good because they become students in the future. And some of those students became mentors, and some of those mentors are now running independent courses. So the journey continues. And so people got jealous, and we did one in here in KRL Hospital. The president obviously had to have his own course, so we did a course, and here we are. And obviously it was the most successful course, you know. So we had 62 registered. This time no delegates, because it was so popular, we didn't need to entice anymore. Self-publicizing, I'm a very good publicist. 62 registered, 36 students passed. I passed 24 on the first case. I kept the standard where it was, the MCQ, the logbook, and the mentor feedback, and the on-site examinations through the OSCEs. And we had the pre and post as well. Learning all that was great, but it takes a lot of effort to develop a new curriculum. So I didn't reinvent the wheel. I used ISN Web Academy for some of the tasters and the web data that existed. And I wanted really to confound everyone and say, look, it can be done in the UK, it can be done in other countries, and other curriculum do exist, but they're quite large and long-standing. So what we thought, Avatar, American Society of Nephrology, NEFSAPs from the journals, we should really have our own. So the next element to this was to develop something in the UK which is recognized. So we've got the postgraduate certification now in Newcastle University. Now these are for UK graduates. This is the first students back in 2022, and this is our curriculum. You don't need to read it, but it's a modular curriculum of 3 modules run over 2 years for full-time people. These people are in work full-time coming to this course. And this is our first student batch that we've taken on, and we've taken on about 5 students. And I'm really proud to say, as of this year, the first students have now qualified. So we've got 5 students, and this is Newcastle University. This is a famous ex-student called Martin Luther King. You might have heard of him. Okay? So the students have passed, and we're really proud of our first pioneer students on this course. But what's happening now, international people are coming onto those courses. So I've got Malaysians and people from Saudi Arabia attending these courses. We are endorsed by our society, UK Kidney Association, and UK, the Nurses Association. And the projects we do not have to be high fly. This is a student project from the same cohort. We have medical students with us already. This is a very simple project looking at micturition or blood in the urine after a kidney biopsy and grading it on a color chart. So when you send a patient home, they have that color chart and say it's grade 2 or grade 3 or grade 6. And if it's grade 8, you say, oh, you come back again. All right? So that was a very simple audit, and actually it got to the Royal College of Physicians and won first prize. Innovation. Virtual reality. Here's a PD catheter under virtual reality. Why did I do that? Well, I just wanted to do that, right? Sorry about that, just go back. Why did I do that? Just because it's innovation. You're allowed to do that. Keep teaching. So each time we come to do a course, courses are now occurring independently in Pakistan. So we started a tsunami effect. A lot of those mentors are doing their own course. So here's another one in Sheikh Zayed. This is the touch points that we've really marked around the world. So we've gone everywhere to look for great experiences. Not personally, I've traveled quite a bit. My other colleagues have traveled as well. But wherever we go, we teach, and we learn ourselves more than we teach, and we bring it back. So that everybody gains from it. So Hong Kong, China, Tanzania, Kenya, all the places we've been. And these are just, I'm going to give you a flavor. In this country, these are now independent point-of-care ultrasound courses in many institutes, from Sheikh Zayed to Indus Hospital, all running like themselves. And here's some more, Taba Institute, here's another one at Indus Hospital, and then even Pima got involved as well. And this is probably the premiere where we want to get to. This is Avatar. So one of my colleagues goes to India every year and teaches on that program. And I'm afraid they are the world leaders in teaching. So we're not ahead of the curve, we're somewhere in the middle. And we want to reach and bring this country up to that level over the next decade or so. And I do workshops, but this is the future, live workshops over screening, and you're putting necklines in, doing PD catheters live, in live cases. So something we can aspire to is not ready right now, but we could do something with it. African Society of Nephrology also invited me, so we did a workshop there. So I'm very interested in Africa, and that's probably going to be our next touch point to do that. Here, I want to show you something that a lot of you know about. This is a temporary vas cath tunneled. Those who put vas caths in will know what I mean. Those who don't, ask me later. So this is a tunneled vas cath, and all I want to show you, here it is, tunneled here. A lot of people in this part of the world who survive on temporary lines, and they just exchange. If you cannot afford a permanent line because it's too expensive, that's great. Here in Tunisia, they tunnel all their temporary lines. I'll say that again. They tunnel all their temporary lines. I learned that. I didn't believe it. I've asked the guy to publish this work. Obviously, he hasn't. So I will publish on his behalf. And that's the position because it's flexible enough to do so. All right? And I've just been to Kenya, and Kenya is just starting. That's why Professor Sakwala is really interested. We had a provision to go to Aga Khan Hospital, which is related to this country, and teach point-of-care ultrasound. And this is the Krakow, which we were there only last year, teaching interventional nephrology. Professor Tushar is one of our mentors, who are also known to many people in this room as well. So, ending it all, where are we now? Well, this is great. I love CKD epidemic, because that's more work for us. I don't want less work, I want more. Volume load is what makes you better, all right? This country has loads of volume. I am jealous of your volume. In the UK, we try to reduce our volume called primary care referral. We have all these systems to prevent people coming through, which is correct, because ethically that's the right thing to do. This is PKDIN, which is what we're starting now, and it's on the website as of an hour ago. This is lastminute.com. As of an hour ago, if you go to PSN website, there's a link to PKDIN, and we're just starting this journey. We're in what we call the thinking phase, in the neural net, as I mentioned. And we'll move on to this phase as well, competency, and then eventually we'll mature. Avatar is down here somewhere, many other systems are here. UK is still probably struggling those two systems. So you're not that far behind, and you should take pride in being able to establish. You could say Pakistan established the system in the UK, right? Other way around. So I want to give you that, and I want to end up this is my mantra. I want to leave you, and I want to say, I've learned that people will forget what I say all the time. People will forget what you did, but hopefully you'll not forget how I made you feel today. It's most important. Feeling is important. Thank you so much. Obviously, it's not a one-man team. This is all my team. These are all the collaborators. This is the whole Estin team that works in Sunderland. And please join the family. So if you want to join us, PKDIN or UKDIN, please join. Thank you so much.
Thank you, Dr. Saeed, for an insightful and forward-looking talk. The practical vision you shared is highly relevant for strengthening kidney care systems in our setting. Now, moving towards our next talk, early detection remains the most effective intervention in chronic kidney disease. I will invite Professor Shafiq Chima to speak on Kidney Early Evaluation Program. Sir, Professor Shafiq Chima is currently serving as Professor of Nephrology and Head of Nephrology Department at Allama Iqbal Medical College, Jinnah Hospital, Lahore. Sir, please come on the stage. Thank you, sir.
Assalamu alaikum. Thank you for the opportunity to be directly talking to such an esteemed group of experts who would basically help our passion how to start and sustain an early kidney evaluation program in Pakistan. Kidney early evaluation program to keep Pakistan healthy, to keep your kidneys healthy. So this would be the outline of my talk. It's basically why we want to do it and how we could do it and what is the way forward. So I'll spend like around 15 minutes running through the slide so that I could save 5 minutes at the end for a short video we made to elaborate the same topic. So as you all know, CKD affects millions of people, almost 10% of the world's population. And majority of them, they have no idea they have chronic kidney disease. And health expenditures, especially in the lower middle income countries, are significant. And the interesting part is it's asymptomatic disease, at least in the early stages, where it could be easily detected and in some cases reversed and cured. So the prevalence of chronic kidney disease worldwide is significant. And in Pakistan, according to this, it's shown like around 7 to 8% people have chronic kidney disease. But I'll show you real data from Pakistan in a little bit. We don't have prevalence of kidney failure, there is no data, but we know the incidence. Almost 100 patients per million every year develop ESRD, which makes it around 25,000 patients every year, new patient who had end-stage kidney disease. And it's a costly treatment. We spend $5,000 to $6,000 US as opposed to significant more money in the Western world, which is around $45,000 every year. And we spend very little, only 3.4% of our GDP is spent on the health care. So there is a limited funding for the kidney care. This is an older slide, but the current number of ESRD patients is around 5 million. And this is only the tip of the iceberg. This indicates these ESRD patients are less than 5% of the total prevalent chronic kidney disease patient, which varies from 10 to 20%. It was projected in US that by 2030, it would be up to 16%. But what they found few years later, that it was already at 15%. So it's rising rapidly. America has a lot of money, they could spend around $51 billion taking care of less than 1 million dialysis patients. They are trying to spend more on the preventive care. So the high risk factor, we all are aware that diabetes, hypertension are two drivers which basically makes most of the cases of chronic kidney disease. In my opinion, in Pakistan, there are other factors. For example, kidney stone disease, hepatitis. So the prevalence has to be a little bit higher. In my opinion, all Pakistanis are at a risk of kidney disease. Pakistan has the highest prevalence of diabetes. And we also have a significantly increased number of hypertensive, which are usually undiagnosed, untreated, poorly controlled. More than 1 billion people in the world have hypertension, 1 in 3. And more than 80% are in lower middle income countries. So this is one study. There are several studies, and basically smaller studies, cross-sectional studies, what they indicate the prevalence varies between 12 to 30% in Pakistan. We did a small study of our own by the name of Keep Lahore. Then COVID came, we were only able to enroll 254 patients. What we found, the prevalence in high-risk population was 24.4%. And obviously diabetics, hypertensive, people with family history, people who have ischemic heart disease, people who were using herbal medication, they had a significantly increased risk of kidney disease. So we had 1 in 4, at least based on a smaller cross-sectional study. And the other thing in Pakistan is, you present very late. 90% of our patients, or 95% present in stage 4 and 5, which makes it very difficult. So prevention is the key, but it's not an easy task. There are challenges, and this is where we need your input and your help. One, we spend very little on the healthcare. There is a burden of communicable diseases, a significant burden. Our health system is very weak, and there is no integration between different NCDs. And mostly we lack local data to present it to the policymaker. We need to show them this is how prevalent the disease is, but we have very small cross-sectional studies. But we could still make a case for early detection. We could tell them that CKD prevalence is very high, more than 35% in some highly prevalent areas. It's a cost-effective way to detect the kidney disease in early stages, because in our part of the world, millions die annually because of the lack of availability of dialysis. Most of the burden of this 850 million, almost 80%, is in the lower middle income countries. And the screening will shift the focus from the costly treatment to easily affordable treatment at early stages. The other benefit is when you are screening them at early stages, you are decreasing the cardiovascular mortality, cardiovascular morbidity. You are improving the survival, which is very significant. I did a calculation. We spent $6,000 for 1 year of dialysis or for kidney transplantation. So if we bargain correctly with the lab, you could do 3,600 screening tests with that kind of money, which is significant. In Nepal, there was a program in which they screened 20,000 people, and they found out that, there was a significant improvement. And currently, we understand the disease very well. We have a lot of newer therapies These therapies, other than just ACE inhibitor and ARB like a decade ago, not only decrease the risk of kidney disease, but also albuminuria, and indirectly decrease the cardiovascular mortality and morbidity. So we would get benefit not only in the domain of kidney disease, but also with hypertension, with diabetes, and with cardiovascular disease. This is a very interesting slide. At stage 3, there are like almost 6 million people, but nobody reaches stage 4, only less than 500,000. The reason behind is cardiovascular mortality. So if you screen them early, you optimize the treatment, you have a benefit that you could decrease the cardiovascular deaths as well. We always talk about return on the investment. In Australia, they develop an economic model to see if the early detection would benefit. So they had a cohort of around 400,000 patients, and if you screen them at early stages for 20 years, this investment according to that model would yield a benefit of $10 billion over the next 20 years. Almost $45 for every dollar spent on the screening. So how could we start a program like Kidney Early Evaluation Program in Pakistan and then sustain it? So we recently launched this program, and the idea behind is, one, what has been said before, to prevent the risk factors of chronic kidney disease like diabetes and hypertension. And then comes the secondary prevention. All these high-risk population, diabetes, hypertensive, people with family history of kidney disease, ischemic heart disease, they are screened at early stages. And obviously you will find out some people at the late stages, and those late stages would be offered these newer drugs so that there is a decreased progression of kidney disease. And the best model for that I have been studying is what has been proposed by ISN. It was published in Kidney International. According to that, you need to document the burden of CKD in your country, develop transparent partnership, define and justify which test you will be using, what is the at-risk population, what can you do locally differently, and then move forward. And then also try to see if you could collaborate your program with other NCDs so that there is extra benefit. So this is the test. Obviously, we all are aware of that estimated GFR and urine albumin creatinine ratio. But in our setup, we could look into other things also. We are doing a study in which we are seeing urine dipstick, a screening surveys, AI-based tool. Like if we could get anything even more economical than the screening test, that might be the way to go in Pakistan. You could all contribute into this kidney early evaluation program by spreading the awareness about kidney disease, by encouraging others to get screened, sharing leads and connections, and giving your time and money. Couple of months ago, we have launched this program, and I'm very happy to announce that we have been donated 10,000 screening tests already. So it's not difficult to do it, and we will be doing that in the next maybe a year or so, all the screening tests in the high-risk population. We could use different AI tools. We could make different labs as keep healthy screening sites. We could have students and internal medicine and physician as our task force. We could spread the awareness on social media. It's a very powerful tool. I have a channel in which I have 400,000 subscribers, and people are interested in listening to you as long as the message is clear. In the month of March, we could have pre-recorded screening messages, just like we have done during COVID time. Our policymakers need to be aware of this program. They could have primary, secondary, tertiary care sites as the screening site. We have taken care of all those pandemics like COVID and dengue. For dengue, we have bargained a very low rate for dengue CBC, like 100 rupees only. So we could bargain things like that with the help of a government. And we have a very excellent Sehat Sahulat program. If we request them to only allocate maybe 5% of that to the preventive care, that would be huge. Then we could actually screen anybody, anywhere without worrying about the cost. So in summary, CKD early detection must balance benefit, cost and opportunity cost. It requires a multi-sectoral collaboration and policy alignment. ISN framework offers adaptable evidence-based guidance, And our goal should be responsible use of healthcare resources to improve kidney health in Pakistan. We have launched this, Pakistan Kidney Foundation and Pakistan Society of Nephrology, and all of these organizations have been contributing. At the end, I have saved 5 minutes by kind of running through the slides. I have a short video which we have created for the awareness. In that video, you would see one person who is well educated, who was hypertensive for years. Since disease is asymptomatic, he has had no idea. So he found out late and he developed ESRD and he's on dialysis. Other person we screened through the KEEP early evaluation program in Lahore, and he has been diagnosed at early stages and he is doing great. So I would end my presentation after this 5-minute video. Can you please play the video? There has to be a tab.
दायमी बीमारी क्रॉनिक किडनी डिजीज या CKD का शिकार हैं। ये बीमारी साइलेंट किलर है, खामोशी से वार करके आपको गुर्दों की सेहत से महरूम कर देती है। पाकिस्तान में हर साल 25,000 लोगों के गुर्दे फेल हो जाते हैं। हर 4 में से एक शहरी CKD का शिकार है और 90% को इसका एहसास तक नहीं। हमारे यहाँ वसाइल महदूद हैं, तशखीस देर से होती है और इलाज पहुँच से बाहर।
आई एम डॉक्टर नईम, 68 years old, और मुझे काफ़ी अरसे से तकरीबन 35 या 40 years ब्लड प्रेशर था। उसकी मैंने केयर नहीं की प्रॉपर, उसकी मेडिकेशन नहीं ली, जिसने आहिस्ता आहिस्ता किडनीज़ को डैमेज किया। फिर मेरी किडनीज़ जब मैंने टेस्ट करवाया तो वो हाफ से ज़्यादा ख़राब हो चुकी थी, लेकिन उसके साथ साथ मुझे फ़िज़िकली कोई प्रॉब्लम नहीं थी, कोई उसकी इंडिकेशन नहीं थी कि मेरी किडनीज़ डैमेज हो रही हैं। फिर आहिस्ता आहिस्ता ये इस स्टेज पे पहुंच गई कि ये अब मुझे होमोडायलिसिस पे आना पड़ा। मैं मैसेज ज़रूर देना चाहूँगा सबको कि जिनको शुगर और ब्लड प्रेशर के इश्यूज़ हैं वो अपनी स्क्रीनिंग ज़रूर करवाएं।
पाकिस्तान में बहुत सारे लोग लेट प्रेजेंट करते हैं, यानी जब उनको पहली दफ़ा हम डायग्नोज करते हैं तो उनकी क्रिएटिनिन 6-7 पे होती है, उनको उस वक्त स्टेज 4 और 5 क्रॉनिक किडनी डिजीज़ हो चुकी होती है। इस वक्त जो भी इलाज है वो इतना इफ़ेक्टिव नहीं होता और उनके गुर्दे फेल हो जाते हैं। ये ऐसे नहीं होता कि उन्हें ये पहली दफ़ा पता चला है, उनको ब्लड प्रेशर या डायबिटीज़ बहुत अरसे से चल रही होती है, लेकिन उन्होंने कभी उसके टेस्ट ही नहीं करवाए होते, क्योंकि गुर्दे की बीमारी की अलामत कोई होती नहीं है। तो जब टेस्ट नहीं होते, बाय द टाइम दे गेट टू नो इट, उस वक्त तक देर हो चुकी होती है। मेरा तो ख्याल है कि क्रॉनिक किडनी डिजीज़ चूँकि खामोशी से वार करती है, तो ये एक ऐसा बहरान है जो हमारे घरों को, ख़ानदानों को और आने वाली नस्लों को तबाह कर रहा है।
मेरा नाम अज़हर है, मैं जना हॉस्पिटल में मुलाजिम हूँ। 3 साल पहले स्क्रीनिंग टेस्ट हुआ था वहाँ पे, तो मैंने भी अपना स्क्रीनिंग टेस्ट करवा लिया। स्क्रीनिंग टेस्ट में शुगर भी ज़्यादा ही थी और पेशाब में प्रोटीन भी ज़्यादा थी, जिसकी वजह से डॉक्टरों ने मेडिसिन इस्तेमाल करवाई। तो अब 3 साल गुजर गए, अल्हम्दुलिल्लाह शुगर भी बहुत अच्छी है और पेशाब में प्रोटीन भी कम हो गई है।
ये कोरोना टाइम पे हमने कीप लाहौर किडनी अर्ली इवैल्यूएशन प्रोग्राम लॉन्च किया जना हॉस्पिटल में। उसके लिए हमने लोगों को स्क्रीन किया, तो अज़हर वाज वन ऑफ देम। अज़हर को कुछ पता नहीं था कि इसको कोई मसला है कि नहीं। उसी स्क्रीनिंग में पता चला कि इसको तो डायबिटीज़ है और प्रोटीन यूरिया भी है, इसके यूरिन में बहुत ज़्यादा प्रोटीन आ रही है, इसकी HbA1c वाज अराउंड 8। इसको हमने फिर एंटी डायबिटिक मेडिकेशन शुरू कराई। अब बहुत सारी ऐसी दवाइयाँ हैं डायबिटीज़ की जो गुर्दों की भी हिफाजत करती हैं। वो दवाई शुरू करने से क्या हुआ, इसकी डायबिटीज़ तो बहुत अच्छी कंट्रोल हो गई, और साथ ही साथ चूँकि अर्ली स्टेज में था, प्रोटीन यूरिया भी बिल्कुल ख़त्म हो गया। अब ये 3 से 4 साल हो चुके हैं और इसके यूरिन में कोई प्रोटीन नहीं आ रही, इसकी क्रिएटिनिन नॉर्मल है, इसका GFR नॉर्मल है, इसकी शुगर बहुत अच्छी कंट्रोल्ड है। तो हम ऑलवेज़ रिकमेंड करते हैं अपने पेशेंट्स को जो हाई रिस्क हैं, जैसे जिनको डायबिटीज़ है या हाई ब्लड प्रेशर है या फैमिली हिस्ट्री है या उनकी एज मोर देन 60 है, वो अपना गुर्दों का अर्ली डिटेक्शन का स्क्रीनिंग का टेस्ट ज़रूर करवाएं। और ये टेस्ट बहुत सिंपल है। आप सिंपल एक ब्लड टेस्ट करेंगे क्रिएटिनिन चेक करने के लिए, जिससे आप GFR कैलकुलेट करेंगे, और दूसरा आप स्पॉट यूरिन फॉर एल्ब्यूमिन क्रिएटिनिन रेशो, उससे पता चलेगा कि आप अपने पेशाब में कोई एबनॉर्मल प्रोटीन तो नहीं लीक कर रहे, क्योंकि मेजॉरिटी डिजीज़ में ये अर्ली साइन होता है किडनी डिजीज़ का। अगर इसको आप इस वक्त पकड़ लेंगे तो जैसे वो कहते हैं प्रिवेंशन इज़ ऑलवेज बेटर देन क्योर, तो इसी वक्त यू कुड निप द इवल इन द बड, और उसको आप डिजीज़ को रिवर्स कर सकते हैं। अगर लेट स्टेज में पेशेंट प्रेजेंट करता है तो फिर आप उसको रिवर्स नहीं कर सकते।
मेरा नाम मोहम्मद यासीन है। मैं जनूबी पंजाब डेरा गाजी खान के रहने वाला हूँ। मुझे 10-12 साल से गुर्दों की बीमारी थी, फिर एंड में आके गुर्दे फेल हो गए हैं। फिर हमारा ऑपरेशन भी कोई नहीं कर रहा था। फिर हम इधर डॉक्टर शफीक साहब के पास आए हैं, फिर इन्होंने हमारा ऑपरेशन भी फ्री करवाया। जो ट्रांसप्लांट के बाद दवाई होती है वो बहुत ही महंगी होती है। पीकेएफ ने हमसे वायदा किया है कि वो भी हम सारी ज़िंदगी के लिए आपको फ्री में देंगे, जिसको खा के मैं अपने बच्चों के साथ अच्छी ज़िंदगी गुजार सकूंगा। मैं बहुत शुक्रगुजार हूँ पीकेएफ का, डॉक्टर शफीक चीमा साहब का।
ये जंग जो है अगेंस्ट क्रॉनिक किडनी डिजीज़, ये हम हारे नहीं हैं। हम इस जंग को जीत सकते हैं अगर गुर्दे की दायमी बीमारी की हम अर्ली डिटेक्शन कर लें। इसलिए हम लॉन्च कर रहे हैं किडनी अर्ली इवैल्यूएशन प्रोग्राम। इस प्रोग्राम के तहत आपकी अर्ली स्टेज में स्क्रीनिंग हो सकेगी। और ये जो प्रोजेक्ट है ये बेसिकली पाक किडनी फाउंडेशन इसको लॉन्च कर रही है, फर्स्ट टाइम इन पाकिस्तान। और इसके साथ साथ हमें पाकिस्तान सोसाइटी ऑफ नेफ्रोलॉजी, गौहर एजाज फाउंडेशन और बहुत सारी ऑर्गेनाइजेशन जो हैं इंक्लूडिंग पंजाब गवर्नमेंट एंड डिपार्टमेंट ऑफ हेल्थ हमें हेल्प करे, तो हम ये फाइट अगेंस्ट किडनी डिजीज़ जीत सकते हैं। बीमारी को अर्ली स्टेजेस में पकड़ के उसको रिवर्स कर सकते हैं और बहुत सारे लोगों के गुर्दे फेल होने से बचा सकते हैं।
पाक किडनी फाउंडेशन इस बीमारी का इब्तदाई स्टेज में तशखीस और इलाज करके अपने मुल्क और कौम के शहरियों को सेहत की दौलत से मालामाल करना चाहती है। सीकेडी के खिलाफ इस जंग में हमारा साथ दें, पाकिस्तान का साथ दें। कीप पाकिस्तान हेल्दी, कीप योर किडनीज हेल्दी।
Thank you very much. I apologize, it was in Urdu, so some of you might not have been able to understand it that well, but thank you very much.
Thank you, sir. Evidence is not an academic exercise. It is the foundation of safe practice. I respectfully invite Professor Khwaja Hamiduddin Mushtaba Qadri to speak on research and evidence-based practices. Sir, please come on stage.
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wa hlul uqdatam min lisani yafqahu qawli. The same dua which I recited yesterday, and it always helps in my experience in easing the burden of the task at hand, alhamdulillah. And so today's task is over the next few minutes to just try and under the theme of developing renal services in Pakistan, look at something about research and evidence-based practice, and just want to start off with what used to be a common theme in my times as a medical student, and it was about what are the causes of this, and who discovered that, and where was it found. And from there, the Flexnerian era started, earlier on in the States, but in Pakistan probably subsequently. And then we went on to how and why. And then we discovered with Sackett and Guyot's movement worldwide that it's not just how and why something works, but it's does it actually work or does it not work, which became the important theme. And then we discovered that even if it does work, some people can afford it and some people can't afford it. And so the thing became add the values and preferences to that particular thing. And then what about people in this part of the world where they say, Dr. Saab, aap hi hamara sab kuch hai, you are everything. So how do they make that decision? So Gordon Guyot, who has been a mentor to me for the last 2 decades, states that perhaps you should be the patient's best agent. Put yourself in the patient's shoes and try and think from their perspective what would be the ideal choice for them. From the cost economic benefit that you can come up with on that visit of that patient who may not show up again, what is the best impact you can make on that particular patient. So we are just going to see the need for transforming to evidence-informed nephrology also in Pakistan, and to highlight the challenges and opportunities in advocating for high-quality kidney research. So what we have seen today is that besides sketchy, excellent data, there's a lot of it is no data from Pakistan. And to share and learn from 2 decades of my particular love affair with evidence-based practice and clinical research, capacity building in Pakistan and elsewhere. So just starting off with what our stakeholders are demanding in the 21st century, the patients want values and preferences incorporated patient-centered care. And one of the best definitions of patient-centered care that I came across is being a guest in the life of your patient, not the other way around. And our nephrology peers are seeking graded and guideline-driven care, like KDIGO or anything else, or the European Society of Hypertension or ACC guidelines for hypertension, as we saw earlier on. The nurses also want integrated, evidence-informed pathways or protocols. Pharmacists want standardized, computerized process order entries and order sets. Nutritionists are obviously seeking, for lack of a better word, healthier outcomes through proven dietary interventions. Quality management wants auditable, standardized processes and tied in with measurable outcomes. Medical education is moving towards best evidence medical education, whether at the undergraduate, postgraduate, or continuing professional development level. And of course, policy makers, I would hope, would benefit from evidence-based policy formulation as a result of all these efforts and come up with something which makes sense in terms of budget allocation. And eventually the benefit needs to then be transmitted to society in terms of better outcomes and quality of life. So this particular evidence-based pyramid puts our good old expert opinion that is still practiced based on eminence in certain parts of Pakistan on a daily basis. And one of the things that I learned through Niels Bohr is that I also happen to be an expert. And if any one of the younger audiences can define Niels Bohr definition of being an expert, I have some money in my pocket, the last of it that's left from this month, that I'd like to hand it out to you. It's not 100,000 rupees, but it's something that might take you home from here to wherever you are. So who is an expert in Niels Bohr words? And you don't have to look up anything else. You can just open it up and Google Niels Bohr and see what he defined it. So an expert is someone who has made all the mistakes that can be made in a very narrow field over a prolonged period of time. So I've made all these mistakes that are there, and I don't want my students and residents and fellows and others that follow to make those mistakes. So there is that expert opinion, good old expert opinion, based on all the where, what, how, why, that's right at the bottom. But then there's a series of evidences that can be accumulated through observational designs and experimental studies, and then you can synthesize the evidence into meta-analysis. And we had a workshop yesterday, day before yesterday, out at one of our centers at part of the pre-conference workshop. And just like research and evidence-based medicine value in Pakistan, so we had 29 registrants for that workshop, and I wouldn't say how many participated in it. And we were told there were another 50 from some other specialties, and I wouldn't say how many showed up. But when I eventually counted, there were 8.5 people out there. 1.5 I realized was this very smart person. And then I realized, oh, he's going to be a co-facilitator subsequently. So that was all that showed up for that entire day. So in 20 minutes or 10 minutes, I'm not going to be able to convince you, but I hope something like this can, which I projected at the last PSN meeting, that when I looked up the state of renal research in Pakistan with certain search terms, we came up with predominantly, observational studies and descriptive studies, and very little on the higher level of evidence. And then if you look up at the same thing in 2026, again, you'll find publications are coming out from everywhere, and very few are higher quality evidence that is being generated. Even observational designs like retrospective cohorts are not too commonly found from our part of the world. So if we are not going to be doing research, and if you're not going to be critically appraising research, then we are going to get very easily misled by all that material that comes our way on a daily basis. Perhaps at this point in time, evidence is doubling worldwide in about, 25 days or so? That's what they say. And so if you are unable to sift through that and unable to use your appropriate search terms to combine your best clinical expertise with the best evidence, then how are you going to provide the best evidence-based healthcare for your patients? You're not going to be able to do that. So we need to move beyond descriptive studies to analytical studies and focus on some of these capacity building efforts and value them, because for some reasons shown subsequently, I'll tell you that these things actually have been noted to be the biggest barrier in terms of advancement of clinical research and high quality publications from the developing world is the capacity to do clinical research, capacity to do research of any kind or to ask a question. And we need to obviously incentivize that research in terms of protected research time and grants. So I'm just going to share some of my experience over the last 2 decades in certain parts of Pakistan, particularly mostly in Islamabad, I would say, that even I was first introduced to Gordon Guyatt in about, I guess, 2003, 2004, attended a couple of his workshops in the Middle East. Subsequently, I invited him to Pakistan, but before that, we played around with some of these simple things. We incorporated, I believe, Shaukat, you were there at that time at Shifa, and Dr. Bangash, who's the CEO of Qaid-e-Azam International Hospital. So we incorporated something like that at the point of care. And the quality of the morning report suddenly rose, and the consultants started feeling threatened by the evidence that was coming on site at that time. Similarly, we moved to EBM formatted morning reports, and lots of questions were raised on therapy, diagnosis, harm, etiology, and most of the questions were answered with some people using PubMed, UpToDate, and whatever primary and secondary sources were available. But it was just that it became a little more exciting for all the learners involved. Then, at a skills center that we had, we incorporated clinical skills along with medical informatics tools and EBM tools. And again, that rotation was rated, the highest on the EBM portion, and on that occasion. Another occasion, we conducted a workshop for faculty, and the ages were anywhere from 31 to 72. So I would say that, some of us sitting out here could still take part in some of these workshops. And a standardized, validated Berlin questionnaire showed a significant improvement between pre and post scores on a maximum of 15 when we included the preceptors and also when we excluded the facilitators. We also incorporated, when we switched from a traditional curriculum to a modular integrated curriculum at this College of Medicine, Shifa, where I used to be associated with, we incorporated evidence-based journal clubs within each modules and the renal modules and published that experience, and again, very well taken and accepted. We tried to see if for diagnostic reasoning we could create some paper cases, and for anything which had a high pre-test probability, normally the evidence-based practice suggests, based on Fagan's nomogram, if you're familiar with it, that you could potentially treat or maybe do just a few confirmatory tests or one confirmatory test, especially in resource-constrained countries. And it so turned out that the higher you were in the hierarchy of experience in Pakistan, the more tests one was likely to offer instead of, and the younger ones were more savvy, the Gen Z and the millennials that we had at that time. We incorporated EBM into our morbidity and mortality conferences and made it a daily habit by looking at literature, quoting literature, looking at the clinical practice guidelines, and actually benefited from these experiences. And I would suggest that we could do that in our fellowship programs for those things as well. We created some clinical pathways which had evidence-informed components and compared them in pragmatic trials with usual care. And although, and this is how we incorporated them into computerized process order entry, those clinical pathways. And although there was no statistical significance in terms of the length of stay, but there was a clinically improved significance in terms of improvement in length of stay. There's a movement in Pakistan from AKU and also out from the military in terms of a development of nephrology clinical practice guidelines contextualized for the Pakistani settings, and I think that needs to be supported. And then, so if we conclude part one, we need to all be, be mentored on these aspects, particularly therapy articles if we are practicing, number needed to treat, number needed to harm, cost-benefit analysis. All these things need to be understood by us in order to serve as patients' best agents. But then how about for research? Now, this particular article identified the capacity to do research as one of the main barriers for us to do that. So we need to be able to attend some of those sessions that we do. The PSN has been doing it through this research task force previous 2 years, and we went through all over Pakistan, ended up in Islamabad and came up with a pathway and put it together for you in PJKD as to how the way should be forward. After all that effort, we had a few proposals which came through, and which some of them probably underway, like the registry and other RCT from SIUT, but the rest of them just fizzled off. So we said, okay, let's just move to journal clubs, and we conducted at least 20-25 journal clubs on a monthly basis throughout Pakistan with the help of Dr. Shaukat Memon and Professor Salman Imtiaz, and obviously under this current executive committee. And all kinds of articles, newer ones, were looked at in terms of number needed to treat, number needed to harm, cost-benefit analysis, and how it works with our practice. So in general, what we have done over the last 2-3 years, we've done about 7 workshops. We have trained over 300 participants. We've conducted about 32 mentored journal clubs rotating throughout Pakistan. And, so we feel that this particular thing, the collaborative research proposal earlier on, I think that needs to be built upon. We need to incentivize our research, both in terms of assessment. One OSCE station was built in by the CPSP, which had some sample size calculation or something similar, I believe. And then, of course, this year there was a Professor Majdi Yaqub gold medal that was announced, and other cash prizes for the best research. And there was an effort to make it a very, above the board, peer-reviewed process. So the proposal for the new committee is, I've increased the research grant from the PSN Executive Committee's task from 10 million to 20 million, because I never got the 10 million last time also. So I said, just let me raise it up to 20 million. And if you give me another few minutes, I can raise it up to 30 million. Okay, so that's my wish list. The PSN research endowment funds need to be created. I would say announce some grants by the 1st of April, not to say make a fool out of people, but April 2nd perhaps. Deadlines for submission, give the final decision, involve the research committee, get your IRB approvals, get the National Bioethics Committee in, continue with your mentor journal clubs, have your annual workshops, raise the standard of your Pakistan Journal of Kidney Disease, try and hit the top journals, and work with your CROs, academia, perhaps industry, which is a necessary evil in my in my judgment. And in the end, I just want to thank you for your support and join this movement, because together we can. Thank you.
Thank you, sir. Thank you. Last talk of the day. ABO-incompatible kidney transplantation has emerged as a viable strategy to expand living donors. I will invite Professor Leonel Rostang and Dr. Naveed Sarwar to talk about developing ABO-incompatible transplant program in lower middle income countries. Sir, please come to the stage.
Assalamu alaikum. Good afternoon. First of all, I would like to thank Professor Nabi for the very kind invitation for me to attend this PSN meeting, and it's always a pleasure for me to come to Pakistan. And so I would make an overview about ABO incompatible transplantation and how it was implemented here in Pakistan through my mentee, Dr. Navid Sawar, and he will present you the data from what he did or what we did together. So nothing very specific. That is to say that when you are ABO incompatible, we have to fight against isoagglutinins that are around, and so therefore we have to get rid of them if we want to have a successful transplant. And this is doable even in a low middle income country like yours. And so these barriers, the isoagglutinins, are very important to get rid of because if they are still around, specifically IgMs the day of transplant, they might result in thrombotic microangiopathy or hyperacute rejection, which is not indeed desired. And therefore, to avoid that, we have to come with the titers the day of transplant below 1:4 if we want to be on the safe side. So how safe is ABO incompatible transplantation? So this was a paper published recently in KI reports from various French transplant groups. We were not part of them because we never came across with this TMA post-ABOI kidney transplant failures. And indeed, in this paper, they've shown that the higher the IgMs the day of transplant, the higher the likelihood of developing post-transplant TMA, and this TMA will result in graft failure in many cases. And so we have to avoid that, and we never came across with such cases, either in my center or in Navid's experience. So indeed, sometimes the titers are, to start with, are very high, and so therefore they might, it's not reasonable to come across, even though it's possible, it's doable, and we did that in my center and in other centers, it's doable. So I will skip that. So the rationale of having ABO incompatible transplantation, just to expand the donor pool, provided it's safe for the recipient. And indeed it's safe. So I will skip the history of, well, I can't come back, sorry. Yes, so the rebirth of ABO incompatible transplantation was done in Japan in the late 90s because tacrolimus in those days was available, and first of all they started with splenectomy to desensitize the patients with transplantation, and afterwards they replaced it by rituximab. And thanks to the courtesy of Professor Ikawa, a friend of mine who is in charge of the Japanese ABO incompatible kidney transplant registry, they found that the patient survival at 20 years as well as the graft survival is reasonable, and indeed the results are far much better since splenectomy has been replaced by rituximab. So isoagglutinins, indeed we have to get rid of them if we want to have a safe transplant. And so what we need first is to have a very good immunology lab on which you can rely on. And they can use either the test tube, which is very cheap, or the gel con, which is very easy also. And we have to separate out IgGs and IgM. And indeed, when we make this ABO incompatible transplantations, we have some rules to follow if we were to transfuse the patients with red blood cells or with plasma. So this is a large study from India demonstrating that, to start with, before any desensitization, very few patients have titers below 1:4. In their study, almost 1,800 patients, only 7% of patients had titers to start with very low. And so therefore, all the others would need desensitization before transplantation. And so to get rid of these isoagglutinins, we have to implement apheresis to remove the isoagglutinins and to have immunosuppression at the same time pre-transplant in order to prevent the rebound. So indeed, in Pakistan, the only apheresis technique that is available is plasmapheresis, and you remove the plasma and replace it by either fresh frozen plasma or albumin, but albumin is very expensive. Otherwise, we can use the FPP to treat more plasma volumes or specific immunoadsorption when the titers are very high, and there are some specific columns that would adsorb A or B antigens. So rituximab is always mandatory, so we need to have apheresis plus rituximab, and rituximab should be given well upfront the transplantation, because rituximab itself is able to decrease to some extent the isoglycine levels. And indeed, we start the other immunosuppressive drugs, tacrolimus, steroids, and MMF, 1 or 2 weeks pre-transplant. So rituximab is indeed necessary. This was a retrospective study from Australia, 2 periods of time, one without rituximab and one with, and they showed that all the catastrophes, ABMRs, TMAs, and graft loss occurred in those who have never had rituximab pre-transplant. And indeed, it's the same if you were to use, in this study, apheresis without, rituximab without apheresis, with low titers to start with. Indeed, in this situation, apheresis is also required in addition to rituximab. And so the rebound pre-transplant only occurs within the first days after the first apheresis session, but thereafter, after transplantation, there is no rebound except in those cases where the IgG titers pre-desensitization were very, very high, which is not the case here. And post-transplant, there is no rebound in most of the cases because of accommodation. This is an active status whereby the isoglycine is still there, that there is the kidney get accommodated to them. So to summarize, this is a protocol we have in my center. So we start the rituximab 1 month before, apheresis about 10 days before, and the goal is to have titers on the day of transplant below 1:4. And so in my experience in Grenoble, which is of more than 5 ABOI cases, we didn't lose any kidney from ABMR or from TMA. So if we look at the results from the registry data, from the CTS data, the results are comparable to ABO-compatible transplants. In Japan, there is no difference across the barrier, A or B. In the UK, it's very nice registry data demonstrating that ABO-incompatible kidney transplantation achieve the same result as altruistic donation or pair exchange. So it means that it's very, very safe. Indeed, because of apheresis that were used pre-transplant, the patients are depleted of clotting factors, factor 13 or fibrinogen, and therefore there is a risk of excessive bleeding during the surgery, and we have to be aware of that, and we have to replenish the patients with fresh frozen plasma before the transplant in order to avoid this complication. So in this study, it's shown that the intra-op bleeding is twice as much as compared to ABO-compatible, but this can be prevented by a fresh frozen plasma infused before transplant. And the post-transplant management does not rely on monitoring the isoglycines. It's pointless. Conversely, it's very important to monitor closely diuresis and serum creatinine. And as soon as there is a decrease in urine output or increase in serum creatinine after checking the patencies of artery, vein, and ureter, we have to implement apheresis in order to treat the patient. So rejections, well, there are cellular rejections, but the same rate as compared to ABO-compatible transplant, and the specificity is isoglycine-mediated rejection that has to be treated very quickly. Okay, and the last complication is the increased risk for having BK virus nephropathy. And so I duplicated my experience. I was the first one to start with in France with ABO-incompatible program, in Thailand, in Morocco, very soon in Libya, and in Pakistan. And my mentee, Dr. Navid, will present the results from what we achieved here. Navid?
Assalamu alaikum. Thank you very much. And I would like to thank the organizing committee, Professor Zahid Nabi and the team. And I'm the last one standing in between you and the gala dinner, so I will not take much of your time. So I will just quickly go through our experience, how we implemented this ABO incompatible transplant. At our center, briefly, we started in 2021. It took us 2 years to, patent the technique for the isoagglutinin titers monitoring, arranging for immunoabsorption, and doing the membrane plasmapheresis. Our cohort of patients, which includes 29 patients, 3 were the second transplants, and 2 of them were HLA incompatible plus ABO incompatible transplants, which were CDC positive. Alhamdulillah, at the end of 1 year, you can say that we have an GFR of more than 60% in 92% and a graft survival of 94%. Our work got recently accepted in the transplant proceedings in the process of publication. So inshallah ta'ala, in the next some session, we will be sharing the details. On average, the starting titers for our patients were about 1/64 for the IgGs, and the average threshold for desensitization was 1/64 for IgGs. And in the ABO incompatible transplant, the standard thing is like with 1 plasma volume, you target a decline of 1 log titer reduction. So if you have to bring 161/164 to 1/4, so you aim for 5 to 6 sessions. So just I have given you the data for the graft survival. So regarding complications, majority of the complications were from the surgical side. We have seen lymphocytes that persist for about 4 to 6 weeks. Wound dehiscence, prostatic abscesses in 2 of the patients, urinary infection, 1 patient required, that was a second transplant, post-transplant TURP was done, and the graft nephrectomy of the first graft nephrectomy for recurrent abscesses. For the medical complications, 2 patients had a post-transplant MI that was late in the course. Sepsis, we lost about 3 patients out of 29. And UTIs was quite frequent. And in the end, the purpose of sharing this model that we implemented is that I think so it's a very unique and an easy way, more feared of, to expand the donor pool and to curb the market of illegal transplants. Like, we haven't lost any graft because of ABM or TMA. Every graft was salvaged within a 1-year time period. So it's doable. You can replicate any center who wants to collaborate. We can help and we can manage. And inshallah ta'ala, this is the way forward. And we are looking forward, inshallah, that more centers will be joining us in ABO incompatible transplants. Thank you very much for your attention.
Great. Thank you, sir. Thank you. I would like to invite Sir Amir Azhar to come on stage for shield distribution to esteemed guests. Professor Katie Richards, ma'am, please come on stage. Professor Saeed. Professor Khwaja Hamiduddin Mujtaba Qadri. Professor Shafiq Chima. Professor Lionel Rostang. Dr. Naveed Sarwar. And the last, Dr. Raja Asif. So it's time for lucky draw. Everyone keep your badges ready. Sir, start. Start. Sir, Dr. Muhammad Sajid Rafiq Abbas. Dr. Athar Ali Haidari. Dr. Asra Elias. Sir, वो आगे से. The strength of conference lies not only in its speakers, but in the conversation it inspires. Thank you to all our mentors, chairs, speakers, industry partners, and participants for making today's program intellectually enriching. This concludes our day 3. We invite all delegates to join us for gala dinner at Tulip Marquee, and the vans will be available outside Sheesh Mahal Hall opposite registration counter at 8 p.m. Thank you.